change, obviously. 10 study. And then the question was, well, can we substitute that and make this very cumbersome inpatient regimen and outpatient regimen by changing the cisplatin to carboplatin and shortening that 24-hour paclitaxel infusion to 3 hours. And that's what was done in GOG 158 with nearly 800 patients, and was confirmed by the German group, the AGO, all showing either equivalence, if not superiority. And we actually showed superiority in GOG 158 with Bob Ozel's study. So it has been significant. This introduced, obviously, the taxane era back in 1986. And you say, well, we're coming up on 30 years of change. What else has happened? And well, we've done a lot of studies. We've spent a lot of money. And other than the PARPs, which, as I said, we'll talk about, I'll leave it to you to judge how much we've really changed the world from that standpoint. So if we look here, you can see the standard is still maximal cytoreduction. And I think that that's really important to stress. I got out of a case late. It's a little after midnight my time in Cincinnati. It's 12:40 or so here. And I just got out of a case at about 7 p.m. So I just got home 4 or 5 hours ago. But in that case, it looked very similar to this, where there was a large volume of disease, and we spent quite a bit of time going through and getting out all that cancer. And why? Because we do believe getting to R0 is very important. And we feel that confers a significant survival advantage with ovarian cancer, and our models continue to hold to this day. And while we have debated it here and there, I think that the bulk of thought leaders do believe that there's still a significant advantage to doing this. And then followed by that standard, I just talked about platinum and taxane, usually carboplatin and paclitaxel, and we could talk about some of the other things that are going on. So I'm going to talk in this period more about maintenance. We'll talk a little bit about where we are with dose dense, intraperitoneal chemotherapy, as well as HIPEC. And then, of course, the introduction of biologics such as PARPs, but also bevacizumab, which has played an important role as well. All right, so these are the intraperitoneal chemotherapy trials. And as I recall, the uptake's been so-so in Saudi Arabia or in the kingdom, and I think that that's been the case here in the United States. We've seen, even at the peak, only the highest that intraperitoneal chemotherapy incidence occurred was obviously pre-PARP, probably looking about 10 years ago or more now, and the uptake was only 12% in the United States at its peak. And so we really have never bought into this idea, even though we have 3 randomized phase 3 trials that have shown anywhere between a 20 and 30% increase. If you look in the blue columns there, as far as the increase in either progression-free survival that you see on the left side of the slide, or overall survival more towards the right. And that's comparing the IV, which is the intravenous, versus the IP, which is intraperitoneal. And I think that the peak of this was when Deb Armstrong's GOG 172 was reported. And I think there was a lot of excitement there because they thought, wow, look at that significant difference in overall survival, hazard ratio of 0.75, 17-month advantage in OS. And a little bit hard to understand that when Joan Walker, who's a true champion of IP as well, reported the GOG 252. And unfortunately, what they found was that the primary endpoint of this trial, and I need to update this because we do have the OS data now, but the primary endpoint of this trial was PFS. And there was no difference at all. And they've tried the Japanese way of doing this in terms of introducing carboplatin as well as the more traditional cisplatin. And they tried to modify it to make it more user-friendly for the patient and the physician. And maybe that modification played a role. They also allowed bevacizumab to be used, and that may have played a role. So it may be that if you're able to give bevacizumab, you're able to equal the outcome that you have with intraperitoneal chemotherapy without the hassles, if you will, of intraperitoneal chemotherapy. But I'll be happy to answer any questions on that when we get to the question period, because that's certainly a hypothesis. But it's very interesting to look at no significant difference in that. So for most people, then that's sent IP back spiraling into the single digits in terms of centers and individual physicians who actually utilized intraperitoneal chemotherapy. So we've seen that sort of drift away, if you will. That doesn't mean it was the right thing to do, and it doesn't mean that there's still were not remarkable outcomes that we've seen in some of these other studies. What has seemed to resurface is the Van Driel data out of the Netherlands. And this came out of nowhere. I think most people were surprised because it was a very small study. As you can see, only 245 patients randomized into 2 arms. So you're only looking at 120 some patients in each arm, which is usually not that many to show a significant difference. The only thing that, and you have to understand the setting here, it's in the neoadjuvant chemotherapy setting, meaning they did 3 cycles of chemo. Then they did their not the primary, but they did the debulking surgery at that point. So interval debulking surgery. It followed by what went on in the operating room, where they received no heated intraperitoneal chemotherapy, or they were randomized to heated intraperitoneal chemotherapy. And they gave a high dose of cisplatin at 100 milligrams per meter squared. And that's the only intervention they did. And then they finished out with intravenous chemotherapy with carboplatin and paclitaxel. It's the only intervention they did. Primary endpoint of this trial was progression-free survival. So if we look here, you can see the PFS that is listed here. And you can see a significant difference of a hazard ratio of 0.6 with nearly 4-month advantage, highly statistically significant. And so people were very excited about this data, and they became even more excited when the overall survival data reported. So you had not even a 4-month difference in PFS or recurrence-free survival, which is what they were measuring in this. And it goes all the way then to significant change there that you see of almost 12 months. So to almost a year's difference in median survival. So this is pretty remarkable, obviously, and people were very impressed with this. Good hazard ratio that did not overlap, but got very close to 1. Other people say, well, there were some problems with this. There was an imbalance in the amount of aggressive surgery. There were some other issues as well. Could this be a type 1 error with a very small study? Sure, perhaps, but we don't know. And it certainly made people wonder quite a bit. Now, there is toxicity associated with this. Interestingly, this study also did not have the toxicity that we see with most HIPEC studies. So was it the use of sodium thiosulfate for renal protection? What all went into this that these patients did much better? Again, a small study with a select group, may have been extremely healthy patients. We don't know what the difference was here. But if you look at most HIPEC studies, there is certainly greater toxicity than what we're seeing right here. So you have to keep that in mind. Doesn't mean that this isn't correct. It just means that you need to be aware that that's certainly the case. So I think that that's one thing that we need to continue to think about. So in the GOG, what we've done is create a new study, and we've labeled it the hot study. I don't know if that's appropriate or not, but the heated part of it, making it hot, if you understand that. A little Saturday morning humor in Riyadh for you. I think, though, that if you look here, 230 patients, so also a very small study, relatively. And then really trying to replicate that study, but with tighter boundaries around this. And we were lucky enough to receive support for this study with GSK. And so all these patients will receive niraparib as well, and we will look at the difference there. Now, the problem is that the maintenance being effective, such as niraparib, could be problematic as well because it might blind the difference. But we will try to look at some things coming right out of the HIPEC before the maintenance and so forth as well to see what the difference is. So I think it'll be a very interesting study. We are certifying sites to make sure that they're experts in HIPEC. So you can't just say, well, I want to start my HIPEC program and join the trial, and then of course have some poor outcomes initially because there's a learning curve. So we're qualifying all the sites. I'm actually the translational PI on this study, where we have some translational correlates as well. So we're excited about this. Do I think it's going to work? I don't know. I'm a little skeptical, but I think the Van Driel data is very compelling, and we absolutely need to test it, because if we are really getting an extra year there, it's worth using it. Now, would we use it in everyone? No, of course not. We'd probably be fairly selective in who we use it with. But I think that there is an opportunity there to extend survival. Dose dense, I'm going to go pretty quickly here. I think all of you are aware of this historical data that came from the Japanese GOG that looked at using a higher dose of paclitaxel overall by fractionating it and giving it over a weekly from a weekly standpoint. So, if you look at dose density, if you will, you go from 60 milligrams per meter squared per week up to 80. So you're getting more paclitaxel in, kind of the principle that we use with intraperitoneal, which some people argue you're just giving higher doses of drug. And so maybe that's why you're seeing some advantage. But this looked very promising initially, and these are the PFS curves and the OS curves, which were statistically significant. And notice they stayed apart pretty nicely there, even out after 6 years plus median follow-up. So pretty impressive data as we look at this. And so most of the world had gone to offering dose-dense therapy to their patients. And then to save us a bunch of slides here, I have the Japanese data on the top with their hazard ratio of just under 0.8. And then we did a study in the GOG where we did basically the same thing, and we didn't find any difference. And hazard ratio here was 0.97. Again, part of the problem is we allowed the physician and the patient to decide if they wanted to go on to bevacizumab. And that was covered in the trial. And so we had almost 80% of the patients went on to bevacizumab. So we had a very small subset that did not. In that subset, the dose dense did do a little bit better, but it was a small subset with non-analytic endpoints in terms of we didn't have alpha allocated to look at the survival in those patients and to know if there was truly a difference or not. But it was hypothesis generating. I just doubt that we'll invest more money to figure that out. When MITO-7 came out and said there really wasn't any difference, and then ICON-8 has been sort of the death knell of this. I do think, though, that so we've gone full circle here, and I do think, though, that the fact that you've seen this distinct difference in the Japanese, and we have some data in breast cancer conferring benefit from weekly paclitaxel as well in Asians with different pharmacokinetics, suggests that there could be some pharmacokinetic, pharmacodynamic changes in our Asian Pacific patients. And so I would consider offering it to those patients. I don't know if there's a benefit in patients from the Middle East or not. I've not seen any data on that. And certainly I'd love to hear about it in the question period if there is, or if there's any way we could access that. It would be interesting to know. We can certainly look in some of the subsets. We're learning a lot more about diversity in our clinical trials in the United States, where we have extremely diverse populations, where we would include obviously patients from the Middle East. We'd have Asians, some of whom have been here first generation, some of whom are Asian Americans or Americans, and they've been here for more than one generation, and so their diet and so forth is exposed to the Western diet, which presents different types of problems than what they see if they're eating the diet that's native. And so there's all kinds of factors that go into here that are an intermix between the cofactors of genetics and environment. And so very interesting in terms of how we look at that. Now, I could spend an hour just talking about bevacizumab, but I won't. I think everyone's familiar with the role of bevacizumab, and there's bevacizumab lovers and there's bevacizumab abstainers, if you will. So there's some people who use it, not virtually everyone that I know. And then there's other physicians who use it very sparingly. And then there's people like myself who tend to use it more in high risk group. Whether that's the right thing to do or not, no one knows, but there's some data to support that, although there's data that confounds that as well, or actually is contrary to that as also. So these are the two big studies that came out, Bob Berger's GOG 218, followed by Tim Perrin's ICON 7. So GOG 218 was done primarily in the United States, but was a global study as well. ICON 7 was a European-based study. And so very interesting in terms of those outcomes. We saw some similarities between those studies, with the primary endpoint being progression-free survival in both. And depending on how you looked at it, if you censored for CA-125, there was a much better PFS difference of almost 6 months, versus if you didn't censor, as was originally written into the statistical plan, you saw a difference of a little over 3 months. That's been consistent in most of the trials, where it did meet its endpoint statistically and was eventually approved in the United States based on the GOG 218 study. But it took a long time. This was not something they filed right away. They thought it was a borderline improvement in progression-free survival. They didn't know if the agency would even take that. And there was a lot of back and forth of, what do we do with that, and where do we go? Nonetheless, this has been something that we've been very excited about. And then I'll talk a little more about Bev when we get into some of the other areas as well, which has had certainly a major role and is a very important drug in our armamentarium. But it did really confirm the value of maintenance therapy, and that's been important. And so not all maintenance therapy has worked. And we know, for example, giving either a novel taxane or giving paclitaxel for an additional year did not improve overall survival. And so that has not been something that we've been super excited about as a whole. This manuscript has just come out this last year with Dr. Copeland as the lead author. So this is sort of a summary of where we are in the frontline disease setting. So, you have conventional therapy, which I would consider to be just chemotherapy, and surgery. And remember, surgery is a big part of this, whether that's giving, again, is primary treatment or as interval debulking, where we start with chemo first. And so for our center, what we do here is we assess the patient with imaging and physical exam, and their obviously a history to look at their performance status and so forth. And we make that very difficult decision then as to what we're going to do. And sometimes it's difficult and many times it's not, in that the patient really points very clearly to what we want to be thinking about. And so that's an easy thing to do then. We just go to making that decision. If there's widespread disease and she has comorbidities, it's pretty easy to decide to do the neoadjuvant. If she has an isolated pelvic mass and not a whole lot else going on, that, it's all about getting to the zero residual disease, so no gross residual. And if we think that that's easy to do based on the imaging and the exam, we'll tend to err on the side of doing primary cytoreduction to reduce that large tumor as quickly as possible, to relieve symptoms, make sure we have tissue for molecular assessment, and including obviously BRCA and other genes as well. And so that's sort of the main thing we think about in terms of conventional. Neoadjuvant, I talked about. Intraperitoneal, we talked about dose dense, and then biologics, certainly with the PARPs, which we're going to talk about in a separate thing. So there's our full circle coming back there. Has led to an amazing number of new approvals, and obviously PARPs have been a huge part of that you see in the light blue, and all those have been in recent years, probably over the last 7+ years now. So it's been an exciting time. We've also seen pembrolizumab introduced in this area as well, for patients that are mismatch repair deficient or MSI high. So I think that it's been an exciting time looking at the PARPs, and we'll get into those in great detail, as well as some of the combinations coming forward. So it's an exciting time in frontline ovarian cancer. I think it'll continue to be that way. And we're really excited about that. I'm going to go over this next slide very quickly because we're going to get into this in a little more detail. But the big decision here, in my point, in this schema, the first decision point is really, are you going to do neoadjuvant chemo, or are you going to do primary cytoreduction? And the second decision is, are you going to use bevacizumab or not with your backbone of chemotherapy? And then you get your molecular information, your BRCA status, you might know their homologous recombination deficiency test score. And so you have a lot of information there then to determine what you're going to do. So if you don't use bevacizumab, and I'll go over this one more time, but if you don't use, you make the decision not to use bevacizumab, but they have a mutation, then obviously you could use either the PARPs, and you have that are approved in frontline, either olaparib, niraparib, based on that. And that I think the majority of people would make that move. I think it would be remiss to not use maintenance PARP in this setting. Certainly in our country, we would say that's a violation of standard of care because the impact is so great for those patients. Now, if they're homologous recombination proficient, you would certainly be able to use niraparib here in this country. But you could also just watch those patients. So active surveillance. Now, if we added bevacizumab, you have the options, if they're BRCA mutated, to add a PARP. And the one that gets added most frequently off the strength of the Apollo 1 data is obviously olaparib. And if they're HRP, certainly most people would continue the Bev. You could make a case for stopping the Bev if they're not tolerating it and adding niraparib as maintenance. And so those are all different types of things that one could do. So I think that it's become a lot more complex, and you have to think about how one decision affects the next decision. So if you've used Bev in frontline, then you may want to consider bevacizumab in second line maintenance, depending on their molecular signature. And in my opinion, if they have a BRCA mutation or strongly homologous recombination deficient, in other words, a very positive HRD test, I have the patient prove to me, and as long as they had not progressed on a PARP, that they actually will not benefit from it, because I think that there's such a strong impact of that. But certainly if you made a case for using something different, or if the PARP wasn't well tolerated, you could certainly go to Bev, and that makes a lot of sense. If you use Bev already, you could use PARP in that second line maintenance, platinum sensitive maintenance. And if you've used both, you've got a lot of things to think about in terms of PARP after PARP and some other combinations. And so exciting times there. And we have some other studies that I think are also very exciting coming up. And I'll talk a little more about these in the PARP session, but the PARP session is a little long, so I'll probably just do this right now. These are really exciting trials, and we're going to have reports coming out really quickly. That top one's completed, the first trials enrolled, and so we'll be looking at this combination of a PARP inhibitor and a checkpoint inhibitor in these trials. As you can see, dostarlimab, which is a PD-1 agent, combined with niraparib. And so we expect to see this data perhaps even this year. And so very exciting there. Duo likely will also report out maybe sometime this year, maybe next year. We'll wait and see. And then the Athena, looking at the second part of Athena, and we'll talk about this. This is rucaparib, but comparing it to not comparing it, but comparing rucaparib plus nivolumab will be very interesting data, but we're probably ways away from that, as well as the Key-Link study is even further out, looking at olaparib versus in combination with pembro, and all those, of course, have control arms, and so forth. So very interesting in terms of the landscape change that we may see. And you may say, well, why in the world would you give three maintenance agents? Perhaps, as you can see, Bev is potentially used in some of these, and it is used in a duo. Yes, that's concerning from a cost standpoint. It's also concerning from a toxicity standpoint. But the hypothesis behind at least combining the PARP and the checkpoint inhibitor is that you may actually create more neoantigens with the PARP, which then allows you to have higher efficacy with the checkpoint inhibitor and changing the tumor microenvironment. And then, of course, Bev can be brought in to get better drug delivery, pruning those vessels and so forth. So there's preclinical models that show there's synergy between these agents, but that yet has to be proven in human beings. And so we'll wait to see. So I'm going to wrap up the frontline section here, that in terms of maintenance has experienced a rebirth with introduction of the PARP inhibitors, causing really, I think, more use of anti-angiogenics as well, in terms of just being familiar with maintenance and patients thinking they're going to get maintenance. And I think that that's been something that has been a change, at least here in our country, in that maintenance is used much more frequently, either Bev, PARP, or a combination. Unless the patient's really sick, most of the patients are on some type of maintenance for advanced stage disease, stage 3 and 4. They feel a bit left out when they go to the support group and find out other people are receiving maintenance and they haven't received any. They're saying, well, why are we letting my cancer potentially recur? And so that becomes a long conversation. That's certainly not the reason to use it, but we feel very strongly that there could be an advantage there. And we tend to throw our best agents at the patient up front because we think this is our best chance for cure. And so we'll see where we are. Certainly some of these molecular subgroups that we'll look at in my last talk, I think you have to actually think about cure, even though they have advanced stage ovarian cancer, which is a very exciting concept. We have 2 PARPs approved, and we'll talk about those. Biomarker development is really important, and I think we'll continue to need to look at these combinations and some of the toxicity, including financial, that we'll see with these combinations, and we'll have to be careful how we do this. The science is going to have to carry the day to show a significant improvement in efficacy for us to want to put these combinations together. I still want to emphasize the surgery, and if I went into the surgical part of this, it would take another 20, 30 minutes, and we don't have the time this morning, but I'm happy to have a more surgical focused talk at some point and have all that data that I'd love to share with you sometime. Hopefully we'll start getting some more data on the HIPEC to understand if this is something we should be adopting as well into standard therapy. I highly endorse doing this in a clinical trial setting. I'm not sure I'm convinced it needs to be done as standard of care at this point based on one small trial, but it is something that certainly needs to be tested and brought into the standard of care if it's confirmed in an ongoing trial that we've now started. All right, so let's move on then. Again, I'm very happy to be here this morning, and was very hopeful that we'd be able to be in person, and I'm sure we will, but I guess we need to move on in terms of where we are with this, because I know we've got to get through quite a few slides. So shukran laka for listening for this, and we're going to move on then to talking about where we stand with recurrent disease. Again, my disclosures, and we'll get into the recurrent disease here. So looking at recurrent disease, I think there's quite a few things to think about. And one of the things I wanted to show you, it's not because I want you to have to care about what goes on in the United States, but I have an updated slide that shows these curves continuing in this way up to 2020. I meant to get that slide in. It's on my other version that I thought I was showing here. I was working on this last night. And I find what's interesting is the incidence of disease has slightly gone down and has continued to fall somewhat. And we think that's due to testing for BRCA and prophylactic surgery, more use of birth control, probably picking up masses earlier. So just we're doing better in terms of decreasing the incidence of the disease. But we've also been able to decrease the mortality by almost, and the latest data is almost 30%. It's like 29 point something when you add on 2 more years onto this analysis. So it's a continuing trend that we're seeing. And so that's allowed the prevalence of the disease to go up, meaning the number of patients living with the disease, which has been very interesting. So there's more patients receiving more treatment in ovarian cancer throughout the world than there's ever been in the history of the world. And that's really been a relatively recent phenomena in less than 10 years, where you see the dynamics of those curves really changing. It's been about 10 years or so. So really exciting in terms of looking at this. And we'll continue to monitor this, but I thought this is very interesting data to show you. So this is a paper that I was lucky enough to be on, and we looked at, what are some of the other things we think about, patients that are platinum sensitive or platinum resistant, and that's been our traditional classification system. As you know, Europeans especially have embraced this concept of patients where platinum is appropriate versus patients in whom platinum is no longer an option. Kind of a long-winded way of saying, are they a good candidate for platinum? Is there a reason to retreat them with platinum? And I think the only thing that we're really recognizing with that nomenclature is that this is a continuous variable. In other words, a patient that's 6 months and 1 day is probably going to behave a lot more like a platinum-resistant patient. And the same for that platinum-resistant patient that's nearly 6 months out. They've got a good chance of responding to platinum. So it makes sense that you would, at some point, perhaps re-challenge them with platinum. And so I think that they've tried to get away from the completely dichotomous breakdown, but the completely abandoned platinum sensitive versus platinum resistant, I think, doesn't make a lot of sense. What I think we need to do is put it into context of other very important factors, such as the histologic type, such as the molecular signature. What is their BRCA status? What is their HRD status? So we've really changed things with molecular signature, and we've expanded upon that. Treatment-free interval, number of lines of therapy has shown a tremendous impact as well. And so and we also have data on their performance status and so forth that would predict outcomes as well now. So things have changed significantly. And I think that that's exciting, but we need to continue to think about these variables. And I'm not one for completely abandoning the platinum sensitive, platinum resistant model, because there is support for doing that. So what do we think about with these patients in recurrent disease? Well, I think the first thing I think about is, what are we going to do for the patient, in terms of what are her symptoms, what are the comorbidities, what is her performance status, the disease volume, and what toxicities has she faced from the frontline treatment that she had. We also have to look at the characteristics of the drug itself. What is the efficacy? What is the schedule? And what is the toxicity that's associated with that? And then what about the tumor? And we're learning more and more about the tumor resistance mechanisms, or we're thinking about those different treatment-free intervals and how they impact things, the lines of therapy there that the patient is on, and other molecular vulnerabilities that we can capitalize on, that we pick up, such as fusions and some of the other more rare findings that we see. So I think it's an exciting time for that. This is the traditional classification, as I said: platinum sensitive, platinum resistant. And certainly, those patients generally went on to non-platinum treatment. Everyone knows that. Platinum sensitive, they would get treated with a platinum-based treatment. And so those patients would receive some type of platinum with a second chemotherapy agent, and then perhaps maintenance. And in the non-platinum arena, it used to be single agent, but now we often use Bev as well, bevacizumab, in that setting. So this is the reason why I don't think you can completely abandon the concept of platinum sensitive and platinum resistant, is that no matter what data set you look at, and this is from Dr. Poujadi-Lorraine in France, but you can look at a number of these and you can see the inflection points that occur, whether it's response or PFS or overall survival. You see that as you get out to 3 months, there's a difference. You get out to 6 months, there's a difference. You get out to 12 months, there's a difference. So, I think that it makes some sense to think about those things, but they should not be seen as discrete entities in which you can only be treated a certain way in each one. But they are helpful, in my opinion, in terms of guidelines for how you'd want to do that. Now, having said that, let's talk about patients for whom platinum is an option. So as I would say, platinum sensitive, but some people argue with that nomenclature. But so again, usually a double platinum doublet, and then you have the option of PARP maintenance or Bev maintenance. Obviously, the histology would guide you there in somewhat, in that the PARP trials have been done on high-grade serous and endometrioid almost in all the trials, not all, but that certainly would point the way. And then, of course, what did they receive up front, as we talked about in the first talk. And so I think there's a lot of things to consider there, and there's a decision-making there clinically that I think is very important. But I hope that this helps guide you a bit. So we have lots of trials that we could go over, and I could show you all the schemas and go through all this. I think this is a nice summary. If we look at the winning PFS on these trials there, you're getting out to about a year, and or slightly more. And we saw that with GOG 213. Where Bev was interrogated, as well as the role of secondary cytoreduction. So that was a paper that we really tried to answer two questions in one, and that's always problematic sometimes. But we're very, very proud of GOG 213, and I think Aurelia has had a tremendous impact on our platinum-resistant population, really setting the standard of bevacizumab with chemotherapy, improving outcomes by nearly doubling the progression-free survival in the overall population, and particularly in the paclitaxel Bev combination. So lots of landmark trials on this slide with ICON 4, Calypso, Oceans, Aurelia, and GOG 213, and I think that's certainly been exciting. This is 213, as I said earlier. This is a trial that had two different objectives. One was to look at the role of interval cytoreduction in patients with recurrent ovarian cancer, platinum sensitive, and the other was to look at the role of adding bevacizumab. Primary endpoint on this was overall survival, which was met, but barely. You do see a higher response rate when adding bevacizumab, almost 80% versus nearly 60%, and a 5.3-month improvement in overall survival. And you can see on the first one there, the hazard ratio crossed 1.01, and then when they corrected for the case report forms and went back verification and so forth, it fell below that. Leave it to you to decide which of those case report forms you take into consideration. But nonetheless, most consider this a positive trial, and it did get published in the New England Journal of Medicine. And by conflict of interest, I was an author on that trial. And then, so these are how you treat platinum sensitive disease. And then bold at the bottom, I think, always are clinical trials. We really feel we've made that really a tremendous amount of progress with that. And I think that most people would do platinum-based therapy followed by maintenance with either PARP or BEV. And we'll talk a little more about that in the PARP section, how you choose those patients. But I think that that's sort of where we sit right now with standard of care. There's been what was really interesting to me is we've had platinum sensitive a decade ago was the area where we had the most drug development, because people felt that the endpoints were a little bit shorter than frontline. We'd get to the answer a little bit quicker. The patients were not as beaten up in terms of comorbidities. And so they thought that there would be an opportunity then to look for the introduction of a new therapeutic and be able to show a meaningful advantage to adding that. And I think that part of the switch to looking more at platinum-resistant disease has really been the opportunity for accelerated approval. So the US FDA has allowed for roughly 100 plus patients with a 200 patient data safety set to then apply for an accelerated approval with the condition that you would then do a full phase 3 to confirm that. They've come under criticism for this, mostly in other disease areas, not really in GYN. And so I think that a lot of pharmaceutical companies pursued the accelerated approval strategy because you could get the drug to market and actually be getting some return. The downside of that is sometimes it's hard to finish the phase 3 because it becomes a de facto standard of care in the community. And people don't want to get randomized to something that, even though it's only accelerated approval, they consider that a win. And a lot of the community physicians are reluctant to put patients on a trial then. So there's some nuances, and I'd be happy to talk about that sometime because it's been an interesting dynamic that I've followed very closely. So those are what we usually want to do as our options go. But some of the things on the top are what we would consider depending on some special circumstances for the patients. Okay, so that's sort of where we are with that. And then what about platinum-resistant disease, or those patients in whom platinum's not an option? Again, we have sort of the same menu of things we could do, anything from repeat surgery to radiation to just hospice, as well as the options that you see. And again, the bottom is really where we are, the clinical trials again, and either single agent or single agent with BEV is really what we usually see in this area, and lots going on in the clinical trial area. And of course, the combinations that we've seen in this have been interesting, mostly in the clinical trials. So let's talk a little bit about what we're going to do with those patients for whom platinum's not an option. And so this is a look at our phase 3 trials that have been done in platinum-resistant disease, or PROC, and you can see where we are here in terms of, and we have it in weeks, but it's basically 3 to 4 months that you're out in most of these, and with even the best of the best, you're really looking at 5 months or so. But most of them are 3 to 4 months, 3 to 4.5 or so. And then overall survival is generally, with the winning arms, somewhere near a year, or a little bit more, but not very much. So you can sort of see the difference there. The response rates for these patients are generally as low as even 8% or so in some of the trials, especially the more contemporary trials where the patients have been pretty heavily pretreated. And as high as almost 20%. Aurelia, a little bit higher with the breakout of that, and I'll talk a little bit about that as well. And we're seeing some of the winners there. Okay, so here we're looking at Some of the things that I think are important in terms of the combination in the PROC patients. And so these are some of the combinations that have been looked at. I was involved in the trabectedin, which is major groove binder, minor groove bender compound. So it interferes with DNA repair and making proteins and so forth. Along with pegylated liposomal doxorubicin, you can see no difference there. Weekly paclitaxel with trabantinib, nothing really there, even though it hit on PFS. No difference in overall survival there, and fairly modest gain at the median. And then chemo plus or minus Bev, very significant in terms of RELIA trial. With pertuzumab, that was a miss as well. So the RELIA trial was a very important trial, but it's very interesting. It's a bit of it's almost a basket trial, if you will, because they had different cohorts they filled, and it was sort of physician choice, but they had certain cohorts that would fill up, and then you had to use this or you weren't able to go on the trial. And so that may have influenced some selection processes, and certainly there would be some criticisms if you repeated this trial today, but I think this was a very important trial that gave us a lot of understanding of what the value was of adding bevacizumab, as you can see here, and that was significant in terms of what was seen in terms of the response rate, and you can break it down by rhesus tumor versus CA-125, fairly consistent in terms of the benefit to the patients. This is looking at the PFS on the left and the overall survival on the right. And you can see that there was a significant advantage here with a hazard ratio of 0.48 for the progression-free survival, and those curves were significantly apart. Overall survival, not as much, obviously. It overlapped one, but it was a hazard ratio of 0.85. So interesting there, in that we were not even in a platinum-resistant setting able to preserve the OS or preserve the PFS effect with the overall survival data. Remember that these patients were not very heavily pretreated, so you have to be careful with looking at this. These were 2 lines or less. So that's something to understand. These are some of the subgroups here. I think most people were most impressed with the PFS that we saw that almost hits the OS for our traditional platinum-resistant patients, so 10.4 months in the Bev paclitaxel arm, much shorter in the other cohorts, so 5.4 months in PLD, 5.8 months in topo. Very interesting in terms of some of those there. So I was going to briefly go over some of the platinum-resistant trials, and I think that's some of the trials, period. But I think some of the really interesting trials and the big investment lately has been in the platinum-resistant disease. And so I kind of wanted to show you that, because I thought that this could be a benefit for you to see. So we'll take a look at that here. I just wanted to look at something also, and time-wise here where we are. So looking at that again, I think that very exciting as we look at this. And I think that, so that'd be 9:35, so that'd be 1:35. Just looking here where we're supposed to be. Yep, so we're right on time here. So the OVAL trial, this is a very interesting compound, VBL-111. You'll see the data came out this past fall. And unfortunately, it was a negative trial. People were very excited about this because they had an interim analysis, and many people thought that this was going to be a win. It was not. It's a bit of an immune drug and a bit of an anti-angiogenic drug at the same time. It's hard to classify it completely. It does change the microenvironment, but has anti-angiogenic properties. And so very promising data in phase 1b expansion, but it was a miss. So we won't talk more about that. I'm going to talk a little bit about Innovate3 with the tumor treatment fields. I think that that's something that's also very exciting. And we, continue to be excited about some of these new opportunities with these compounds as we move forward, because we obviously need new things, and we'll talk a little bit about that. I'm not going to skip Moonstone, but is very interesting. Also looking at niraparib and dostarlimab in phase 2, but we'll have that more advanced data coming out as well. The LAKENA trial and the Alkermes trial, I'm the global PI on, so I'll talk a little bit about them, but just to give you an idea of what's out there, because it looks also interesting. Mirasol, is coming up. We'll be getting a report on that shortly. And then we have some other interesting compounds that are out there as well. So lots going on. We have the last one there is GOG 3059 is one that is closed now. It says recruiting, but we just closed it to recruitment, and that's a Gas6 axle pathway. So it's somewhat angiogenic, but a totally different way of attacking that. And so it'll be very interesting to see where that hits, because it came out of a relatively sparse phase 1b expansion. Also had little to no toxicity. So it'll be interesting to see if that does indeed have any activity. So we should be hearing about this fairly soon. So this is exciting, and I don't know if you're familiar with it. I was a bit of a skeptic when I heard about it, that you're going to put magnets on patients and cancers are going to get better because we changed the polarity of the cells, and we interfere with the mitotic spindle and some other things, and lots of hand waving in terms of what the mechanism of action is. But when I started getting approvals in other disease sites and other cancers, it certainly brought attention to us, and it's approved in glioblastoma and malignant pleural mesothelioma. So two global approvals. Now it's time to take interest in this. So this is the Innovate study. You can see there the single arm, the OS and PFS look pretty good. More so also the some thought leaders. I know Dr. Vergote's one of the PIs, or is the PI on the registration trial. So it's going to be very interesting to see where this all goes. This is the Innovate schema here. So again, these patients are platinum resistant, and they are comparing it to weekly paclitaxel. And so very interesting in terms of looking at this, and I expect some of the data to come out very soon. So keep that in mind as you move forward. Here's a trial that I'm the PI on. This is aflibercept. It's a pan AKT inhibitor, and we've seen some really good responses with this. We only have 13 patients to go globally to close this, so we're excited about this. We hope that we see more in the future. Another trial the global PI on is which is why I'm not there this year. It's just been a crazy year, because the one trial will be wrapped up here in the next month. That'll be very helpful, and not only hopefully have this trial open, which hopefully should be well on its way and sailing towards the endpoint by next year. So this is a trial with nemvaleukin, which is a it's a synthetic IL-2. It has a very interesting mechanism of action, and what's interesting about it is that it binds the IL-2 receptor in a way that what I think is interesting is it confers most of the positive effect without the problems that we see with the significant toxicity with cytokine release syndrome and other problems that we see with IL-2. So IL-2 is a program that's been around for many years, but it's really been just too toxic. So this is a way of introducing its positive effects. And so what we've seen is a significant increase in NK cells and helper cells, T8 cells, T helper cells, that the increase is also there in the suppressor cells, but it's not as much. And so the ratio changes significantly, and we think that it tremendously changes the microenvironment. So the real experimental arm on this is a 4-arm trial. The real experimental arm is the comparison between Pembro and nemvaleukin versus investigator's choice chemo with either pegylated liposomal doxorubicin, weekly paclitaxel, or topotecan, or gemcitabine. And so we're excited about that. We'll see what happens. Some exciting early data on this, but again, it has to be tested in this type of setting, which is much more rigorous. So we'll see where that comes out. And then there's also been some interesting in terms of modulating the cortisol levels. And so this is a program where they, we know there's physiologic cortisol levels can suppress immune activation. And so can you change that by manipulating this, by acting on the glucocorticoid receptor, and then thereby influencing tumor growth. And so that's the hypothesis behind this. I was involved in this study in the phase 1. I'm not involved in the phase 3 other than as an advisor, but I can tell you it is interesting. They found that the intermittent schedule worked better. And so that was what was taken into the next round with the drug relacorilant. So another interesting thing here, and this is the phase 3 here, in which it's combined with nab-paclitaxel, and why they're doing that is because they don't have to have steroids involved with that. So somewhat interesting. And then the investigator's choice. And I don't want to go into too much detail on these trials, but investigator choice chemotherapy, again, you can see the options there with, again, pegylated liposomal doxorubicin, weekly paclitaxel, topotecan at 2 schedules, or nab-paclitaxel. And so very interesting. But we'll have to see how it performs in phase 3, because that's really where things at. And then we've seen the introduction of antibody drug conjugates into ovarian cancer. And so this is certainly new to our experience in ovarian cancer, and the first time we're really talking about it with any meaningful data in Saudi Arabia, because even last year at this time, we didn't have the data. It was just coming out virtually about 3 to 4 weeks later. And so here you can see the data from the so-called phase 3, but single-arm trial, and where the response rate in this platinum-resistant ovarian cancer setting was really quite impressive at 32.4%. So I think that the duration of response was quite good, and we're awaiting the confirmatory trial with Mirasol. And so this has been approved on that accelerated approval pathway that I was speaking about earlier, which has encouraged a lot of investment in platinum-resistant ovarian cancer. They have a lot of other trials ongoing in terms of looking at other ways of using mirvetuximab. And you can see the other things that they're looking at in combination with Glorioso, which is going to be looked at in platinum-sensitive disease. And then can they replace chemotherapy, perhaps, with replacing paclitaxel with mirvetuximab in combination? And so that's going to be looked at in platinum-sensitive disease as well. So there's a number of programs that are ongoing as we move forward. And so other drug conjugates that you need to be aware of is that there's other conjugates that are looking at folate alpha as well, as the case with mirvetuximab. The folate alpha receptor is overexpressed in about 80% of ovarian cancers. And that's really where things stand. But there's also other targets, if you will. So if you think about antibody drug conjugate, it's very simple. You have the antibody, you have the drug, the payload, if you will, and many of these are tubulin attackers, but there are some other ones as well. And then you have the linker. And what you try to accomplish with this is to load enough payload or warheads onto the antibody, and that you have high enough affinity binding. And then you have endocytosis, where this is brought into the cell. And then you may have some release where you have a bystander effect, but hopefully not too much, or that's where you're going to get off target problems. And that's really the concept behind this. So, some of them, they have higher leakage, say, well, it's great because we have a bystander effect in the tumor with other cells changing the microenvironment and so forth. That's also where you're going to have uptake systemically, because the drug, when it's bound, it will not be toxic. But when it gets released and then re-released out of the cell, if it's a substrate, for example, for P-glycoprotein, pump, or something else, then we have the toxicity. And that's where you see some of the eye toxicity or ophthalmologic side effects, some of the neuropathy, some of the fatigue and nausea that's associated with some of these. Not all of them have it. In fact, this particular one does not have much of that, as we've seen with tisotumab vedotin that we use in cervical cancer, or with mirvetuximab, which has less of the eye toxicity, but still has eye toxicity mandating during treatment that they initially, with each cycle, see an eye specialist or an eye professional. This is targeting NAPA2B. It's UpRi, if it's the short name for it. You can see the waterfall plot here, which is really quite impressive in terms of looking at this at different doses. And so I think it's been a little bit of a project to get to the right dose, as it often is for these drugs, and especially with the FDA now with Project Optimus demanding more in the way of understanding why you select the dose that you do to move forward in clinical development. And you can see some of the response rates there, pretty impressive. So you're looking at 34% response rate in this population, which is, again, is outstanding. The other thing about this is the NaPi2b is probably more prevalent, probably looking at 50 to 60% of patients that would screen positive for this, versus if you're doing folate alpha high, it's probably capping out at 40% or so. And it's probably, realistically, it could be lower. It could be just a little over a third or so. So something to think about as this develops also. So number of different initiatives here, looking at up next in the platinum sensitive population, looking at the drug here. Again, they have a particularly high antibody or drug to antibody ratio. So it's over 8 to 1 on this. So lots going on in recurrence, and I want to leave some time for PARPs because there's quite a bit to talk about. In fact, I have too many slides for PARPs, so I'm going to run through them pretty quickly because I do want to leave some time for questions. That's the most fun part for me. So as you can see here, lots going on in this area. I've talked about why I think that is in terms of the accelerated approval process in our U.S. regulatory authorities, which drives a lot of the profits because it's very profitable to be approved in the U.S., where the markup can be significant for the pharmaceutical company. Whether that'll continue forever remains to be seen. But certainly there's a market here that is appealing to even companies outside the United States, so Chinese companies, European companies, and so on. And so we'll continue to see changes. Immunotherapy so far on its own has been 0 for 3, but I think some of these combinations are very promising. So we'll keep an eye on that as we move forward. And then we'll move into the PARP talk here. And I just want to check the chat here and see if there's anything I'm supposed to be doing there. It doesn't look like it. Okay, just making sure everything's okay. All right, if you're hanging in there, I'm hanging in there. This has been a lot of fun so far. We're going to do the PARP talk now, and as I said, I know we want to leave some time for questions. And let me again look so to see where I'm supposed to be on time here. I have it right here. Get to a different screen. Okay, I'll find it here in one of the breaks. But I think with the PARPs, what's really been exciting has been the tremendous development that we've seen. And I'm going to go over some of the historical part first, and then we'll get into some of the things. You've seen my disclosures now a few times, hoping they're all matching. And I think that I'm not going to, with the amount of slides I have in that, because I want to get to the clinical implications, which I think are probably more meaningful to the audience. I do sort of want to have you think a little bit, though, about, where we are with all this moving forward. And so, we have about 15 minutes or so to get through this, and I have way too many slides, so I'm not going to spend a lot of time. What I am going to show you is that, this whole thing started with this concept of synthetic lethality, which is really, reported on in 1922 with the concept that and it was found in the Drosophila, the fruit fly, and they were looking at different gene rearrangements and so forth. But if you have pathways that interact, if you knock out one pathway, it's not lethal. You knock out the other pathway, it's not lethal. You knock out both pathways, it becomes lethal. And that's that idea of synthetic lethality, and that's what this is really based on. And so the one pathway that's critically important is base excision repair, and and PARP is an essential part of that. And so that's why you think about that system, and then you think about double strand, and that's single strand DNA repair. And so what happens when you're trying to replicate is you create single strand breaks, and that allows it to unravel so that you can replicate and so forth. But if you don't allow single strand DNA breaks to repair, which is lots, chemotherapy takes advantage of that, and certainly PARP plays a major role in that if you're inhibiting PARP, because it's central to that repair process. What happens is you have double strand breaks that occur. And the most powerful way of repairing those, and the most accurate way of repairing those, is through the homologous recombination pathway. And so BRCA1 and 2 is central to that particular pathway. And what happens is if you knock out homologous recombination, you'll still have repair of double strand breaks, but you'll switch to non-homologous end joining, alternative end joining, which have very low fidelity, and it will eventually result in genomic instability. And that's what you see with the loss of heterozygosity and some of the tests that we do to see if you'd be likely a responder to PARP inhibitors, because it's really those two pathways together that create that synthetic lethality. So I hope that makes some sense to you. In translation, it may not, and it may not even in English, but I hope it does. And I know it's almost 2 a.m. my time, but I think the concept is very important to understand, and I think it makes a lot of sense if you sort of think about it in those terms. And hopefully that was a better explanation than what you've had from others. So I think when you think about the different things that you can do, looking at these different molecules that we have, and these different tests and so forth, we used to look just for germline mutations. So sort of start at the bottom of the slide. So we used to identify those patients that had a BRCA mutation. And who are those patients? Well, those patients, frankly, they are just those patients who have either BRCA1 or 2 mutation on the germline testing. Then we realized that significant number of these patients have tumor mutations. Oh, so why is that important? Well, if they have a tumor mutation, that's important because we can actually then find out that we're able to increase the number of patients that would benefit from PARP therapy, for example. So we went from 15%, now you're up to about 22%. Then if you start thinking about the genes, such as RAD51C, RAD51D, and all those other genes that are important for homologous recombination repair, You then get up to even higher. And so you gain another 12, 13%. And then you gain another 15% when you start looking at just this genomic instability, even without the HRR genes being mutated. And so I think that that's important for people to understand, is that by casting the net wider, you see almost half the patients with certainly high-grade serous cancers will benefit likely from PARP, because they have the molecular phenotype that is going to confer a higher likelihood of response. So I think that's important to understand, and I hope that that makes sense to you. And that's really what this is showing, is that you can sort of see how you get up to that group, where in some papers it has exceeded 50%, such as this particular paper. But it gives you that concept. You have the germline somatic, then you get the HR deficient, possible HR deficient. And there's other ways of getting there, right? You can have BRCA1, promoter methylation. There's lots of ways you can get there. And so you need to be aware of that. And I think genetic testing and that is so important now. I'm not going to waste much time on the phase 1, only to say that, you know, when Peter Fong reported this in 2009, we little did we know that this would change the next 15 years tremendously, or now 14 years tremendously, for treatment of ovarian cancer. And this, you know, this was looking at olaparib, which was the first one out. And you can see here in terms of the response rate that's seen there, which is pretty impressive looking at this. And so I think, you know, getting this type of response rate that was seen is something that is pretty remarkable, and it has made a tremendous difference. So 46% response rate was reported in this particular expansion of the phase 1. And it's led to this. Now, who should be tested? Virtually everyone, right? So anyone with epithelial ovarian cancer, and you can argue about mucinous, but you'll occasionally pick something up. So it's pretty unanimous, no matter which organization, NCCN or Society of Gynecologic Oncology or American Society of Clinical Oncology, ESMO, European Society of Medical Oncology. You go on, and they all have different recommendations, but all sort of saying the same thing. This is the value of why genetic testing should be performed. It's prognostic, it's predictive, and now it really makes a difference in how we treat patients. And I think that'll become clear as we go through this talk here. This was the original accelerated approval for olaparib, based on Dr. Kaufman's paper that came out in JCO in 2015. It did have an ovarian cohort. You can see the primary therapy indications there with SOLO-1, PRIMA, and PALO-1. We'll talk a lot about, and then the platinum sensitive maintenance I'll get into as well. This is the platinum sensitive maintenance for olaparib. These are very similar trials, and I think this is somewhat old news to most of you, so I'm not going to spend much time. Primary endpoint in all these trials was PFS. It was investigator PFS in SOLO-2, and also in the rucaparib trial, and it was blinded in NOVA for niraparib. So blinded independent review. So MDS has been an issue, and this is certainly something that we continue to look at. You know, NOVA, you can see that in the BRCA cohorts, about 7% have MDS AML, and 8% in SOLO-2. So fairly similar. So we do need to pay attention to this as a long-term problem, and I'll mention that as we go through some of this data. But I think it's important to understand the background on this. Rucaparib, we haven't had the long-term follow-up, so it will probably likely be much higher than 1%, especially if you look at the BRCA cohort. We've had trouble getting new data out of the company because they filed for bankruptcy protection recently. So that's been a little bit of a challenge. SOLO-3, I'm going to spend a little more time on that for a different reason later, but it was an interesting trial. It looked at olaparib versus physician's choice chemo. As you can see, the response rate was higher with olaparib. These patients were, interestingly, um, platinum sensitive, and they were treating with non-platinum, that 6 to 12 month group. The trial that I think, in terms of recurrence maintenance, that really made the first mark was the NOVA trial. This was a trial that really had two cohorts. One was looking at germline mutated patients, and the other one was non-germline mutated. So they really had a nested trial of two separate cohorts that were going on here. And there was randomization within each of those cohorts to niraparib versus placebo. And again, blinded independent central review for PFS outcome. A large trial. So these were all platinum sensitive patients. And they had to have a response, as did all these trials, with either a CR/PR to the penultimate platinum. So the platinum they're receiving for the platinum sensitive recurrence. And so, really impressive results. This is sort of the flow, if you will, in terms of the breakdown and some of the data that we've seen, but I've got other data that's probably a little clearer here. But as you look at this, I think what's important is to really see the breakout here of some of this. So this is the progression-free survival in those of the germline BRCA mutated population. So really big differences, 21 versus 5.5 months in progression-free survival. Hazard ratios like we've never seen before, right? So we've seen hazard ratios in these types of trials under 0.3, and in one case under 0.2, but unbelievable in terms of looking at some of the impact of this. So really impressive. Look at those curves, and they stay apart. They're widely apart. We just wish for this for everything we worked with. You can see the landmark analysis, your chance of progressing or dying, even 18 months out, 50% is the chance of not having a progression or death if you're on niraparib, and only 16% if you're on placebo. So only 16% did not have progression or death by that point. So very interesting in terms of the breakout that you see there. So this is some of the exploratory analysis. Again, I have this all on a table, and this is relatively old data. But the bottom line on this is if you're HRD positive, even if you don't have a BRCA mutation, you show a significant benefit. If you're HRD negative, it's not as profound. You can see the difference there. Is the this is the non-BRCA cohort. You see a difference there of almost 3 months. Final, I think, was 2.7, 2.8 months, but the hazard ratio was 0.58 on this, but 0.68 on most of those. So it made a big difference. Quadra, we'll talk a little bit about later as well. And then if we look at Aerial 3, this was the same type of study looking at rucaparib platinum sensitive maintenance, and again using investigator PFS in this one. And you can see here if they're BRCA mutant, unbelievable hazard ratio 0.23, HRD 0.32. So you're that includes those with mutation. And then intent to treat, which would obviously include those that are homologous recombination proficient or who tested negative for homologous recombination deficiency. You still see a very impressive benefit there. So this is, to summarize, you can sort of see the breakdown, because I think it's good to look at the groups. This is not to cross-trial compare, but to organize all this data, because there's just a lot of it. I could show you another 20, 30 slides with all the different subgroups. So I literally, if I put my whole talk together on PARPs, just looking at PARPs in ovarian cancer, it's over 130 slides, because that's how much data we have now from all the updates and everything else. So I tried to be a little selective in what I showed you, but also to emphasize some of the new data I'm going to show you also for the front line that came out at ESMO this year, which is also important. So all amazing. The orange program is the rucaparib program with Aerial 3. The blue is the niraparib program with originally Tesaro and now GSK. And the purple is the olaparib program with AZ. or AstraZeneca. And they had 2 studies there, the Solo 2, but that was only done in germline BRCA patients. But they also had study 19. And that was an all-comers population, but that was a phase 2 randomized trial. And they spent a lot of alpha along the way. And so they weren't able to show that long-term benefit in OS, but they had very substantial differences as well. So very interesting in terms of looking at this, and literally you could go on and on talking about the differences. So let's talk about frontline for a few minutes because I want to stay on time again, and I want to make sure we have a few minutes for a couple questions. And so this is looking at the data as you go across there, looking at these amazing trials that really did make a huge difference in treatment. So you look at Solo 1 there that was the first trial to report, and that reported in 2018 at ESMO. And then the following year, you had 3 trials report in the presidential session of ESMO that was in Barcelona. And you can see there, the trial on the far right really never went anywhere. It was Velia. My good friend Rob Coleman was the PI, but unfortunately, it doesn't appear that they're going to file for anything in ovary. So we're kind of going to leave that alone. But the 2 that really obviously have influenced our treatment because of approvals from both these trials are Prima and Palo 1. So we're really impressed with all these 3 trials on the left, Solo 1 all the way through, and sort of leaving off the Velia at the end. You can see the differences here in terms of amount of stage 4 disease, neoadjuvant use versus primary cytoreduction. Prima was designed to be a high-risk trial. If you did primary cytoreduction, you had to have residual disease, and that was also BICR assessed, which is a little bit different. The statistical plans on all these are similar but different, so you have to be careful in terms of any cross-trial comparison. So again, I'm showing you this to organize the data, not to cross-trial compare, because they're different populations, and some of the stats are a little bit different. Solo 1, I think everyone's familiar with this. This was done again in patients who had BRCA mutations. Virtually all of them were germline. There were a handful of somatic that got in. Nonetheless, the label reads for both. And I think, really impressive data once again. And I'll show you that primary endpoint was PFS by the investigator. Originally, it hadn't even been reached, and then was updated by Susanna Banjari about 2.5 years ago at ESMO. Original data, again, was Katie Moore presenting this in 2018 with the New England Journal of Medicine paper that came out that same year. And you can see a tremendous difference in the medians, 56 versus 13.8 months, with a hazard ratio of 0.3. And remember, this is just in BRCA mutated patients. Nonetheless, amazing. Look at these curves. The curve morphology just keeps going and going. And there's your landmark analysis of 60% progression or death free at 3 years versus 27%. Which curve would you want to be on? That choice is very easy in this study. This is looking at the 7-year data that was reported at ESMO this past year in Paris. Paul de Silvestro reported this on behalf of the Solo 1 group. And you can see here, hazard ratio. This is overall survival at 7 years, but the hazard ratio is 0.55 in OS. So this concept of, well, is there really a benefit or not, or does it, look at this. And when you start talking at 7 years, you can start talking about potential cures. And that's what I was talking about earlier. We've never been able to talk about that in advanced ovarian cancer. So this is really exciting. This type of approach will likely change lives for the better for many patients and their families. Prima trial, also incredibly important trial that has made a big difference. And I think that as you look at this again, we're high-risk patients that I described. They're using BICR. You can see the strat factors, whether they did neoadjuvant or primary cytoreduction, what their HRD score, and whether they had a CR, PR to the antecedent chemo, all of which these patients, again, had to all these trials, they had to respond to the prior chemotherapy. that's there. And you can see the hierarchical testing that they did there. So all these had different plans. This is what I was talking about earlier. They had to have, if they did have primary cytoreduction, they had to have visible disease, or they weren't able to go on the trial. So it sped up the endpoints, if you will. Hazard ratio, very impressive in the HR deficient, which was the first group that was looked at in this hierarchical design, in which they passed alpha along to the next group, which in this case was the intent to treat population. But here you see the first look, if you will, what they were planning on doing. The hazard ratio, very impressive, 0.43. Favoring the niraparib versus placebo, and you can see the landmark analyses on that as well. Medians essentially doubled from 10.4 months to 21.9 months in the HRD group. This is your intent to treat population here. The overall population is still a really impressive hazard ratio of 0.62. Really impressive there. Here's looking at the 4-year PFS from Prima that was put out at ESMO this year, again by the primary investigator, Antonio Gonzalez Martin, who's been the PI on all the podium public presentations from from Prima. And you can see here the really impressive curves here again. OS is immature at this point, but all those, as you can see, strongly favor the PARP in the front line. So keep that in mind as we're talking about, when do you use PARPs and so forth, but very important in looking at that. All right, so if we look at Palo 1, this is the idea of combining olaparib plus Bev versus Bev alone. So what's the role of adding olaparib to for people who would otherwise use Bev, and which it's used quite a bit in some countries in Europe because it's their only opportunity to use it. So it varies how Bev's used is different or globally. And we probably in the United States, if you average household, everyone does it, it's probably about 40 to 45% of patients receive Bev. To give you some idea, again, investigator assessed PFS, and so again, you had to respond to the platinum. Here's the all-comers population here, and you can see a hazard ratio of 0.59, incredibly impressive. Good curves there again. If you break it out by mutational status, you can see here those that had tumor, so they're either a germline or somatic, had a hazard ratio of 0.31, very similar to what we see in other studies. And then the non, it was 0.71, but did not cross 1 when you look at it in that way. But when you looked at the HRP group, not as impressive. HRP group, I was giving you the data actually for Prima before, it was 0.68 with a 2.7 month median. So the NOVA data that was on the slide was correct there. It's what happens when you're doing this at 2 a.m. You've been operating all day. And then you have the update here that was at ESMO this year, and Isabel Ray-Cocard, who's the original principal investigator on this, continued to report on behalf of the group, showing now looking at 5-year OS from Paula. Again, hazard ratio 0.62, not crossing 1, big difference in the median. So consistent data for these two PARPs in frontline, showing wildly positive data with no diminution in OS looking further out at 5 and 7 years. So really impressive. Here's some more subgroup data that I don't want to have to get into at this point. More of a breakdown here again from the latest data we've seen. I think everyone's familiar with the safety profile. What has been the most reassuring is the long-term data on Solo 1 all the way out to 7 years has not seen an increase in MDS-AML over what was seen on the original. So when you use it in frontline, we don't seem to see the same amount of MDS-AML. This is something that we'll need to continue to follow, though, and that's important. These are more of the side effects that we see, the hematologic and non-hematologic common things, and then the less common things that are very important that we continue to follow with AML, MDS, and pneumonitis. So the last thing I wanted to talk about was one addition to this. This is the rucaparib program looking at Athena mono. So there's, if you look on the far right there, you have the rucaparib versus placebo. And then you have the combination of rucaparib and nivolumab versus rucaparib and placebo. And so you sort of break that into Atheno mono and Atheno combo. So the only thing that really reported here was the Atheno mono. But again, very similar to the other trials, high-grade serous cancers had to have a CR/PR, the usual, and then randomization was different there with 4 arms, before 4 to 1-1, mainly looking for contribution effect from just nivolumab alone and just placebo alone to isolate the treatment effect. Primary endpoint here, you can see Dr. Monk presented this, but you can see the hazard ratio 0.47. Big difference there in the median. And so very impressive data as you look at this in the HRD population. If you look at the ITT population, again, impressive hazard ratio 0.52. So not quite as good, but very impressive overall. Really good data across the board here. Same thing we're seeing here, same trends that we've seen, maybe even slightly better in some respects with the HRD test negative, but nonetheless, really good data. We think, all this is more of a class effect. And then I've included the PRIME study that was done in China, which looks very much like PRIMA. They used individualized dosing to decrease the platelets throughout versus PRIMA only about the last third of the trial had individualized dosing, again, showing less thrombocytopenia in those settings. But you can see the subgroups there and so forth. It's very interesting. It definitely is the strongest effect is in BRCA mutant, followed by HRD positive, followed by HRP, if you will, HR proficient or HRD test negative, where you see differences in PALO1 that were not significant at all, hazard ratio 1.0. PRIMA and PRIME still showing significant differences, as did Athena. But what that translates into, other than PRIME, was you're looking at 2.7 to 3 months. So again, you've seen this before. In the interest of time, I'm not going to go through it again, but I think it's very interesting with all the choices we have now, and it's gotten a lot more complicated with all this molecular data, but it's been very exciting to be part of this. Avario, just to remind you that niraparib does have a phase 2 study looking at a combination with Bev as well. It was just based on a landmark analysis. So we're waiting on that write-up and possible NCCN listing there. So we'll see that. These are those other trials with combinations with IOs and with Bev in some cases. PARP resistance mechanisms, many are there, and we just don't have time to go into those. And then I was going to just show you some of the other things that have come out with these Dear Doctor letters, where we've seen a withdrawal from SOLO3, where we combined or where we compared in platinum sensitive olaparib versus physician's choice, where we saw a positive PFS study, but some cohorts in the OS, which were non-analytic endpoints, were judged to could be a problem. Same with Ariel 4 for the rucaparib program. In their Dear Doctor letter, where they voluntarily withdrew it for that indication for treatment, as was done with olaparib with the SOLO3 program. And then Quadra with niraparib did the same thing. And then also Nova, we saw where for the platinum sensitive maintenance, even though we saw those impressive differences, they voluntarily withdrawn for non-germline BRCA mutated. So you can see the crossouts that are on here to bring you up to date in the US where the FDA stands. We're a little concerned with this. We think it's been an overreach by the agency, frankly, in some of these cases. We were hoping for an ODAC to be able to get some of the science out there. That is yet to come. It's unclear if rucaparib is going to proceed with an ODAC or not, so we'll see. But there's lots to talk about, and there's sparingly little time to be able to do that, to go into the depth. But suffice to say, in my opinion, these were non-analytic endpoints. There was a tremendous amount of crossover. And in the case of Ariel 4, just to give you an example, the patients that had received prior rucaparib, this was done ex-US, mostly in Eastern Europe, and the majority of those patients went to hospice. So to be able to say that, and then most of the patients in the placebo arm went on to get rucaparib by the way the study was set up for crossover. So it's impossible to know what's going on with OS when you have that degree of crossover. So I think we have to be really careful when we look at these types of things. So I think you've seen many of these. I do think that the FDA concerns and the robustness of the data has really pushed PARP use in the front line. And then I think there's a case for it being used later as well, depending on the molecular signature. But I think patients should strongly be considered, especially in all cases of BRCA mutation, in most cases of HRD, and then I think the HRP group is a little more open for debate. So again, I want to thank you so much for having me, and I know we're right about at time, but if we have time for one or two questions, I'm happy to do that and answer anything. So shukran laka. Again, thank you, and any questions I'd be happy to entertain.
Okay, thank you, Dr. Herzog. We are waiting now for questions. However, I will start with one question. Patient with BRCA mutation, they have a very good response to chemotherapy. Should we augment this response by using HIPEC, for example, in the first line, or using IB? What do you think about this?
I don't think the data is there to say that, and I hope we'll have that data soon, and I'd love to know. I think the data that we're doing, where we're going to have the molecular signature on all these patients, will be very powerful from the HOT trial. So I look forward to sharing that data with you at some point. In my opinion, and this is just my opinion, the profoundness of the PARP inhibitors is so great that I don't know if you need to do anything else, frankly. We even saw that when we added Bev to 262. Those patients did very well. I think PARPs are going to be even more impressive for those patients that have a BRCA mutation. I mean, when you have hazard ratios that we're seeing that are 0.3 or less, I don't think you're going to do any better than that. And that's on PFS. And even Van Driel's data wasn't near that impressive in terms of the hazard ratio. It was quite a bit more than double that. So I don't think that the toxicity justifies it. The other concern I would have is if the patient does have any significant side effects that are long-term, it could potentially keep her from getting PARP therapy.
Thank you, Dr. Herzog. What an impressive 3 sets of lectures, especially at 2 a.m. in the morning. That is a lot of stamina after operation. I'll start from the basics. What are your thoughts on giving bevacizumab with dose-dense carboplatin paclitaxel? That's for, not always used, but sometimes we have to use it for elderly, frail patients where we can dose modify. So with the Japanese evidence, what are your thoughts on that?
Yeah, I think I would direct you to GOG 262, where we were allowed to use Bev, and it turned out that most of the patients received Bev. Over 4/5 of them did, over 80%. So I think that for me, if you look at the MITO data, it actually is surprising that, we thought that the weekly data would actually be less toxic, and it really wasn't less toxic. There were some things it was less toxic in, and there was others that was worse in terms of neurotoxicity, for example. So I just tend to go lower on the dose initially with the real elderly patients, and then escalate if they're doing well. And I've been going, and I do use Bev where appropriate. I think Bev is generally pretty well tolerated. I think you have to look for the normal things that are contraindications. But I don't have a problem with using Bev if it's indicated for me, which is those high risk patients, certainly wet cancers where there's a pleural effusion or where there's ascites as well.
We have a question in the audience, but before that, just to follow up, another question, if you don't mind.
Sure.
If you look at breast cancer and using neoadjuvant chemotherapy for those who we get pathological complete responses, there is an overall survival difference. What's happened in ovarian cancer when we do get an R0 resection, there isn't any overall survival benefit. You would say both
overall survival benefit for which group again?
From adjuvant versus neoadjuvant, I'm talking about. So for those patients who we get R0 resection, unlike breast cancer, where we do get if we've got a pathological complete response, there is an overall survival difference. But what has happened? Do we need to do more trials, or what's the way to neoadjuvant treatments?
Yeah. So what we've done, obviously the chorus trial, and the first trial that came out with Vergote. What was interesting is those were done as non-inferiority trials, and what they found was there was no difference. But you're absolutely right. It doesn't take a genius to look at those and say, well, there's no advantage either, which is true. And I think what it does allow you to do, though, is do this in a way that obviously less morbidity and less mortality occur. And that's for sure. That's been documented in those trials. But I have exactly that slide that you just described. So I chuckled when you said it, because I have one of my slides has going, you can see I like a lot of arrows and colors and that, but I had what happens with R0 normally converting to an overall survival advantage. And I have an X going through that with neoadjuvant in ovary. And why that is, we're not sure. One hypothesis was that we don't give enough chemotherapy after the interval debulking. Although there was a group at, I believe, the Mayo Clinic that looked at giving an extra couple cycles, and it didn't show any advantage, but it was a really small study. So I don't know if that's enough to disprove that theory, but that's one of the hypotheses that I know has been generated, is that there's still enough stem cells. I think if we look at circulating tumor cells, which is probably something that you'll see more data on coming up, that we might get a better insight into what might be going on there in terms of the dynamics. But I don't have a solid explanation. I only have hypotheses behind that. But it is an interesting phenomenon. But what I do think is reassuring. So it doesn't actually cast a big shadow on the idea of neoadjuvant, because what it does say is you're going to do just as well generally. Although, we have a couple centers in the US that have argued vehemently that primary cytoreduction in their hands is still far superior to what we've seen with any of the neoadjuvant. And those European trials that were done, the EROTC trial and the chorus trial, really did not have very good outcomes in either of the arms, and they pale in comparison to some of the contemporary aggressive ultra radical resections that are done. And then we have the debates, that go round and round on that. So we'll see.
There's a question in the audience.
Yes, thank you so much for your talk. My question is regarding the rare aspect of, say, here's carcinoma within tumor subtype. For those who are HRD patient, could you consider doing status and site and check for possibility of temporary
I didn't catch all that. Can you paraphrase that real quick for me? I just couldn't hear it. I just can't hear you. Can you repeat it from the podium there?
So I think the question is for these rare aggressive clear cell type and others, is it worth giving immunotherapy? I guess that's the question.
Yeah, we have some data on that it looks like, there's just really small cohorts where we've seen activity. So I think it's completely unclear as the best path forward at this point for clear cell. The other problem is it represents such a small percentage. There hasn't been a tremendous amount of commercial interest in that subgroup. So we're probably going to have to finance that in different ways. So we're doing some investigator-initiated trials through the GOG, and clear cell would be an unmet need. We also have the energy side, which is our National Cancer Institute side that's part of GOG Foundation, So we probably need government money to look at that. As you know, they have a unique set of mutations. So, people have thought about ARID1A, trying to target that pathway. So I think more data is needed on that, but there are some early signals that immunotherapy may be part of the solution.
I think there's one final question, if you don't mind. I know it's very late.
Oh, that's no problem. I feel bad making
excited
your
to have
break
you
short.
here.
For excellent talk. My question regarding now in 2023, for what you are mentioned in the beginning, the first talk, for whom hybrid now in 2023 in ovarian cancer, for whom patients?
So the question is, which patient would you ideally do HIPEC for? Can you, obviously it's not for everybody, would you have a certain cohort, certain subset of patients that would benefit more from HIPEC in 2023?
Yeah. So for me, there's only one phase 3 trial that really shows an advantage at this point. I'm waiting for further data. As you know, there are a couple of other trials out there that are randomized. I think the best one is going to be ours because it's going to be fully molecularly annotated. The HOT trial, GOG 3068. I think that's going to be an exciting trial. And for me, I will do it on trial, but I usually don't do it off trial. I don't think there's enough data to support.
Patients? Would you select specific patients or just?
Well, that's part of the problem with HIPEC. The patients I would select would be the healthiest, strongest, fit, and obviously have a good response to platinum. And those are your patients that are going to live very long anyway. And so, that's been the problem with HIPEC originally, is they have had a lot of single arm studies that said, well, this is much better than historical control. But I can show you subsets of patients from, IP alone. If you look at Deb Armstrong, she's got a series of BRCA patients where, you didn't even know the BRCA status. Now we went back and looked. The number of 10-year survivors out of that group was fantastic, just with IP, no HIPEC. And so, I've seen such polarity. There was a professor at Harvard who spent most of his latter career talking about the ill effects of HIPEC and how toxic it is and how it's not been proven. And the fact that it hasn't, panned out in colon cancer. When it looked very promising and there was much data and much enthusiasm. They were at the same point we were, where they had some small trials that showed positive results and then larger trials that didn't confirm those. So, and to me, until the data comes out showing it, I would do it under the guise of a study. I don't think there's anything wrong with offering HIPEC. I think that has a very good chance of being successful. So I'm not saying it's not going to be successful, but I do think we need more data.
I think reading into Dr. Waleed's mind, his question probably is, would you offer it to patients with more peritoneal disease and less ascites and things like that, disease characteristics, as opposed to just performance status? Or
I don't think we know, because the problem with the Van Driel data is you only have 100 and some patients in that. So by the time you stratify out certain, subsets like that, tumor volume, ascites, large volume ascites, and that subgroups are so small, there's never been any data that's been written about it. So I think we're going to continue to need to look at those things. So I just can't answer the question because there's no data to answer it. It does make sense that in those small peritoneal studying cases, to me, that would be where your real benefit is, where you can directly affect those tumors. We sort of have widespread diffusive disease. You take out the disease that's large volume, and then you do the HIPEC. To me, that's the patient that would most likely benefit.
There's one chat question, and I'm not sure how to put it. It says, can malignancy depend upon race? So you can answer however you interpret this question to be.
Yeah, I think we're learning more and more about diversity, where one of the predictors is race. Social determinants of health we've learned a lot about, and race is certainly one of them. And one of the things that's confounding in this country is that race often correlates with socioeconomic status, which is another determinant of health. And so, yeah, I think you see later stages of malignancy. You may see more malignancy because of diet and health maintenance and screening availability by race and some genetics in some cases. So parsing out all the contributory effects is difficult. And we'll need to continue to do that. Certainly, we're seeing, for example, in endometrial cancer, that there's more cases of serous cancer in our African-American race or Blacks than we see in whites. Yet we see those cancers in whites, and we see lots of endometrioid cancer in Blacks. So it's not. There's a Venn diagram that's very complicated, in my opinion, and I think it's something that obviously, with great sensitivity, we need to continue to explore.
That's very interesting. Actually, we are in the middle of printing something, and we found out exactly same thing: papillary serous and endometrial cancer. And I've looked at the world or USA, statistics, and it's nearly doubled that. So
wow.
So anyway,
yeah, let me know when that's coming out. I'd love to see that.
Yeah, no, it's some dotting the I's and crossing the T's with statistician and
yeah, I'd love to see it though. That's great.
So thank you very much. I think we would say good night to you. A very impressive talk at 2 a.m. Much appreciated, a wealth of knowledge, and then we'd move on to the next session, please. Thank you.
Hope to see you all soon in person. Thank you.
Thanks.
Minutes break.
We will have a 15 minutes break and we'll come back.
This.
Testing. Test. 1, 2, 3, test. One, two, three, test.
السلام عليكم. Can you hear me?
Yes, السلام عليكم دكتور شادي. We are live.
طيب perfect. إن شاء الله. We'll back in 5 minutes.
will be moderated by our colleague, Dr. Shadi Al-Khayyat. He's an associate professor in medicine and oncology from Jeddah. And we have also Dr. Zainab Talal. She's a consultant gynecology oncology from Al-Hassa. And Dr. Muhammad Saitan, consultant medical oncology from Security Forces Hospital. Is Dr. Shadi and the colleagues start the session.
يعطيك العافية دكتور نشمية. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد وصحبه أجمعين. We'll you back to our program, and I will start our pleasure to chair the session. From us, that Dr. Yahya could not for an unavoidable reason, so hopefully things will be fine with him, and inshallah we'll see him back again in the next meeting. So I'd like to congratulate the Dr. Nashmiya and the group in National Guard Hospital for the success in having this annual meeting to get updates, especially with this big group of experts in in gynecological cancer. So our next topic will be the effect of the anti-angiogenesis treatment in ovarian cancer. Our speaker will be Dr. Walid Al-Salawi. Dr. Walid is a consultant medical oncology from King Fahad Specialist Hospital in Dammam. Dr. Walid is a well-known gynae and GI medical oncologist. He has been heavily involved in educational activity and also research. He's the
Thank you, Dr. Thank you, Dr. Shadi. Yeah. Thank you, Dr. Shadi, for introductions, and thank you, Dr. Nashmiya. It's my pleasure. I think that it is a congratulations for you, and this is the 8th meetings, and really we learn a lot, share the update of the annual meetings, and really yesterday we enjoy, and today morning also. I will talk about the role of anti-angiogenesis in ovarian cancer. Prof. Thomas mentions in the morning about the anti-angiogenesis in the ovarian cancer. And this is the all talks regarding anti-angiogenesis in the ovarian cancers. This is the outlines, backgrounds, and first study, and Paula, and then in the relapse. As you know, the ovarian cancer is the most leading cause of death, and that is about 95 patients per year. And this is according to the 2019, about 6.6% of patients death in regards of data in 2018. We try to look for any biomarkers in ovarian cancers. There is signatures, molecular background to help us in the targeted therapy, and that is working a long journey on molecular biomarkers. As you know, there is started with the BRCA testing, and then looking for the HRD and other molecules. As we know, that is the BRCA mutations in ovarian cancers about to start with is only 15%, and then going to the testing depend on the type of the testing. Are we testing the germline or somatic testing? Started by the germline and found about 10 to 27 to 70% of the germline BRCA positive. And then when we're starting to do the somatic mutations and looking for the HRD testing, that about 48 to 50% of the ovarian cancer become positive with HRD testing. And this is how is that About 50% of those patients have somatic mutations and depend on the HRD testing and score test. As mentioned, Prof. Thomas in the morning, that all the guidelines support the idea of the testing, or including the NCCN guidelines, SGO, ASCO, and ISMO. And when every patient has ovarian cancer diagnosis, should be tested. As we restrict only to the high-grade serous carcinoma or clear, that is sometimes we are recommend for all patients high-grade cancer ovarian, and to start from the day one. This is only just to touch about the BRCA testing and scoring, how to look for the patients with the HRD and when to call the HRD gene panel. And there's a lot of genes, and then HRD genomic scarring, and HRD positive meaning BRCA mutated patient or germ score above the threshold of the cutoff. Again, this is the mirrored HRD genomic scarring test, and there is have the score test for BRCA mutations, BRCA mutated, and the genomic scar test above the 42 is considering as positive, and we are considering those patients who has HRD positive or BRCA positive mutations. Then, as you know, the patient's characteristic is very important when we are looking and categorize our patients for the depend on the many factors. One of them is the fitness of the patients, histological subtypes, a burden of the disease, and also if we are going for a neoadjuvant setting, then the reimbursement about the guidelines. This is the unmet need. About 70% of the patient with stage 4 or high grade has a relapse within the 5 years. Survival is only 39%, and that is going how is patients is need some sort of the maintenance therapy. This is, we are seeing that in each meeting in the regards of the first line therapy, and then when he is relapse symptoms, then we are categorize the patient, is he is platinum sensitive disease or platinum resistance or a refractory disease, and how is with each progression of those patients end by the symptoms and become more symptoms and then palliative. What is the things can be changed this journey of those patients by the idea of doing the maintenance strategy. As we know, the angiogenesis therapy, that is the mere rule of the cancer supply of the blood and leading to the metastases. And then have a different forms of the VEGF. There is VEGF B and A and C and D, and most of the bevacizumab is working on the VEGF A, what you call the VEGF2. FDA and EMA approved the bevacizumab in support by the studies in that in the new diagnosed patients, that is EMA and FDA, that's based on the GOG 0218 and ICON-7 to start with before the targeted therapy. Then in the part of the relapsed patients sensitive, there is OCEANS and oral study. In the recurrent disease, the oral study, and in the resistant form, there is a lot of the study. One of those is GOG 2113. Also, we will just brief mentioning. Anything in the maintenance therapy in the first line, that is a journey of the disease to start with. How is the maintenance strategy in general for ovarian cancer from 23 till the now in 2019 and now into 2023? This is the GOG 218 carboplatin-based chemotherapy with platinum, looking for bevacizumab in the first line setting, then maintenance for 12 cycles, and bevacizumab for maintain of the 22 or almost 1 year of therapy. The primary endpoint is progression-free survival, and secondary is overall survival. By the progression-free survival, there is a significant for subgroup of the progression-free survival, and based on that, This is the no difference found when we are collecting all patients and when he looking for subset of the patient with high-grade patients, there is a significant for progression-free survival, but there is no overall survival. But based on the GOG 218, leading to the EMA and FDA approval of the bevacizumab in patients with newly diagnosed ovarian cancer. Another study is ICON 7, is the same, higher stage 1, stage 2 disease, grade 3 with good performance status, and those patients, he has bevacizumab 7.5 milligram with carbopaclitaxel, and then the other group only standard of care chemotherapy, and then maintenance bevacizumab for a total of 12 cycles. The endpoint is progression-free survival, and the secondary endpoint was overall survival. Again, bevacizumab shows significant improvement in the median progression-free survival in high-risk patients. And we see that this curve, how is those patients, meaning of those high-risk patients is get benefit in the first-line setting. But for overall survival, no clear overall survival benefit. There is no overall significant in those patients treated with standard of care versus the chemotherapy. But in the subset of those patient high-risk group, there is a minimal improved of overall survival, but is diluted when he is selected. Based on that, is this support again the GOG 218 from the ICON 7 approval of the bevacizumab in the first-line setting. And both ISMO and NCCN guidelines support the recommendation of using bevacizumab in the first-line setting based on those two trials. Any other of ongoing that study in with area of the targeted agent can be using bevacizumab instead of the PARP inhibitors. As we know, the journey of the PARP inhibitors for almost 50 years, looking for the PARP discovery of those patients from 1960 when start the first study, and the study 19 looking for the PARP inhibitors and for all the tumors, and then going for the more specific for patient with ovarian cancer till 2022, and now the update of patients in the maintenance strategy. Progression-free survival with maintenance placebo, that's the mention of the changing of those patients, around 50% to more than 50% of the patients have a relapse within 1 year of platinum chemotherapy. And patient BFS with maintenance olaparib in solo 1 showing that's clearly progression of those patients. How is progression-free survival? Very clearly separation of the care started from the early ongoing till the end of therapy. This is the just show the studies. I mean, this slide show how is that observations for high-risk group of ovarian cancer is no more one of the strategy for our patient. We should be give some sort of the maintenance therapy for our patients. And when we are talking about who is those patients, low risk, high risk patients, I think those is the high risk patient we know at stage 4 disease, patient with a residual disease, and patient still have a residual disease after the meaning the suboptimal debulking surgery. A low risk group, those patients have no residual disease after surgery or stage 3 disease. Could be using the, we have now GOG 218 and have progression-free survival, and now we have PARP inhibitor as a maintenance, and this is the idea to give combine both PARP inhibitors with bevacizumab, and this is the going to the BAULA-1 study, and BAULA-1 is a maintenance olaparib plus bevacizumab after the standard of care chemotherapy protocol for a patient with newly diagnosed ovarian cancer who have BR or CR after upfront or interval surgery, then maintenance and then given adjuvant chemotherapy, then maintain those patients with olaparib 300 milligram and for 2 years, and bevacizumab 15 milligram per kg for 15 months. And the another arm is the standard, only just going with the chemotherapy, then maintenance bevacizumab. Paula 1 progression-free survival, seeing that is very significant, clearly separation of the care for a combination olaparib bevacizumab with median is 22 months compared with 16 with placebo with bevacizumab, and median time of the first cycle from the chemotherapy was 7 months. Approximately 50% of the patient high-grade ovarian cancer have alterations of the HRD gene changing. And that's seeing how the HR repair happening, and that those patients, how is those significant response to the PARP inhibitors, that is HRD deficient or the HRA proficient, and some of this alteration in between those patients who didn't respond well to the PARP inhibition, especially those patients with cyclin E1 amplifications. That's around 15% of the patients who didn't doing well with PARP inhibitors. And we know those patients with BRCA mutated have the more sensitive to the PARP inhibitors. Again, HRD patient is more again sensitive and responding to the PARP inhibitors. For that, each patient from ovarian cancer, we must do the HRD testing. And this is by the analysis of the Paula 1 progression-free survival based on the HRD status. If you see the first cartoon seeing that slide, HRD positive, including BRCA mutated patient, very significant median progression-free survival is 37 months compared with 17 months in the standard bevacizumab alone without combinations. If we go to the HRD positive, excluding BRCA mutations, again with median progression-free survival 28 months compared with 16 months. Again, significant hazard ratio is 0.4. What about HRD negative or unknown? If you see the median progression, again 16 months in both groups. For both groups, the HRD positive, including BRCA mutated and HRD not BRCA mutated, very significant with very significant hazard ratio 0.3. When we are looking for those in the Paula study subgroup analysis for patient based on the staging for high risk and low risk, if you look for the high risk group, again is in the combination maintenance therapy, HR hazard ratio was about 0.6 with median progression-free survival 20 months compared with 14 months with a significant of almost 6 months. If we go to the low risk again, median progression-free survival is 39 in the combination group with bevacizumab alone is 22. Both arms, if you see the curve again, is the same with high risk, meaning in both arms, in the high risk and low risk, there is a significant progression with very significant hazard ratio is 0.4 and 0.6. If we just only, this is not study comparable, only just to show how is those patients with different study. We have Solo 1, Brema, and also Paula 1. If you look for all of this trial in PARP inhibitors as a maintenance strategy, there is in the median progression-free survival in the Solo 1 is almost 56 months compared with 13 months. In Brema also 22 compared with 10. That is just to continue off about our strategy for maintenance therapy. In Paula, again, 37 compared with 21 months with very significant p-value, and only hazard ratio, if you see in the 3 studies, 0.3 and 0.4 in the Prima and 0.3 in Paula 1. And progression-free survival in the PARP with HRD ovarian cancer, if we see the both study, again 21 months compared with 10 months is almost double with a maintenance strategy. In the Paula 1, 37 compared with 17 with very significant progression-free survival and hazard ratio on 0.4 and 0.3 in Paula 1. And this is all the study we compared that GOG 218 and seeing that how is the median progression-free survival 15 compared with 10 and hazard ratio 0.7 with this is improved in patient with there is no HRD data for those patients. In Prima also it's the same, very significant p-value with hazard ratio 0.6 and also Paula 1. And when we go to the stage, is translate the same strategy. If in the first line setting, Paula the prime, and seeing how is those patients is compared for both group with HRD positive patient and in the both group. What about the side effect? As you know, this is the class side effect, with including the GI toxicity, mild nausea, vomiting, and hypertension. And most of those patients sometimes have fatigue, and the most important of those of fatigue. In any addition of those, by the thing that adding the bevacizumab to the PARP inhibitors are any affecting on the quality of life. If we are looking for this slide, in the Paula one, he do study and element of the quality of life, saying that adding bevacizumab to the PARP inhibitors, olaparib in this study, it didn't affect the quality of life. This is the ESMO, the last year on about the update of the Paula one in the ESMO. And again, this is the 5 years overall response rate compared to 47 compared to 41, with about 5 years, 47 compared to 41. This very median time from the first cycle was about 6 months. And final overall response for the Paula one overall survival in HRD positive patient, you see that at the 5 years, about those patients 65% compared with 48%. The median overall survival 75 months compared with 57 months, with combination as a maintenance strategy Bev with olaparib. Again, final results from those Paula 1 BFS in HRD positive group, same with very significant 47 compared with 17 months, with hazard ratio 0.4. Again, translate the same class effect and adding BEV to the olaparib in subset of those patients high grade ovarian cancer, HRD positive. I'm just mentioning this for bevacizumab in the recurrent ovarian cancer. As you know, depend on GOG 213 and OCEAN study, oral study, all of those in the recurrent setting of the ovarian cancer. And again, any other know that anti-angiogenesis therapy, there is the phase 2 study, sidranib with combined with olaparib in patients with relapsed ovarian cancer. This is a phase 2 study in both groups, BRCA mutant patient and BRCA wild type patient. Again, seeing there is significant benefit for adding sidranib to the olaparib as a combination therapy. And any rule about the also niraparib with bevacizumab in the ovarian cancer in both group BRCA mutated and BRCA wild type. This is saying that there is a synergistic effect in the adding bevacizumab to the olaparib in those patients with ovarian cancer. Now, what is available systemic treatment for our patients, as Prof. Thomas is mentioned in the early morning, how to be as an oncologist, as a surgical oncology, how to be looking for our patients, depend on the decision from the first, as we will go for the neoadjuvant therapy to start with, and then if we go for the neoadjuvant therapy, then we go to give our patient bevacizumab. And as we know, to add bevacizumab in the neoadjuvant setting, we are not doing that much in our patient, but some we are selected, and this patient is not in the first line setting, is non-debulkable. We start with bevacizumab, then become excellent response, then maintenance. Then the third decision, if patient who has bevacizumab or not, to go for the maintenance strategy based on what is the molecular makeup of this patient. If he's BRCA mutated, and we can be add PARP inhibitors to the bevacizumab based on the Paula one, or only just we use the solo one trial or PRIMA study, or can be add both in both group, or just we are maintain our patient for HRD unknown, and that is very rare now, because we have every patient, we should be know the status of our patient to go with a maintenance bevacizumab alone, as by GOG 218, ICON 7, or GOG 262. In summary, bevacizumab is active in the setting of ovarian cancer. and also show very effective in the BRCA mutated patients. And again, it have additive and synergistic effect when combine both group and olaparib plus bevacizumab to lead to the improved progression-free survival. And also olaparib alone is a maintenance strategy for a selected patient. In those patients, we have to know the HRD status to guide our treatment strategy. Thank you.
Well, thank you, Dr. Walid, for this elegant review and all the information you mentioned. I'm sorry that I'm not physically there, but we'll see if there's any question come there. However, just as a question, because this is the common question we get in the practice right now, we have two efficient mechanisms how we can attack these cancer cells with the PARP as majority of these patients. Now they're receiving PARP inhibitors and an anti-angiogenesis factors. So do you think the study trials that we have so far can answer the question which patient should receive anti-angiogenesis plus PARP inhibitors, or still we need further study to decide about that instead of going PARP alone or PARP plus anti-angiogenesis?
Thank you, Dr. Shadi. I think that is very elegant questions regarding how to be used. As you know, I think we saw very clear benefit for those patients who have HRD positive status. If you know the HRD status, and then we know to these patients is response to the PARP or to combinations. Is we are using combine both for all patients, I think it's not that. If we are using bevacizumab in the adjuvant setting, I think this is the wise to add Bev and PARP inhibitors as a strategy as Paula 1 protocol. If patients didn't receive bevacizumab in the first line setting, I will maintain on alone on PARP inhibitors. As we know, those patients, especially patients present with ascites, high burden of disease, I think those and HRD positive patient, it is those patients is most likely is gain positive with very significant. If you see Paula 1 is very significant progression-free survival, and even the update with 5 years. And as you show, there is no that effect on the quality of life with both combination. But we should be select our patients.
Good morning.
Dr. Mohammed, from your side, do you have any question, or Dr. Zainab?
Thank you.
I don't think anyone is raising his hand. I'm not sure about if there is anyone in the attendees.
Well, there's one question, Dr. Walid, about the role of bevacizumab in recurrent platinum-resistant ovarian cancer.
Yes, those patients, as you know, recurrent disease has a bad disease. We are trying to use all the things we are available, usually single agent chemotherapy, looking again, as we know, the Orilla study combined bevacizumab and GOG 213, also using of bevacizumab in those subset of patients with recurrence platinum resistance.
If you allow me, Dr. Hayat. So thank you, Dr. Walid. So do you use bevacizumab in all first-line maintenance if they are HRD proficient?
Thank you, Mohammed. For patients, if we are using the bevacizumab in the upfront, I will maintain and HRD positive. If he didn't, HRD positive, we select patients is a burden of the disease, and we are looking is high risk, low risk of patients. We can only just maintain on PARP inhibitor single agent for a selected patient, high burden disease, high risk patients, ascites. Those patients is get benefit HRD positive. We maintain both Bev and olaparib.
I mean, if they are HRD negative, HR proficient, we know that GOG 218, they get the overall survival in the post-hook was only for those with ascites and stage 4.
Yeah.
So is this your practice, or you are using your PARP inhibitor, for example, niraparib, since it was positive in all intention to treat?
Yeah, thank you, Mohammed. I think that's very important. In those patients with HRD negative, we know we are not using those much unless that bevacizumab is ascites. I will use bevacizumab, and we know those patients doing well even with bevacizumab. Adding olaparib, if those patients, as you know, now not only olaparib, now we can look for era of the niraparib. We can use niraparib regardless of the stat, but still this is the era of combination both. No, we have to very select patients for a combination, especially for what you call the maintenance strategy. It's not all comers. I will use it bevacizumab and PARP inhibitors.
Thank you, Dr. Walid.
Thank you.
Any more questions we have?
I can't see any hands in the audience.
I think if there is no more questions, we will conclude this session. I want to thank Dr. Walid again, since he's a regular in the program. And I want to thank Dr. Nashmi and the organizing committee and congratulate them for their great effort and yearly update they provide us. Thank you so much.
Okay, Dr. Nashmiya, we are back to you for the satellite symposium.
All right, so first I would like to thank AstraZeneca for the kind invitation, and I would like to introduce Prof. Christian Mart, who is head department of obstetrics and gynecology in Innsbruck, Austria. He's also a professor in Innsbruck Medical University. He's as well as the president of Austrian Study Center for Gynecology and Gynecology Oncology. Prof. Christian, you could kindly start your session, please.
So, do you see my my slides?
Yes, it's clear.
Okay. And do you see my mouse too?
Yes.
Yes.
Okay, great. So yeah, thank you very much for the very kind invitation. It's a great pleasure for me to be here today with you and to discuss bevacizumab and olaparib in ovarian cancer management. I'm from Innsbruck, a gynecologist. You see here where the hospital is located in the very beautiful landscape and a lot of mountains behind. Sorry, any problems?
Hold on, we have some technical issue. 1 second.
Okay, should I wait?
它现在我们的运营能力是一个问题啊，所以在这块的话，正好两个都落在跟 BC 重点工作也是匹配的啊。然后同时呢，再补一嘴，就是这个关于这个5G ready 这个事儿，是吧？特别赞同刚才孟总谈的，就是永远是4066，对吧？我们其实今年从去年下半年开始，就是这个在华总的这个带领下，我们把整个这个 ScanPark 也作为一个样板。特别是区域EM市场，对吧？引进的那个做一个专题的分析啊，这块的话，我们的目标是一致的，然后我们必须给我支持好啊。
Sorry.
Yes, Prof. Christian, I think we are okay now. You can continue.
So I will start again, maybe, huh?
Yes, please.
Okay. Yeah, thank you very much again for the very kind invitation. My name is Christian Mart. I'm a gynecologist from Innsbruck Medical University. And you see here where the hospital is located in Innsbruck city, which is very famous for organizing twice the Winter Olympic Games. This is my disclosure information. When we look back at the evolution of ovarian cancer first-line treatment, for decades we had only carboplatin, paclitaxel. Then, but 2011, bevacizumab arrived first in Europe, later in the FDA, and only 2018, olaparib has been introduced at the beginning only for BRCA mutated patient, and later on, niraparib and olaparib in combination with bevacizumab arrived. And this completely changed our landscape and paradigm in the treatment of ovarian cancer. First, in a historical view, we had the debulking surgery, we did the chemotherapy, and then we had to wait, and we had only watch and wait, and we had to wait that the recurrence was coming. Then by the introduction of bevacizumab, we were able to delay this recurrence and to reduce the growth of the tumor nodules. But now with also the introduction of the PARP inhibitor, this maintenance dramatically increased the response and the duration of remission in ovarian cancer patient. And also angiogenesis is very important. I made this image a couple of months ago, a patient with a carcinomatosis, and what you easily see is how the blood vessels are going into the peritoneal lesion to bring nutrients in. So angiogenesis is a very important step and important factor in ovarian cancer. And we know that especially VEGF is important for the switch from benign to malignant growth pattern. We know that ascites is mainly driven by the increased peritoneal blood vessel permeability, and also the formation of metastasis in the peritoneal cavity is driven and regulated by VEGF. We understand that VEGF is involved in the epithelial mesenchymal transition. It's involved in the adhesion, in the neovascularization, and these all are crucial effects for the development of ovarian cancer. More than that, and more recently, we understood also that VEGF is also involved in the immune suppression. We know that, for example, the invasion of deregulatory cells, which are immune suppressing, are increased by VEGF. We understand that the dendritic cell maturation and antigen presentation is reduced in the presence of VEGF, and also CD8 immune cell T cell function is also regulated by the activity of VEGF. So altogether, we understand that angiogenesis is a role. We published recently in the GyneOnco this in the last issue, also that the antigenic phenotype is really associated with prognosis. Those with high VEGF alpha expression, those we constructed and score. I will not go more into detail. We measured the different angiogenesis factors, and it's obvious that both progression-free survival and overall survival is dependent on this angiogenesis. And when we look also, and we took out the data from the ICON-7, and we validated our angiogenesis score in those patients. And what you see is that those patients with a high angiogenesis, especially VEGF angiogenesis score, have an impact by the addition of bevacizumab. So maybe not all patients have a benefit by BEV, but there are subgroups of those which have a benefit. And it's important to mention, therefore, that this not only bevacizumab, but almost all anti-angiogenic agents which has been tested, nintedanib, trebaranib, pazopanib, showed an PFS improvement. On the other hand, regarding overall survival, in the intention to treat population, there was no difference. We know that the two most important studies, the GOG 218 and the ICON-7, both unanimously showed a good prolongation of progression-free survival with hazard ratios approximately 0.7 and 0.87. But for the intention to treat population, there were no improvement in overall survival. However, when we look on high-risk subgroups, for example, stage 4, or in the ICON 7 high-risk group, which is a summary of those with high residual disease, stage 4, those patients never operated. Again, you see also an overall survival improvement. We published last year real-world data in Europe about the use of bevacizumab. First of all, what we see is that those patients with no residual disease are rarely treated with bevacizumab. You see that 70% of those patients without residual disease don't get BEV in Europe. But when we looked on the overall survival, and I think that's really more than 1,000 patients, we see that 30% of patients were treated with BEV altogether. There is a major difference between countries, and the majority had, as I said, the residual disease. But when we look on overall survival in this real-world data, you see that there's a significant difference. So how do we explain that in the clinical trials? We don't see this, but we see it in real-world data. Yes, when we did a more accurate analysis, and we hope to present the data this year at ASCO, we submitted an abstract. What we saw is that in the real world, you have much more patients never undergoing surgery, much more patients with neoadjuvant chemotherapy, with more residual disease. So in the clinical trials, you might have a selection of the better patients. And here in the real world, you see that indeed the addition of bevacizumab, and all those patients were treated before PARP inhibitors were available. You see that there is a possibility. Another point, how can we predict the patient who might get the best outcome from bevacizumab treatment? You all know the Kalin factor, which is the kinetic of CH12/5, and those with a very good favorable Kalin, meaning predicting a good response to carboplatin paclitaxel. You see that there is no difference between chemo versus chemo plus BEV, but those patients with an unfavorable Kalin, meaning that those patients don't respond very well to chemo, you see that there is a significant difference in overall survival. And this might cause the selection. And Nakai et al. Published recently a meta-analysis, and what he also described here, when we look on overall survival and the role of bevacizumab, you see maybe a small increment, but it's not really clinically significant. But if you distinguish the population in those with a short overall survival and those with a long overall survival, you see for those patients with a short overall survival, there is a significant improvement in overall survival, which is not seen for those patients with a long overall survival. So there is also no doubt that in our last ESMO-ASCO guideline, bevacizumab has been included as a standard of care in those patients treated with carboplatin paclitaxel with a level of evidence of 1 and the rate of recommendation of A. So, yes, any problem? No. So there is no doubt that the addition of bevacizumab plays a major role in ovarian cancer treatment. But still we have a problem that we see a median progression-free survival of only 11 to 19 months. We know that the majority of patients still relapse within 3 years of treatment, and the 5-year overall survival rate was in this area, looking especially GOG218, only 38%. So what we need is an improvement in the outcome of ovarian cancer. And I think one of the major steps forward was recent introduction of PARP inhibitor frontline. And we have now 4 clinical trials all together telling us that for those patients with a BRCA mutation, there is a major impact by the by maintenance therapy with PARP inhibitor. The hazard ratios ranged between 0.31 to 0.40. So that's really amazing. But also for those patients with an HRD positive with a homologous recombination deficiency, you see again very similar efficacy with hazard ratios of 0.43 to 0.58 for niraparib, olaparib, and rucaparib. The first most important trial which has introduced a PARP inhibitor in ovarian cancer treatment was no doubt the SOLO-1 trial. And in this, only patients with a BRCA mutation have been included. All patients were treated with carboplatin paclitaxel, and then they have been randomized in the maintenance phase between olaparib and placebo. And these are the results which are really fantastic. You see that after 5 years, there is a major difference, although the treatment was kept after 2 years. So you see that the PFS curves are separating, and still after 5 years, we have 21 progression-free in the placebo compared to 48 progression-free in the control arm with a hazard ratio of 0.33. And this effect is found in all risk groups. And I think it's important to mention that we cannot avoid surgery, because the best what you see is for those with an olaparib followed by an upfront surgery with the best outcome. And if we are going for neoadjuvant chemotherapy, and this does the good effect of PARP inhibitor of olaparib does not replace a good surgery. And it is, as you can see here, also in the low risk population, there is a major difference between the activity of PARP compared to the control arm. One important factor is we are used in oncology and in ovarian cancer treatment to see these banana effects. You see a prolongation of progression-free survival, but in the end of the day, the curves are coming together. And this is really the new era. In SOLO-1, we saw the first time really no banana effect. So the effect is also after completion of therapy is maintained. That's something different what we see maybe in BEF, where you see that when you stop the treatment, the disease might come back. And this prolongation, progression-free survival has also been confirmed in last year by Paul Di Silvestro, also a prolongation in overall survival. So 67% of olaparib patients are alive at 7 years compared to 47% of placebo. So this is really a major improvement. And the toxicity is something which is manageable. And also what we all feared was a very long-term toxicity. And since we are blocking DNA repair, we all were worried that we might see a lot of secondary malignancies, but only 3 cases of MDS AML have been reported in the primary data cutoff with no additional cases after an additional 2 years follow-up. So the therapy is also safe on the long term. The next trial I would like to discuss with you, and I think that's also the question we are raising, is the PAOLA-1, the ENGOT OV25. In this trial, again, patients with stage 3, 4 ovarian cancer have been enrolled, and they got what in Europe is the standard of care for those patients, platinum-based therapy, taxane-based therapy, plus bevacizumab. And the patients, after achieving and completing their first-line chemotherapy with no evidence of disease, complete response, partial response, then have been randomized to continuing with bevacizumab plus olaparib or continuing bevacizumab plus placebo. And you all know the data, PFS really, really impressive. We see for those patients which are HRD positive, including the BRCA mutated patients, you see a hazard ratio of 0.33, a major impact in progression-free survival. The same was seen for HRD positive, excluding those with a BRCA mutation, but there is obvious no effect in the HRD negative population. I think that is something which is really important, and this is really what we are saying now, personalized medicine. This means that we have to test for HRD to avoid to treat the patient with a toxic product without any effect. The overall survival analysis has been presented recently. It is now under evaluation for publication. What we see is that in the intention to treat analysis, there was only a 6% difference, which was not statistically significant. But if we look only on those patients with HRD positive, including the BRCA mutated patient, then you see that there is a hazard ratio of 0.62. There is a gain of overall survival from 48 to 65% after 5 years. This is statistically significant and also, in my mind, also clinically very meaningful improvement of overall survival by the addition of olaparib to carboplatin, paclitaxel, and bevacizumab. This is confirmed when you look on overall survival for the BRCA mute. This is also confirmed for the HRD positive, excluding the BRCA mute. And here again, for HRD negative, there is no benefit. So you see in the BRCA mute an improvement of 19%. That's really a major effect. A 10% gain in overall survival for the HRD positive, excluding BRCA mute, and there is no effect in the HRD negative. You see -6%. This is something which is really we should have a look for, but it's important for coming from this data. We have to test for HRD. Again, toxicity, no major new events on MDS AML. So also this toxicity is really something which is manageable. A major question now is we have now two possibilities. We have olaparib plus bev, and we have also the trial which used bev-free, including niraparib, and therefore there are no direct comparison. And therefore, it was the aim of our analysis to look, can we compare those by population-adjusted analysis, including the PAOLA-1 and the PRIMA trials. So when we compare PAOLA-1 with PRIMA, we have on one side a different population. In PRIMA, you have more high-risk patients with visible residual disease after primary debulking surgery, more inoperable patients. So that was a really high-risk population with a very good response to platinum-based, with a 90% reduction of the CH12 level. And there are some differences, so it's not possible to compare both trials in a simple way. And therefore, a more complicated analysis has been performed. And from the PAOLA patient, a subset was selected of patients who would be eligible for the PRIMA trial. And then a propensity score rating has been performed to build up a new trial and do this analysis and to compare from the PAOLA-1 population the PRIMA eligible subset, and then compare those patients who might from the PAOLA who enrolled in PRIMA, compare this with the PRIMA cohort. And these are now the findings. And I think regarding PFS, it's very interesting what we see, that the best progression-free survival in this group was found for olaparib plus bevacizumab. The second group was bevacizumab alone and niraparib alone, and the worst one was obviously those patients who got only placebo. When we look more in detail, what we see here that there is a major difference. As expected, the addition of olaparib to bevacizumab results in a hazard ratio of 0.6. So there is a clear addition. This is what the PAOLA-1 showed. When we look, however, on the comparison between bevacizumab versus niraparib, you see that both substances are active, but there is no major difference. And we look now and compare olaparib plus bev versus niraparib. You see that this combination is better in this subset of group than niraparib alone. So summing up, what we can say is that olaparib added to bevacizumab showed the maximum treatment benefit in delaying PFS compared to niraparib monotherapy. And niraparib monotherapy showed better treatment outcomes compared to bev in the HRD positive patients, but the effects were equivalent in biomarker unselected patients. So that's again important. So niraparib is a good option for HRD positive, but for HRD negative, bev was even superior. In HRD negative patient, treatment with bev seemed to have superior efficacy over niraparib alone. So BRCA mutation and genomic instability testing are an important part of treatment decisions for both olaparib added to bev and niraparib monotherapy. This was our conclusion. When we look now on the nowadays algorithm, I think when we have an ovarian cancer patient, first of all, we should test for BRCA, somatic germline, tumor testing is important. And then we have the first decision point we have is not BRCA, is not bev. The first question we have, should we go for primary debulking surgery or should we use neoadjuvant chemotherapy? If we made this decision, the next point again is not PARP. The next point is, should we add bev or no? Because if we think for some patients undergoing neoadjuvant chemotherapy, some of them never might be operated because they have such a huge amount of tumor that we never go into debulking surgery. And here, those patients have a great benefit by the addition of bev. So in our hand, we have to make the second decision whether we use bev. And then the second decision is, should we give in the maintenance phase after primary, finishing the primary chemotherapy, the first-line therapy, should we give PARP inhibitor? And then we have two groups of patients. We have one without bev, and there we have one which are BRCA mutated or HRD positive. We have those trials telling us that you can give a PARP inhibitor as maintenance. And for the HRD negative, you might add niraparib according to the PRIMA trial. For those having bevacizumab, we at the moment have the possibility, if we add HRD positive, we can add olaparib and give according to the PAOLA-1 trial. For those which are HRD negative, we would not treat those patients anymore with PARP inhibitor, but we would continue with bev according to the trials I have mentioned. So I think what we are really improving, and one of the most important steps forward was really the final result of PAOLA-1 that showed that despite 50% of patients in the control arm were receiving a PARP inhibitor post-progression, the addition of maintenance olaparib to bevacizumab provided a clinical meaningful overall survival benefit in patients who were HRD positive. I think that's a very important mention. And this clinically meaningful benefit was observed in HRD positive patients regardless of BRCA mute status. So it's not only the BRCA mutated patients who have a benefit, but we should not use negative patients. No new safety signals were observed with longer-term follow-up. That's also something which is really encouraging. And these data confirm that the addition of olaparib to bevacizumab as a standard of care for HRD-positive patients in this setting, and the importance of precision medicine and biomarker testing to guide treatment decisions. And with this picture from the area of Innsbruck, I would like to thank you very much for your attention. I'm happy to get your questions.
Thank you, Prof. Christian. This was a very informative presentation. First, I would like to echo you with that there is no more banana effect in the era of PARP inhibitor. And my first question to you would be, after deciding on primary versus interval debulking and whether we are going to use bevacizumab, what is your current preference when it comes to patient with HRD deficient BRCA mutated patients? Do you offer the combination or do you offer the PARP inhibitor alone as Bersolo 1?
Yeah, we are treating the patient with BEV because in the clinical trial, in Solo 1, the patients have been enrolled after completion of primary treatment. So some of them might not have this complete response, the good response. Some of them will then never get the PARP inhibitor. And I think it's our principle is to give the best first. And before we can start with a PARP inhibitor, the best first is the addition of bevacizumab. So there is a group of patients, although they are BRCA mute, they might not get a PARP inhibitor afterwards because they are progressing. And so they could have on that side a benefit if we treat them with bevacizumab.
Okay, excellent. So the second question would be for those with homologous recombination proficient HRD negative patients. We know that currently we have the options of niraparib or bevacizumab in high-risk population. So what is your current preference and how do you practice?
I think it's when we look on the PRIMA trial and when we have a patient with a lot of residual disease, with an outstanding response to carboplatin paclitaxel. And you see that this is really platinum responsive, highly platinum responsive patient. Then you can think about treat this patient also with niraparib, despite the patient is HRD negative. But otherwise, if there is no very good response, we prefer BEV. And for all those patients, for example, with ascites, we prefer anyhow than BEV over the addition of niraparib or over treating with niraparib. And I think our analysis clearly demonstrated this niraparib is effective in HRD negative, but it's only a subgroup of patients. And therefore, on average, BEV might be superior to niraparib.
Excellent, Prof. So I'm not sure if there is any question from the audience. Let me see the chat box. Seems there are no questions, but let me ask one more question, Prof. Christian. So when it comes to HRD deficient patients whom are BRCA wild type, we know from your cross-trial comparison between the PRIMA and the PAOLA 1 that most likely the combination is more potent. However, cross-trial comparison are not really a strong evidence. So would you should we practice a doublet of PARP inhibitor with anti-VEGF for all of our patients whom are HRD deficient, or still do you believe that a PARP inhibitor alone is a good option to go with?
No. For HRD deficient patient, I think the evidence, for me, it's very clear that the addition of BEV is something which really improves the outcome. The first patient you mentioned, if you have a patient with a BRCA mutation there, you might think to avoid BEV because of the good outcome. But as I mentioned, there is a subgroup of patients who then, if you treat them only with carboplatin paclitaxel, they will never get PARP because they're progressing before. But otherwise, for the HRD positive, the efficacy of PARP inhibitor is not as good as in the BRCA mute patients, and there is a subgroup of patients who might not have a benefit from PARP, and they will get the benefit from maybe from BEF. So, as I said, the best first, and we treat them before. And I'm living in a country in Austria where we are a little bit lucky because we can also use BEF off-label, so we can use multiple lines, and we don't need to spare BEF for later lines. We can retreat the patient according to the MITO-MANGO trial also in a recurrent situation. So therefore, in some countries you can use BEF only once in the life, and then you might think about this. But the best combination first, and especially the toxicity of the combo olaparib plus BEF is not so bad, as it's very easy to use, and there is no major toxicity compared to PARP only. I think it's something which we are really used to. So my favorite, no doubt, is to use the combo, the best data we have available.
Excellent, Prof. So since you are favoring the doublet in combination with BEV, what would be your option for the second line maintenance and recurrent platinum sensitive in such patient?
Yeah, in the platinum sensitive patient, we would treat them with carboplatin, pegylated liposomal doxorubicin, and we would add again bevacizumab. So sometimes the patients are still under BEF, and when they are recurring, we are only changing the chemotherapy backbone, but the patient stays on BEF. So the argument is that when we are treating with cytotoxic agents, when we are treating with PARP inhibitors, we are treating direct the tumor, and the tumor has a higher mutational activity and can develop resistance. If we're treating with BEF, we're not treating direct the tumor, we are treating the stroma. And the stroma cannot adapt as easy as a tumor. And therefore, for me, it was not a surprise that in the MITO-MANGO trial, we saw that also a retreatment with BEF was effective. And even those progressing during BEF, by changing the chemo backbone, showed a better outcome if BEF was continued. So we are treating the stroma, and the stroma does not develop as rapid resistance against bevacizumab compared to a tumor, which is adaptive and might develop a platinum resistance, PARP resistance.
All right, thank you, Prof. Christian, and I believe there are no further questions. We can end the session.
Thank you very much for the invitation. It was a pleasure to be with you.
The morning session now, that balance prayer time, will be back at 4:00. The next one.
Assalamu alaikum. We'll be back after the break, lunch and prayer time. Meanwhile, we would like to remind you that to get your own CME, you should be attending the 2 whole days, and you should be eligible for these CMEs as per your specialty in the Saudi Council. For those who attended the 2 full days, we will be sending you an email today or tomorrow to evaluate the event. And after that, you will get your CMEs. We'll be sending your details to get the CMEs, and the final decision is for the Saudi Council. We wish you an informative, knowledgeable event, and we encourage you all to post your question in the Q&A box for the speakers. And don't forget to follow us on Twitter, Facebook, Telegram, YouTube to stay updated about the upcoming events, and also to check our website, oncologyevents.info, where you can find a lot of events where you can register yourself in, and you can find a lot of resources that's useful for the oncologist and other healthcare providers, and also you'll find information about the CMEs and how to get it. Thank you all. We'll be back soon. We will start in a few seconds, in a few minutes.
خلاص تمام. السلام عليكم. تيستينج. كويس. اوطي صوتي؟ لازم صحيهم بعد.
الله يخليك تفضل. هذا البروف جاي.
العالم كله خالد الوادي، دكتور عبد العزيز العبيد، يعني غنى التحرير، دكتور حسام صباح، دكتور حسام سليمان. والله انا اتشرف صراحه.
الله لا لا والله ما
لا عشان ما قلت شيء.
معك معك.
Assalamu alaikum. We'll start our afternoon session. This session will be about the uterine malignancy. It's my pleasure to introduce our colleague who will moderate this session. We have Dr. Bassam Bas Suleiman. He's a consultant medical oncologist from King Fahd Medical City. Dr. Khalid Al-Wadi, he's consultant gynecology from King Fahd Medical City. Dr. Hassan Sabbagh, consultant and division head gynecology from Prince Sultan Military Hospital. And also we have Dr. Abdulaziz Al-Ubaid, consultant gynecology-oncologist from Riyadh Care Hospital. Start this.
Yeah. Hello, everyone. Hello. Yes. Hello. Yeah. Good. Thanks, Dr. Nashmiya. And I would like to congratulate you for this successful event, and we'll start our session for uterine cancer today. So from the beginning, I would like the starting of this session. Our first talk will be about the frontline treatment of endometrial cancer. It will be presented by Dr. Mazen Ba'adim. Dr. Mazen Ba'adim is well-known gyne-oncologist working at King Fahd Medical Oncology, and he is also the clinical assistant professor at King Khalid University Hospital. So Welcome, Dr. Mazen.
Thank you very much, Jan. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين. First, I would like to thank the organizing committee for the invitation. And second thing is I'm very lucky to present after lunch, so I can get away with anything I can say. Okay. So I don't have anything to disclose. We're going to talk about frontline treatment of endometrial cancer, which is a well-known topic. As you know, there are many treatment options as a frontline treatment for endometrial cancer, whether it's surgery, fertility preservation, surgery followed by adjuvant treatment that is tailored by either chemotherapy or radiation, neoadjuvant chemo followed by surgery or adjuvant treatment, or it could be even just a primary radiotherapy or palliative treatment. But we all know by now that surgery is the cornerstone for management of endometrial cancer. So I wanted to take this, I didn't want to talk about surgery by itself. I want to take this presentation to shed light on some of the challenging topic that we can face in our practice that can guide us, hopefully. And it's a learning process. I wanted to learn from you guys, and I want to just shed light on these challenging situations. So I divided my talk into 4 topics that I'm going to speak about. So first thing, as we know, the biomarker effects now, that is well-established data about how efficient they are in terms of stratifying the risk of our patient and guided our adjuvant treatment. But the question, can we use them for frontline therapy or no? The second thing, I'm going to talk about minimally invasive surgery in high-grade endometrial cancer, and this is an interesting topic that was raised a couple of weeks ago in one of our tumor boards. So I just wanted to just refresh our knowledge and shed light on that. And then radical hysterectomy for grade 2. These are all for early stage. For advanced stage, I wanted to just visit the importance of surgery in these kind of patients. So we're going to start with the preoperative biomarker. Would it actually change our management as a frontline treatment for endometrial cancer or no? So as we all know now, you can't even go to any conference or you can't talk about endometrial cancer without talking about the biomarker and how important they are in terms of stratifying the patients. The evidence is accumulating, and these molecular testing have a very, very important value in the prognosis for our patient. But the problem is all these risk stratification are actually based on post-operative histological evaluation. So when you go to the surgery, you don't know what you're facing. So because all of these biomarkers are actually based on testing post-operative specimens rather than from the diagnosis. So the real question is now, how representative is the endometrial sample of these biomarkers? And can we rely on endometrial cancer to actually change our management but just based on the biopsy? So these are some of the basic genetic alternation or biomarker that's used in endometrial cancer. There are many, but these are the 4 markers who are the most important that is actually changes the outcome for endometrial cancer. The most important one is B53. And as we can tell from post-hoc analysis of PORTIC3 trials, that BOL mutation, and B53 are the most important prognostic value for endometrial cancer. But the good news is when we test the B53 mutation based on the curettage sample or endometrial biopsy, they do even have the same difference in the survival according just to the endometrial biopsy. So that could lead us in the coming couple of years to actually stratify our surgical intervention based on this mutation. But of course, we will have to accumulate more data and more studies into how different will our surgery be based on the B53 mutation. So in other words, if a patient has a curettage sample with a B53 negative and have some high risks, so I would be able to avoid doing the extensive surgery and lymph node dissection.
The second most important factor as well is the hormone receptor. It's very easy actually to be tested. And again, it shows the same difference in the survival between curettage sample. These actually two diagrams for PR and ER receptors based on the curettage only. And as you can see, survival according to the expression of the estrogen receptor and progesterone is actually excellent representation of the actual specimen after the complete hysterectomy. HER2/neu is an increased level of HER2/neu receptor associated with poor survival in endometrial cancer, and it has an important role. But for HER2, it's actually its role is mainly for high-risk endometrial cancer or high-grade endometrial cancer, which luckily they are not the most of our cases. Unfortunately, when we looked at the HER2 receptor status based on curettage sample, there was no difference, actually, no survival difference between the samples. And this might reflect that the curettage sample could not be very much representative of HER2. And maybe more studies actually are needed in that area to establish the role of HER2 in endometrial cancer. So as of now, we can't actually rely on endometrial sampling for HER2 status. So statamine is actually a new molecular or biomarker, and is an oncoprotein. It is actually in curettage. It could be actually used as an independent predictor for lymph node metastasis and poor survival in endometrial cancer. And the question is, can we use it as a marker to select patient that has highly responded to PI3 kinase inhibitors? And this is actually need more investigation, especially in the sample that is actually collected from endometrial cancer. Endometrial curettage. So these are the biomarker. This is a very important table, and I think it summarizes everything we can see. Is what is the change between the biomarker in the specimen versus the endometrial curettage? This area is actually a very important area for research, and I think it's very easy to implement and easy to research these kind of questions. And I would really encourage all of us to dig into that more, to differentiate between the biomarker and the final specimen and the curettage, because this, we know that now in the future, we know where we're heading. So in the coming 5-10 years, not all patients with endometrial cancer will need lymph nodes. Not all patients will need extensive surgery, or omentectomy, et cetera, et cetera. So the way is actually we're heading towards the pre-staging biomarker. And this will definitely change our fourth-line approach to endometrial cancer. And again, the research is encouraged in that area. So we'll move to the next topic. So the story behind this is actually, we had a tumor board discussion a couple of weeks ago. We had a patient with with the high-grade endometrial cancer. It was sarcoma. And then the question was whether it's actually correct to go for these patients with minimal invasive surgery or not. And is it just because we can do minimal invasive, should we do it in these cases or no? So and the good news is actually high-grade subtypes account for about 25% of endometrial cancer. This includes sarcoma as well and any high-grade. But at the same time, why it's important? Because these high-grade are actually responsible of 50% of mortality of endometrial cancer. So that's why it's a very, very important topic. So, and of course, you can't talk about minimal invasive surgery without bringing the LAB2 trial, which is a landmark trial that actually shaped our practice now. And it shows clearly the non-inferiority of minimal invasive surgery versus open surgery in early stage endometrial cancer. Yes, their primary outcome was progression-free survival, but even with the very high conversion rate, we still establish this conclusion with a better quality of life for patients who receive minimum invasive surgery. So if you look from the LAB2 trial into the table, as you can see, most of the, it's a good numbers of the high-grade endometrial cancer, they were included in the initial study of LAB2 trial. This is the number of course, there were 2-to-1 stratification randomization, and these are the numbers of even sarcoma. There was about 60% of patients that were there. Okay. Despite the biological aggressiveness of this high-risk resolution, women with high-grade uterine cancer were treated via laparoscopy, showed there was no change in survival. And this is clearly shown in the post-hoc analysis of this data that of LAB2 patients. They took only the high-risk patient, and they clearly showed no survival difference between those two cases. And again, this is a retrospective study with multi-center showing that there is no difference between MIS versus open surgery for the select patients of high-grade patients. Again, Cochrane database review published this meta-analysis. And as you can see in the fourth plot here, comparing the laparoscopy versus open, there was no difference in the progression-free survival, neither the overall survival between laparoscopy and laparotomy. And this included about 4,000 patients. Okay, this is a very important table, and this table shows you the major studies that looked at the comparison between laparoscopy and open surgery for high-risk histology. As you can see here, the progression-free survival actually was even more in patients with MIS in these studies, as well as some of them in overall survival. But the only study actually that showed statistically significant better outcome for laparoscopic arm in high-grade lesion was actually this study from Turkey, where they looked at, it was of course a retrospective study, but they looked at the high-risk histology and compared laparotomy versus minimally invasive surgery. And surprisingly, when they looked at the high-risk group, they found actually there is better outcome for patients who actually had a minimally invasive surgery versus open surgery in endometrial cancer. So what happened since 2009 until today in MIS category? So we are doing a much better technique in terms of minimally invasive surgery. We have robotic surgery, etc. And this is actually reflected by the better conversion rate. If you look at the LAB2 trial, the conversion rate was about 25% of patients who were initially planned to go for laparoscopy, but then changed, and better patient selection as well. So the idea is when you do a minimal invasive surgery, you're going to have less morbidity, as reflecting actually starting chemo earlier and having what really going to make a difference for the patients is the chemo, and then you will be able to start it early. And we now actually need to have more studies to establish the superiority actually of minimally invasive surgery in high-grade endometrial cancer. So basically the question is, or the conclusion of my small research, that MIS is not associated with worse outcome in high-grade endometrial cancer. And basically, it actually should be encouraged to have patients actually going faster to chemotherapy and receive the systematic treatment. Sarcoma is actually very difficult. As you saw in the LAB2 trial, there was only about 60% in laparoscopic arm and 30% in open. Sarcoma, when I look in the literature, there was almost like no real good data to establish the difference between the two. Most of data we're talking about commercialization, but it's not our scope. So basically, the sarcoma, I think, if the uterus is small, you still can do it with minimal invasive. There is nothing against it, given the data of LAB2 trials. Okay, you still with me?
Yes.
Okay, good. Right. The third question is radical hysterectomy. Should we still do it
or this is something that's going to be taken away again from us as gyne-oncologists. As you know, for stage 2 endometrial cancer, the suggested treatment either radical hysterectomy followed by radiotherapy, or superficial hysterectomy followed by radiotherapy, or just adjuvant radiotherapy, neoadjuvant radiotherapy followed by extrafacial hysterectomy. And this is a question that is not really answered a lot. But if you look in the NCCN guidelines about stage 2 endometrial cancer, you will find a radical hysterectomy as actually one of the options, but it's either hysterectomy or radical hysterectomy. But surprisingly, in the ESMO, ESCO, and ESTRO recommendations, and if you look at their recommendation, that radical hysterectomy is not recommended for management of stage 2 endometrial cancer, because there is no clear evidence. And as you know, most of patients actually will never have any histological diagnosis of cervical involvement preoperatively, so you're mostly going to rely on imaging. The thing is, actually, the reported rate of parametrial involvement in endometrial cancer is about 14%. And most of this parametrial involvement is actually not the early stage disease, it's actually the advanced disease, which is stage 3 and higher. So the reliability of cervical involvement, of cervical extension of endometrial cancer in predicting the parametrial involvement is actually different. As you can see, it's speculated that because in endometrial cancer, the cancer starts from the endometrium, then goes to the cervix, and then spread to the parametria, that is actually different than what happens in cervical cancer, where the cancer starts from the cervix, where it goes right away to the parametria. So that's why the parametrial involvement is different, and we cannot treat endometrial cancer based on our data or our knowledge of cervical cancer, because these are two different diseases. But the question is whether there's actually any impact in the survival of patients who have radical hysterectomy. This is a very important trial, talking about the impact of radical hysterectomy versus simple hysterectomy for stage 2 endometrial cancer. It was a meta-analysis, and as you can see, they included 10 retrospective trials with about 2,800 patients. In the first plot here, you can see that there's no difference between patients who underwent radical treatment versus simple hysterectomy. But the interesting part is this data actually included all endometrial cancer stage 2 that was previously including patients with only mucosal involvement, so the old FIGO classification. When you look just at the patients who have the new FIGO classification of stromal involvement, and this trial, actually, there is superiority of simple hysterectomy rather than radical hysterectomy in these kind of cases. And that's why this should change our practice now, because we're following the 2009 FIGO classification. So my message is actually we have to slow down in recommending radical treatment. Why? Because there's a very operative morbidity and quality of life difference between those cases. There is a lack of evidence actually supporting going for this radical surgery in such patients. And the last thing is actually, we know from our cervical data that the double modality treatment is associated with the worst quality of life and morbidity for our patients, including radical hysterectomy followed by radiation. So the last point I'm going to talk about, do you still have time? Are we good with time?
2 minutes.
2 minutes? Oh, more than enough. So actually, I started this before knowing that Dr. Hani is going to speak about recurrent endometrial cancer, so it's going to make my life much easier. I didn't actually have much to say about advanced endometrial cancer, but the reason behind this, actually, I put that question, is I want to reinforce the importance of surgical intervention in these kind of patients. And we still did not miss the boat entirely for these patients, because we can still make some difference in patients with advanced endometrial cancer, even with omental
extension. So there's about 10 to 20% of endometrial cancer present at advanced stage, which is a good thing, alhamdulillah. But again, the high quality data is actually lacking when we compare it to ovarian cancer because of the small number of patients. And we did not establish very well based on randomized control trial the importance of cytoreductive surgery in these cases. So this is a very good meta-analysis of advanced endometrial cancer treatment, whether actually surgery will make any difference. And surgical candidates, actually, there's less patients achieve complete cytoreduction in endometrial cancer versus ovarian cancer, which is actually related to the nature of the disease itself. But we know based on this retrospective trial that patients who receive chemotherapy plus cytoreductive surgery do much better than patients who receive chemotherapy alone. So that established the an important rule of endometrial cancer in these kind of cases. What they concluded from this trial that each 10% increase in the percentage of patients that are going complete cytoreduction improves survival by about 10 months, 9.3 months, so which is an important number. So when you change 10 months in the survival of a patient, that actually make a huge difference. So the message behind this point is even in advanced endometrial cancer, we still did not miss the boat. You still can help patients and improve their survival. If you're able to achieve full cytoreduction, that will be the best. But even with patients with disease less than 2 centimeters, you're still going to make some difference. Thank you very much. On time?
Yeah.
Okay.
Almost on time. Thank you.
Good.
Thank you, Dr. Mazen, for your comprehensive and elegant presentation. We will keep the questions and answers until the end of the session, just to make sure that we will be on time. Next is Dr. Hani Al-Halal, who's going to talk to us about the treatment of recurrent endometrial cancer. Dr. Hani Al-Halal is a gynecologist who was trained at McGill and then University of Montreal, and he joined us at King Khalid University Hospital a few years ago. He's well known for his surgical capabilities, especially with the robot. So welcome, Dr. Hani.
Thank you, Dr. Abdulaziz. So before I start, I would like to thank Dr. Nashmiya for this kind invitation. And I want to congratulate her for this successful event for many years now. And I wish this continue for years to come, inshallah. So today I'll talk about treatment of recurrent endometrial cancer. It's a little bit complex topic, so I'll try my best to summarize it and become comprehensive. So, what's here? Yeah. So it will be incomplete to talk about treatment of recurrent endometrial cancer without mentioning the natural history of recurrence, the pattern of recurrence. So fortunately, I mean, we are lucky, that most endometrial cancer patients are early stage. 10 to 20% of these patients will recur within the first 2 to 3 years. The survival of recurrence after recurrence will be dependent largely on the stage, the primary disease, then on the location of recurrence. The estimation of 5-year survival in case of pelvic recurrence will be more than 50%, and in case of extrapelvic recurrence will be less than 20%. So here it summarizes the location of recurrence. And as I mentioned earlier, it will be dependent largely on the primary disease stage. With most patients in early stage, 50% of recurrences will be pelvic. The other 50% will be distributed equally between combined pelvic and distant. And 25% will be isolated distant recurrence. In advanced stage group, most of patients will be extrapelvic or distant recurrent. I like this study. It's a recently published paper that describes the pattern of recurrence and the natural history of recurrence based on the molecular profile of the endometrial cancer in the primary disease. So in this study, they recruited patients, it's a retrospective study, cohort study. They recruited patients from 2004 to 2015. They had around 594 endometrial cancer patients. More than 100 patients of them recurred. So here they looked at the molecular profile. Only 2 patients were Pol mute. The others were equally divided among the other molecular profile, which is MMRD, P53 abnormal, and non-specific molecular profile. Yes. Oh, okay. I think that's better. Thank you. So as you see here, for polymute, only 2 patients recurred. That's why they didn't include these 2 patients in the survival analysis. The other group of patients here, they looked at the progression-free survival, the location of recurrence, and survival. For MMRD, they had the shortest progression-free survival, only 13 months. However, there are the group who had the best survival curve here, as you see in this graph. For the P53 abnormal, most of the patients had abdominal recurrence, and they had the worst survival, as you see here in this graph. For the group with non-specific molecular profile, the mean recurrence was after 16 months, and most of these patients, they recur distally. For the 2 patients with polymute and this group, I think one of the limitations was they were already, one of them was P53 abnormal, and the other one was high-grade pathology. So now we move to the management part. The good thing about recurrence that most patients will be pelvic recurrence, and the majority of them will be in a radiation-naive field. So here, the management is straightforward. Usually, there will be a good candidate for salvage radiation, and the response and the outcome will be excellent. The cure rate can reach up to 88%, with excellent 5-year survival that goes more than 60%. And usually, they salvage them with combination of external beam radiation and brachytherapy. For tumors that are larger than 4 centimeters, some of our colleagues in radiation oncology will prefer a surgical resection of the mass to reduce the size, and that will improve the radiation outcome. In contrary to that, when patient already received radiation, here the options will be, it's in the coming slide. For this one, we are talking about those group of patients with pelvic recurrence, okay, in contrast to vaginal recurrence. Unfortunately, this group of patients will have poor prognosis and poor survival. Usually, the survival will drop significantly. For example, here, the 3 years overall survival will drop from 70% in those in vaginal relapse to only 8% whenever there's pelvic or nodal recurrence. And one of the reasons is lower response to radiation and difficulty in surgical resections at these sites. And usually we consider chemotherapy in case of pelvic recurrence, in contrast to vaginal recurrence, where radiation can be the only modality required. There is one trial, which is GOG 238. The results, it's not yet published, I checked last night. It tests the value of adding chemotherapy to radiation, okay, in case of pelvic or vaginal recurrence. Still, we are looking up for the result of this trial to show if there is any survival benefit. But so far, we go case by case and we individualize our management plan in terms of chemotherapy in this group of patients. Now we move to the most challenging part. In case patient already received radiation, okay, in the pelvis, in the adjuvant set, and now she comes with pelvic recurrence. What are the options? The options are limited. The only feasible one will be surgical resection, and most of these patients would end up with a radical surgery, which is pelvic exentration. There is some literature describing the outcome of pelvic exentration in the context of recurrence after adjuvant radiotherapy. Unfortunately, the morbidity and mortality is still high. It's more than 50% in all retrospective studies, with some modest survival benefit. If patient is lucky and comes with a small isolated vaginal recurrence, we might consider doing just vaginectomy, but this is the exception, and most of them will actually need pelvic exentration. Now the question, sorry, I need to go back. Now the question, is there a role for re-irradiation after pelvic radiation? Still, this is not a standard of care. Historically, that was tested in advanced or in recurrent cervical cancer. There is some data that describe a good outcome, but still with high complication rate. In other gynecological cancer, there are also some retrospective studies that showed some good control in the expense of high risk of complication. It can reach up to 100%. Okay, and the most common complication would be actually fistulization. So, how do we choose our patient? I think it depends, okay, on the patient herself. Okay, whether she is a candidate for that modality or not. If she's not a surgical candidate, for example, and on the expertise of the radiation oncologist after extensive patient counseling. If there's a small vaginal recurrence, we can consider interstitial brachy or the intensity modulated radiation therapy technique. And I'm sure our colleagues here from radiation oncologists will have more experience, and they can tell us more about it later on. So now we go for surgery. Dr. Mazen already mentioned a little bit about the role of surgery in advanced endometrial cancer, and the same thing is applied to recurrent endometrial cancer. Unfortunately, we don't have any prospective randomized trial that looked at the value of debulking surgery in advanced or recurrent endometrial cancer, and most of the literature will be extrapolated from ovarian cancer. However, we do have some good retrospective data, and the largest study here comes from Bristol with his meta-analysis. He looked at the survival benefit from debulking surgery. It's exactly like what we do in ovarian cancer. And as Dr. Mazen mentioned in his slide, there is almost 10-month improvement in survival, with each 10% increase in the proportion of patients undergoing complete debulking. And the rate of complete debulking will be largely dependent on the skills of the surgeon and on the experience of the center. And these results were showed in other studies, okay, with the same good result in both progression-free survival and overall survival. Like in this retrospective study, there is almost doubling in progression-free survival from 20% to more than 40%, and in overall survival from 30% to 60%. So nowadays, most gynecologic oncologists would agree that when a patient is a good surgical candidate and there is a disease that can be resectable, we usually go and do the debulking surgery as we do in ovarian cancer. This is another study that shows similar result, retrospective study. And as you can see here from the curve with non-visible disease, there's a huge gap, okay, there's a huge improvement in overall survival comparing to incomplete debulking. Now we move to systemic therapy. I'm not going to expert in systemic therapy. We have here more expert colleagues from medical oncology. But given the nature of the topic, okay, I have to talk about it. So when it comes to chemotherapy, I like this table because it summarizes the history of chemotherapy in endometrial cancer. So it started with doxorubicin as the best chemotherapy given for endometrial cancer. Then subsequent trials examined doxorubicin in comparison to other forms of combination, like here doxorubicin versus cyclophosphamide, then doxorubicin versus doxorubicin plus cisplatin, then the combination of doxy and cis comparing to the triplet combination, the famous TAB triplet combination, which was at some point of time the standard of treatment, in endometrial cancer, until the landmark study of GOG 209 was published and established carboplatin and paclitaxel as the standard of treatment in endometrial cancer, both in a primary, advanced, and in recurrent set, with excellent survival benefit. So here it summarizes the result of GOG 209. They looked at a group of patients with advanced endometrial cancer and recurrent endometrial cancer, and they randomized them into the historical standard, which is the TAB regimen in comparison to carboplatin and paclitaxel. And it showed similar results. Carboplatin and paclitaxel was not inferior to TAB, but when it comes to toxicity profile and the side effect profile, the carboplatin and taxoplatin did far better with less morbidity comparing to TAB, and that established carboplatin and paclitaxel as a standard treatment. Now, what about the concept of a platinum sensitive versus platinum resistant, in ovarian cancer? We do use that in ovarian cancer. Do we use the same thing in endometrial cancer? This study, which is a retrospective study, had looked at that question, and actually they found similar result to ovarian cancer. When they examined the response to chemotherapy as second line, whether platinum or non-platinum, they found significant difference in response rate in relation to the progression-free survival. As you can see here in the table, when the progression-free survival is less than 6 months, the overall response rate was 25%, comparing to more than 24 months, which was 65%. And that, so in the practice, we do stratify patient, and the classification of a platinum sensitive versus resistant will influence our decision for chemotherapy in the context of recurrence. When it comes to other options other than platinum chemotherapy, there's no actually good chemotherapy. One good chemotherapy, this is a list of multiple options, and this is left for the treating physician to decide which one to give based on his experience or her experience and the available chemo in the center, but there's no actually one good chemotherapy that's established. Now, what about hormonal treatment? Hormonal treatment plays a major role when it comes to endometrial cancer and fertility preservation and management of advanced stage, and also in recurrence. And the good thing about hormonal treatment that compared to chemotherapy is the good toxicity profile. It's very benign medication. It can be given orally. Usually we don't give it IV or parenteral. Unfortunately, there's no data that support any survival benefit, with hormonal treatment, and there's no study that compare chemotherapy to hormonal treatment, but it's used actively to treat and manage patients with endometrial cancer. So here we have multiple studies. This is one of the oldest studies that looked at medroxyprogesterone acetate, and they tested low dose regimen compared to high dose. And surprisingly, the group with low dose regimen, 200 milligram per day, did far better than the high dose. So this is the standard dose, 200 milligram a day, and it was better in terms of survival and the response rate. The best candidate will be those with well-differentiated endometrioid, hormonally positive. However, even those with hormonal negative can benefit from hormonal treatment. And it's not a contraindication for hormonal treatment, but they will have a lower response rate that can go up to 10%. Also, tamoxifen is one of the options. It's not commonly used, but there is some literature that's described some response. The overall response, the pooled response rate in multiple studies can reach up to 22%. So it's one of the available options. And usually the dose will be from 20 to 40 milligram a day. This is another study that examined an alteration between medroxyprogesterone acetate and tamoxifen, and it showed some response, 27%, and the response duration was more than 20 months. This is the Paragon trial that examined anastrozole, which is an aromatase inhibitor, 1 milligram a day, and there was a clinical benefit rate that reached up to 44% in the 3 months. This is another study that compared 2 different combinations, which is everolimus plus letrozole, aromatase inhibitor, in comparison to tamoxifen and medroxyprogesterone acetate. And here there was no difference in adverse outcome, but the everolimus and letrozole was better than tamoxifen medroxyprogesterone acetate in terms of progression-free survival and overall survival. This is very recently published meta-analysis about the role of progesterone treatment in both advanced and recurrent endometrial cancer, and it showed good response rate that reached up to 30%. And now we'll move to bevacizumab. The data in bevacizumab is conflicting. This is one trial that showed some overall survival benefit. This is another trial. The METO trial didn't show any benefit. So still, it's not one of the standard treatment, but it's something to consider. Trastuzumab was established as one of the options in serous endometrial cancer whenever there is HER2 in you based on this phase 2 trial, and it showed some improvement in progression-free survival. mTOR inhibitors was also one of the options that were tested and showed some activity. Immunotherapy, I'm not going to talk a lot. Dr. Azzam will be talking about it, but here in Keynote 146, the combination of lenvatinib and Bimbo showed some positive result, and that triggered people to go and do phase 3 trial with the Keynote 775, and this established lenvatinib and Bimbo as a standard of care in patients with recurrent endometrial cancer after previous line of chemotherapy, and Dr. Azzam, I'm sure we'll talk about it in more detail. And dostarlimab recently has received the FDA approval as one of the options whenever there is MMRD, MSI-H positive. And by this, I will conclude my presentation. Thank you.
Thank you very much, Hani. We'll move to the next speaker, Dr. Faisal Azzam. He's a very well-known medical oncologist from King Fahd Specialist Hospital in Dammam, Saudi Arabia. He's joining us from home. Thank you for being with us, Azzam. Without further ado, please proceed.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you very much for the nice introduction. And thank you for Dr. Nashmia to invite me to talk about the immunotherapy in metastatic endometrial cancer. I believe you can see my slides, am I right?
Yes.
Yeah. Okay. So these are my disclosures. Endometrial cancer is one of the commonest cancer in one of the common gynecological malignancy, and since incidence is increasing by 1% every year. Luckily, 75% of these patients would present with early stage disease, and the 5-year survival is around 75 to 90%. The problem is with stage 3 and stage 4 disease, where the survival is quite poor, and that is why you see more and more trials are done to improve the survival of these patients. There's an unmet need to do that. This has already been discussed by Mazen and Hani, that for early stage disease is basically surgery, radiotherapy, and brachytherapy. But for stage 4 disease, surgery, of course, is one of the treatment options, radiotherapy, hormonal treatment, chemotherapy, immunotherapy, and immunotherapy plus target therapy. So this is my topic today. I'm going to discuss more in detail about the immunotherapy. But I want to discuss one of the case presentation. One of my patients. I'll take you through her journey of treatment and discuss the evidence behind the treatment. So Mrs. FH is a 65-year-old lady who's obese, presented with post-menopausal bleeding and abdominal pain. She was generally well, and the only comorbidity was controlled hypertension on amlodipine 5 milligram. Biopsy reported as endometrioid adenocarcinoma. CT scan showed metastatic disease with bilateral lung metastases, periaortic lymph nodes, pelvic lymph nodes, and uterine mass. Because she had a bleeding, so we opted to go for radiotherapy first, which was palliative radiotherapy. And meanwhile, the histology was reported as ER/PR positive, MS stable, MMR proficient, and P53 mutant disease. If you look at the guideline, the first-line treatment for metastatic disease is chemotherapy, which is mostly carboplatin and paclitaxel. Herceptin is usually used for patient with a serous carcinoma, but in subsequent line is mostly immunotherapy or combination of immunotherapy with targeted therapy. So lenvatinib plus pembrolizumab, and then a single agent or monotherapy, immunotherapy currently approved are pembrolizumab, dostarlimab, evolumab, and nivolumab in patients who have an MSI high or MMR deficient disease. Anyhow, our patient who is a metastatic endometrial cancer, we opted to give her carboplatin and Taxol. 6 cycles completed. She had a good response, but partial response, still have a disease. And she tolerated chemotherapy reasonably well. So we decided to start her on letrozole hormonal treatment. So she continued without any problem. After 8 months, apart from some arthralgia, no major side effects. Her disease was stable. But after 1 year of treatment, 1 year of chemotherapy treatment finishing, her disease started to progress. So CT scan reported progression in lungs and periaortic lymph nodes, and also we had new bone metastases. She also had arthralgia, so we stopped letrozole. And at that time, we thought the next treatment option. So because this was more than a year since she had carboplatin-based chemotherapy, one of the options was to re-challenge her with the same chemotherapy, carboplatin and Taxol. And by that time, we had pembrolizumab and lenvatinib, so this was another option. Second-line chemotherapy, as Hani has mentioned, there are quite a few chemotherapy, but not very effective. Hormonal treatment, she progressed on hormones, so that was not on our priority list. And then we had pembrolizumab and dostarlimab, but these are approved for MMR deficient or MSI high disease. Our patient had MMR proficient and MS stable disease. So monotherapy or immunotherapy, single agent was not recommended. So MMR DNA repair pathway is quite crucial for any cancers, and there are 4 genes which are involved in this process: MLH1, MSH2, MSH6, and PMS2. When there is a mutation in any of these genes, it can cause the problem with the DNA repair, and that accumulates thousands of mutations, specifically in the microsatellite region, and that is what we call as MSI high disease. If you look at the incidence of MSI in different cancers, uterine endometrial cancer is one of the cancer which has the highest MSI high, 28.3%, followed by GI cancer, adrenocortical cancers, ovarian, hepatocellular, and cervical cancers. And these are the cancer who usually respond well to immunotherapy drugs. So pembrolizumab has been tested in different early phase studies and showed to improve the objective response rate. And it was different in KEYNOTE-016, it was 71%. And then pool analysis reported an objective response rate of 36% when pembrolizumab was used. But a phase 2 study called KEYNOTE-158, single-arm study using pembrolizumab in patients who had MSI high or MMR deficient disease, reported as an objective response rate of 57%, and complete responses of 16% were reported with pembrolizumab. Garnet is another study that led to approval of the dostarlimab. This is a phase 1 study. Part 1 of the phase 1 study was dose finding. Part 2A was a fixed dose safety run, and part 2B was to test the dostarlimab in patients who had MMR deficient or an MMR proficient disease. So in this study, they have reported when dostarlimab was used in MMR deficient patients, the objective response rate was 44.7%. with 11% complete responses. As compared to MMR proficient, it was 13.4% with only 2% complete responses. Progression of disease were more common in MMR proficient disease as compared to MMR deficient. Ongoing responses were significantly higher in those patients who had MMR deficient disease. So that shows that immunotherapy is quite effective in patients who have an MMR deficient or MSI high disease. How about the toxicity from both these two studies, Keynote 158 for pembrolizumab phase 2 study and Garnet study phase 1 for dostarlimab, reported grade 3 or more severe adverse event were pretty much rare. So generally well tolerated. And immune-related adverse event of thyroid problems, pneumonitis and colitis, again not very common. Then we have avelumab, also recommended in guidelines, not commonly used. And it's again a phase 2 study where they used avelumab in MMR deficient and MMR proficient disease, reporting an objective response rate of nearly 27% versus 6% in MMR deficient versus MMR proficient disease. FIREDRY is another phase 2 study testing durvalumab in patients who had an MMR deficient and MMR proficient. Similar sort of result, 47% objective response rate in MMR deficient, while only 3% in MMR proficient disease. So all these studies are showing that if the patient have MMR deficient or MSI high disease, single agent immunotherapy works very well. Now, so we know that the patient immunotherapy is an effective treatment, single agent when it is MSI high or MMR deficient, and in first line chemotherapy is quite effective. So how about combining chemotherapy with immunotherapy? So currently there are trials going on. So NRG GY018 testing pembrolizumab with chemotherapy. ATTEND study is testing atezolizumab with chemotherapy, and RUBY is testing dostarlimab with chemotherapy. All these trials are currently not reported or ongoing studies in first line setting, testing immunotherapy with chemotherapy. But we have pembrolizumab plus lenvatinib, which is immunotherapy plus targeted therapy that has been currently approved as standard of care because of phase 2 study called Keynote 146 and phase 3 study Keynote 775. LEAP-001 is currently ongoing study testing its efficacy in first line setting. Nivolumab plus cabozantinib is a similar sort of study. So let's discuss the standard of care currently in second line or subsequent line is to use lenvatinib plus pembrolizumab. A phase 2 study called Keynote 146 have tested this combination of lenvatinib plus pembrolizumab in patients who have MMR deficient or MMR proficient disease, and you can see the objective response rate in patients who had an MMR deficient disease was more than 63% with more than 9% complete responses, and the highest responses were reported in clear cell carcinoma, and that is the type of cancer where the prognosis is the worst. This benefit was seen regardless of the histological type and regardless of the PD1 or PD-L1 positive or negative disease. The most common grade 3 or more treatment-related adverse event were hypertension in 32%, fatigue 8%, diarrhea 6.5%. Discontinuation and drug interruption were pretty much common, but mostly with lenvatinib and not with pembrolizumab. So that led to a phase 3 study where they randomized patients to lenvatinib, 20 milligram daily plus pembrolizumab, 200 milligram every 3 weeks versus chemotherapy, either doxorubicin or paclitaxel. This is a randomized open-label phase 3 study in subsequent line or second line after failing chemotherapy. The primary endpoint was progression-free survival and overall survival. So baseline characteristic in this phase 3 study were pretty much balanced in both the arms of lenvatinib plus pembrolizumab versus chemotherapy. So most of these patients had MMR proficient disease. We said when you use monotherapy, it's the MMR deficient which responded very well. So they're trying to test the combination if it is better for patients who have MMR proficient disease. There are patients with all the histological types, and they've included patients who had one line, more than one line, or more than 2 lines of chemotherapy. Primary endpoint, progression-free survival was significantly better with the lenvatinib plus pembrolizumab, median of 6.6 months versus 3.8 months, hazard ratio of 0.60 in patient who had an MMR proficient disease. Similarly, in all comers, the hazard ratio was 0.56. Subgroup analysis for progression-free survival, significant improvement of progression-free survival with lenvatinib plus pembrolizumab in all patients, regardless of age, regardless of the MMR status, and regardless of the histology. Overall survival, similar results favoring lenvatinib plus pembrolizumab with a median 17.4 months versus 12 months, hazard ratio of 0.68 in patient who had MMR proficient disease. Similarly, hazard ratio was 0.62 in all comers. So favoring lenvatinib plus pembrolizumab versus chemotherapy. Subgroup analysis, similarly reporting the benefit with lenvatinib plus pembrolizumab compared to chemotherapy in all groups of patients, including MMR deficient, MMR proficient disease, and all the histological types. Objective response rate is another endpoint, significantly better for lenvatinib plus pembrolizumab as compared to chemotherapy in both MMR proficient and all comers. It was around 30% with complete responses in 5 to 6%. Median duration of response was also higher with lenvatinib plus pembrolizumab versus chemotherapy in both groups of patients, either MMR proficient or all comers. Median time to response was pretty quick when you use lenvatinib plus pembrolizumab as compared to chemotherapy. We have said from the phase 2 study that hypertension and diarrhea are one of the common side effects, and here you can see grade 3 toxicity were not that common, but hypertension was reported in 37.9%, followed by weight decrease in 10.3% and diarrhea in 7.6% of the patient, but generally well tolerated, and hypertension can be managed easily. So to conclude from this phase 3 study, lenvatinib plus pembrolizumab is currently a standard of care in subsequent treatment for metastatic endometrial cancer, because of the improvement in overall survival, progression-free survival, and objective response rate. These benefits were seen regardless of the MMR status and regardless of the different histological type. The safety profile was consistent with the earlier trial. It was generally well tolerated. So our patient who's a MMR proficient disease, who have MMR proficient disease and MS stable, we decided to give pembrolizumab 200 milligram daily plus lenvatinib 20 milligram as recommended by the phase 3 study, full dose. 3 weeks after starting the treatment, her blood pressure shot up to 160 by 110. You remember I told you her blood pressure was controlled on amlodipine 5 milligram. Now we increased the dose to 10 milligram. ECG was normal, blood tests were normal. So we continued with the same dose of pembrolizumab plus lenvatinib, just increase the dose of amlodipine to 10 milligram daily. From studies Keynote 146 and Keynote 775 for endometrial cancer and Keynote 581 in renal cell carcinoma, they used lenvatinib plus pembrolizumab. And you can see the median time to onset of different toxicity. Hypertension usually happen very quickly within 2 to 3 weeks, which we have seen in our patient. Also, fatigue, musculoskeletal pain, diarrhea, hypothyroidism all happen very quickly in the first 2 months of starting treatment. Diarrhea in one of the study reported to be happening after 20 weeks, but generally you will know the side effects within the first 2 months of starting treatment. So after 2 months of starting pembrolizumab plus lenvatinib in our patient, her blood pressure is now controlled with amlodipine 10 milligram, and she's on full dose of pembrolizumab plus lenvatinib. 3 months into the treatment, she developed diarrhea, and severe diarrhea, actually grade 3 diarrhea, and we were not sure is that diarrhea because of pembrolizumab or lenvatinib. So we stopped both the treatment, started on high dose prednisolone, IV fluid, and loperamide. She improved significantly in the next few weeks, and we tapered down the prednisolone. So when the diarrhea was settled, we reintroduced pembrolizumab full dose. A CT scan reported a very good response in lung metastases and also in lymph node metastases. So we decided to continue with pembrolizumab as a single agent. 5 months after starting pembrolizumab plus lenvatinib, her blood pressure is controlled, bloods are okay, and she was generally well, no more diarrhea. So we decided to introduce again lenvatinib, but this time we started with half the dose. Pembrolizumab full dose, lenvatinib 10 milligram, which is half the dose or 50% dose reduction. And if you see if you look at 3 studies for lenvatinib plus pembrolizumab, dose interruption and dose reduction has been reported in 60 to 70% of the patient, but mostly or almost all these patients, the problem was with lenvatinib rather than pembrolizumab, and most of the dose reduction and interruption was done on lenvatinib, as we did in our patient. 7 months into the treatment, a CT scan reported near complete response in lung metastases and periaortic lymph nodes. Bone scan also reported significant response. Blood pressure is controlled, no more diarrhea, but she developed hypothyroidism. So we started on thyroxine and referred her to endocrinology, but we decided to continue on the same dose, 50% lenvatinib and pembrolizumab, because she had a very good response. So we continued with the same treatment. 9 months into the treatment, her thyroid functions are better. She's on 75 micrograms of thyroxine and generally doing very well with performance status of 1. So as I mentioned, hypertension, hypothyroidism, and diarrhea are the common side effects, and our patient had all those in the first few months of starting treatment, but generally well tolerated and well managed as we did. So what's happening in the future? So we have pembrolizumab plus lenvatinib versus chemotherapy in first-line setting, currently ongoing. We don't have the results yet. Another study of cabozantinib plus nivolumab has been tested and reported that when you use cabozantinib plus nivolumab versus nivolumab, progression-free survival and objective response rate is better with nivolumab plus cabozantinib versus immunotherapy. Then we have pembrolizumab plus chemotherapy in first-line setting versus chemotherapy. Currently ongoing study, we do not have the results yet. And the atezolizumab, another immunotherapeutic agent with chemotherapy versus chemotherapy again in first-line setting. ATTEND is the study, phase 3 study. Still, we do not have the result yet. And then phase 3 RUBY study testing dostarlimab plus chemotherapy for 6 cycles followed by maintenance dostarlimab versus chemotherapy for 6 cycles followed by placebo maintenance in first-line setting. We have initial result for this study and seems to be positive and practice changing. The results from this study will be presented next month in the SGO conference, and it seems to be that this will be the new standard of care for first-line treatment. So just to conclude my talk, pembrolizumab plus lenvatinib is currently approved in second-line metastatic endometrial cancer, regardless of the MMR or MSI status. This approval is in Europe, but in US FDA, the approval is for patients who have MMR proficient disease and those who does not have MSI high. The reason for that is because, as I have mentioned, a phase 2 study of pembrolizumab alone, Keynote 581 reported objective response rate of 57% in patients with MMR deficient disease. And similarly, when you combine pembrolizumab plus lenvatinib in another phase 2 study, Keynote 146, the objective response rate was not much different in MSI high or MMR deficient disease, 63%. So you can see here, either you use pembrolizumab alone or pembrolizumab plus lenvatinib in MSI high or MMR deficient, it does not make much difference. And that is why US FDA has recommended, if you have a patient with MSI high or MMR deficient, it's better to use single agent pembrolizumab rather than adding lenvatinib, which has significant toxicity. So a phase 3 study of pembrolizumab plus lenvatinib currently is a standard of care because of overall survival benefit, progression-free survival benefit, and objective response rate. That is regardless of the MMR status. Hypertension is the most common side effect, but generally well managed. Even oncologists can do very well in treating the hypertension. Patient education, early recognition, close monitoring helps in reducing the side effects. And my last slide, currently the first line for metastatic endometrial cancer is carboplatin plus paclitaxel. This is soon going to change because next month, RUBY study, which is a phase 3 study, is going to be presented, and dostarlimab might be added to carboplatin plus Taxol in first-line setting. Currently, a standard of care for second-line and subsequent line is pembrolizumab plus lenvatinib in MMR proficient, as per US FDA approval, or regardless of the MMR status as per European approval. Pembrolizumab and dostarlimab are two of the immunotherapeutic agents currently approved only for those patients who have MMR deficient or MSI high disease. Thank you very much.
Thank you very much, Dr. Faisal, for this extensive review. We will move now to the next session with Dr. Kenan Shammari, who is a consultant medical oncologist at King Abdulaziz Medical City National Guard. He will talk to us about updates on the management of uterine leiomyosarcoma.
Assalamu alaikum. Thank you, Dr. Nishmiya, for inviting me to talk to you today about updates on management of uterine leiomyosarcoma. So in brief, in terms of concepts, when we talk about soft tissue sarcoma and specifically leiomyosarcoma, we have to consider a few things. One of them is disease heterogeneity. So between subtypes of soft tissue sarcoma, this is well known, and within a specific subtype. So there are in uterine leiomyosarcoma or soft tissue leiomyosarcoma, there are your slow growers and there are your aggressive ones. Probably the best way to actually discern which ones or which subtype this is clinically by follow-up. So when patients who have indolent or slow-growing type malignancy, active surveillance is always recommended. These are the patients that have low-volume metastatic disease and have no significant symptoms. Now, again, another concept is when we have oligometastatic disease, local or radical therapy should be considered. Now, when we talk about systemic therapy, specifically in the metastatic setting, we should always keep quality of life paramount and maintain it. Also, historically, when we talk about soft tissue sarcoma, specifically uterine and soft tissue leiomyosarcoma, historically, we always spoke about the median overall survival being around 12 months. There were previously toxic and limited therapy options. Probably the two oldest ones were doxorubicin and dacarbazine. Nowadays, we have an increasing range of therapies that have led to improvements in survival. We have more systemic therapy options. Hopefully, we do have better symptom control and better palliative care. We also have better confirmation of diagnosis. Now, this is paramount when we talk about sarcoma. I do recall a study that actually looked at community confirmation of diagnosis versus tertiary care center confirmation of diagnosis. And they do report that 25% of sarcomas diagnosed in the community get changed into a specific subtype of sarcoma at tertiary care centers. So this is of great importance. Multidisciplinary team discussion is also essential. All of these led to an improvement in the median overall survival in uterine leiomyosarcoma to being around 20 months. Now, again, talking historically, when we talk about the first anthracycline trials in soft tissue sarcoma, doxorubicin being probably the standard of care, there were quite a few trials that investigated the addition of other agents with doxorubicin. So when we talk about the EORTC published in 2014, it added ifosfamide, led to a small, non-statistically significant improvement in overall survival. Picasso-3, SARC-21, and GEDIS, which I'll talk about in a bit more details. So the GEDIS trial, as my colleague, gynecologist, oncologist know, involved or had 29% of those patients actually had uterine leiomyosarcoma. So it investigated first-line gemcitabine and docetaxel against doxorubicin in metastatic soft tissue sarcoma. And again, 29% were uterine leiomyosarcoma. When we look at the median progression-free survival, it was almost similar. Median overall survival was actually favoring doxorubicin. However, this improvement was not statistically significant. And hence, this further confirmed the benefit of single-agent doxorubicin in such patients. Now, back to EORTC, published in 2014 by Ian Judson and colleagues. It investigated the combination of doxorubicin and ifosfamide versus doxorubicin alone. We can see doubling of the objective response rate, improvement in progression-free survival, however, a non-statistically significant improvement in overall survival. Patients with the combination arm were more likely to experience more grade 3 toxicity. So this is a summary of single-agent doxorubicin trials in soft tissue sarcoma. Now, all of these trials had around 20 to 30% uterine leiomyosarcoma. All of them showed an improvement in objective response rate, almost doubling. So from around 15% to 20%, up to 30%. Progression-free survival was also improved in one study. The rest, there was not a statistically significant improvement. However, when we look at the median overall survival, there were no major or statistically significant differences. So this all favors the use of single-agent doxorubicin. Now, again, this is when we talk about palliation of, or the intent of therapy is palliative. Now, when we want to talk about an improvement in objective response rate, so hopefully changing a locally advanced unresectable to being resectable, I think we should still consider combination. Now, what I want to talk about today is LMS04 study, which was a study that was led by the French sarcoma group from Gustave Roissy. And what they have done is investigated the addition of trabectedin with doxorubicin and compared it to single-agent doxorubicin in metastatic or unresectable, specifically leiomyosarcoma. So the rationale or the background of the study is that leiomyosarcoma are rare. They carry poor prognosis, unfortunately, when they are metastatic or locally advanced. They do have somewhat moderate chemosensitivity. Now, we talk about response rates and combination therapies being less than 50% in uterine and 35% in soft tissue leiomyosarcoma. Response duration ranges between 3 to 6 months, never better, without a significant impact on overall survival when we talk about combination therapies. Trabectedin alone, response rates are around 10% in leiomyosarcoma after failure of anthracycline. There were encouraging results of doxotrabectedin in the phase 2 clinical trial, and hence this phase 3 clinical trial came about. So the study design is they took uterine and soft tissue leiomyosarcoma that were either locally advanced or metastatic, randomized them 1-to-1 to doxorubicin, the usual dose, 75 milligram per meter square for up to 6 cycles, against doxorubicin, slightly lower dose at 60 milligram per meter square, and trabectedin, also a lower dose at 1.1 milligram per meter square. Now, my medical oncologist and oncologist colleagues know when we give trabectedin as a single agent, we give a dose of 1.5 milligram per meter square. So both doxorubicin and trabectedin are at lower doses. Now, this was given for 6 cycles until either a stable disease or partial response is reached, then consideration of surgery, then maintenance trabectedin for up to 17 cycles. Primary endpoint was progression-free survival, so the study was statistically powered to detect that. Now, again, if you look at the doxotrabectedin arm, all of these cases got some sort of granulocyte colony stimulating factor agent. So if you pay attention here to the baseline characteristics, the majority of patients, so up to 60 to 70%, had a performance status of 0. So not 1, but 0. Grades 2 and 3 pathologically were the majority. And the uterine versus soft tissue division in terms of leiomyosarcoma were almost 50-50, so 45 to 55. And the majority of patients actually had metastatic disease, so 88 and 92%, rendering less than 10% being locally advanced unresectable. Now, when we look at clinical characteristics, all patients received the induction phase, so 6 cycles of doxorubicin and 6 cycles of doxorubicin and trabectedin. Now, in terms of dose reduction, you can see that the majority of patients with doxorubicin and trabectedin had dose reduction. The percent of patients that actually progressed on therapy or during therapy were 22% in the doxorubicin arm and significantly less in the doxorubicin trabectedin, reaching 6.5%. Now, withdrawal due to toxicity were around 3% for the doxorubicin arm and up to 10%, which is quite high, in the doxorubicin trabectedin arm. Patients reaching surgery after 6 cycles were 8% in the doxorubicin arm and 19% in the doxorubicin trabectedin arm. Now, when we talk about progression-free survival, and this is done by blinded independent central review, we talk about a significant improvement in the doxorubicin trabectedin arm by doubling of that of the doxorubicin arm. So 6.2 months in the doxo arm, and doxo trabectedin was 12.2 months with an impressive hazard ratio of 0.41. Now, if it was done by investigators, the results were also similar with clear separation of the curves that actually happens quite early and is maintained. In terms of subgroup analyses, all patients actually had an improvement with the doxorubicin and trabectedin arm, whether this was a uterine or a soft tissue leiomyosarcoma, whether this was locally advanced or metastatic, and whether they reached surgery or they did not reach surgery. Now, in terms of objective response rate, so the objective response rate in the doxorubicin arm was around 13%, which is as expected, and it was almost triple that in the doxorubicin trabectedin arm, reaching 38%. When we talk about disease control, so including your partial response, complete response, including a stable disease percent in the doxo trabectedin arm versus almost 80% in the doxorubicin arm. Now, this is quite important as well. Now, when we look at grade 3 toxicity, we compare doxorubicin and doxotrabectedin, up to 25% of doxotrabectedin patients actually had febrile neutropenia. And if you recall in the protocol, all of these patients actually had GCSF or some sort of GCSF analog. So this is quite significant. Thrombocytopenia happened in 20% of patients, most likely due to trabectedin, and nausea and vomiting up to 12%. And these patients did not receive aprepitant because it stimulated one of the CYP or CYP enzymes, so it was not used. Now, this is also what we all look for, which is an improvement in overall survival. Now, there was a significant improvement in the median overall survival, favoring doxorubicin and trabectedin, reaching up to 30 months. Now, I recall this is probably the only soft tissue sarcoma study that exceeded 13 months in terms of median overall survival in the leiomyosarcoma subgroup. Hazard ratio was decent at 0.73 at a median follow-up of 37 months. So in conclusion, now these are the author's conclusions, is that LMS-04 did meet its primary endpoint, demonstrating a statistically significant improvement in progression-free survival, favoring the combination of doxorubicin and trabectedin versus doxorubicin alone. Improvement was observed in both uterine and soft tissue populations. There was a significant benefit in objective response rate and overall survival. Safety profile, as per investigators, they mentioned that it was consistent with previous report. However, I do say that it was quite significant, so we need to carefully select our patients. Now, if you recall, 60% of those patients in the study had a performance status of 0. So these are your fittest of the fit patients. And doxorubicin should be the new standard of care in metastatic leiomyosarcoma. I do agree with this. However, I have to add in carefully selected patients. So patients with excellent performance status should be considered for doxorubicin and trabectedin. And biomarkers are needed to select patients who may benefit the most from this combination. By this, I conclude. Thank you all for listening.
Thank you, Dr. Shamari, for this excellent presentation and update. We will open the floor for questions and answers before we move to the next session, the satellite symposium. Dr. Walid.
Thank you, Dr. Kanaan, and thank you for excellent talks. Dr. Kanaan, while you are seeing those patients, leiomyosarcoma is very interesting, those patients to see, especially those with very fit patients, to add trabectedin. We use trabectedin as a single agent for a soft tissue leiomyosarcoma, and is somehow he has need specific follow-up for those patients, especially for a toxicity. How to be seen now in practice, and you see that how is very selected patient for those patients is, ECOG 0. For uterine leiomyosarcoma to a doxorubicin trabectedin, how we'll see in practice?
Thank you, Walid. Very important question indeed. And how many of your patients have informal status of 0? Unfortunately, not many.
Yeah.
However, I have currently 2 patients on this regimen. One is a lady in her 50s, I think 51 or 52 years old, who I gave 2 cycles to. She is still tolerating the therapy quite fine. Another one is a younger lady, 37 or 38 years old, who actually got admitted after the first cycle with febrile neutropenia. Both of them symptomatically are doing better. I am yet to see a disease assessment CT scan to basically see if they are radiologically responding or not. But your question is quite important. I still think we should consider it in your ECOG 0 and 1 in patients who you think are going to be fit for such therapy. And if you recall, Walid, the doses were not the same for single agent. So doxorubicin was 60 milligram per meter square, trabectedin was 1.1 milligram per meter square. So these are lower doses compared to single agent being given either alone.
Thank you.
Well, thank you very much for this presentation, but I have 2 questions. Why did they choose a lower dose in the second arm? And second question, I did not get it. Did the surgery made any difference in those patients, especially that the 90%, I'm a surgeon, so 90% were, or more than 90% more metastatic?
So I'll start with your second question. So they did not, or the investigators did not really mention whether the ones that actually reached surgery. So I think these were 10% in the doxorubicin arm and 19% in the doxotrabectedin arm, whether it actually made a difference in overall survival or not. So that was not specifically mentioned in the protocol. Regarding why did they choose lower doses, and I think this is based on poor tolerance of high doses in if given both as doublets. And with the 60%, or 60 milligram per meter square in doxorubicin and 1.1 milligram per meter square in trabectedin, which are decent dose reductions, we had 24% of those patients actually having febrile neutropenia, which is quite large.
Assalamu alaikum. I have a question for Dr. Hani with regard to recurrent endometrial cancer. So 2 questions. One of them, the concept of platinum sensitive and resistance, I know is very well established in high-grade serous ovarian carcinoma. But when it comes to the endometrioid type, does it behave in the same way when it comes to platinum sensitivity? And the other question is, in the era where HIPIC is still being explored and coming back and forth, and just recently in Jeddah was that big conference about the peritoneal carcinoma, what are your thoughts about HIPIC in recurrent endometrial cancer as well? Is there a rule for it? Is the pathological type playing a role in considering it or not? Thank you very much.
Yeah, thank you, Dr. Hassan. Regarding the platinum sensitivity and resistance, most of the data are extrapolated from ovarian cancer. We don't still have large-scale studies that examine the outcome in recurrent endometrial cancer. I showed that study that was the only one actually that addressed that question, and it showed a clear survival benefit whenever the progression-free survival goes beyond 6 months in terms of overall response rate. Still, there's no good second-line chemotherapy for endometrial cancer after failure of platinum. And we have our colleagues from medical oncology also. Their input will be very useful in this context. Regarding the HIPEC, as far as I know, we don't have any evidence that support HIPEC in endometrial cancer. Even in ovarian cancer, still the evidence is evolving. We have only one phase 3 trial that showed improvement and survival in the interval debulking setting, but in endometrial cancer, I think we only have some retrospective and case series. I don't think we have any strong evidence that support HIPEC in endometrium, and I'm not aware about anybody who support that practice, at least in our country. Thank you. Thank you.
I have a question for Dr. Faisal Azzam. So, Dr. Faisal, regarding the combination pembrolizumab with lenvatinib, what's your preferred starting dose for lenvatinib? And if the patient develops toxicity from lenvatinib and required discontinuation for lenvatinib, or you will continue on pembrolizumab alone if it's MSI proficient?
Thank you, Bassam. Nice question. Yes, so my preferred, I used to start with the full dose, 20 milligram of lenvatinib and 200 milligram of pembrolizumab. But I've seen a lot of toxicity actually with the lenvatinib mostly. So now I prefer to start with 10 milligram, which is 50% of the dose of lenvatinib and full dose of pembrolizumab. And then I gradually go up to 14 and then to 20. So this is how I'm doing it. So gradually increasing the dose if the patient can tolerate. If not tolerating, I continue with 50% of the dose. Regarding the toxicity, if the patient gets toxicity, as I've shown you, nearly 60 to 70% patient needs dose reduction or dose interruption because of lenvatinib only. So so most of the time I would only stop lenvatinib, but like in my case, it was diarrhea, and immune-related diarrhea can happen. So that's why in that case I stopped both temporarily and restarted pembrolizumab. But usually I go for stopping or discontinuing first the lenvatinib and then pembrolizumab in some cases. Thank you.
Dr. Faisal?
Yes.
I would just like to ask a question that might seem to be a little bit general, but how much really would the dose reduction in chemotherapy, when you apply it to ovarian or endometrioid, or like this dose reduction that sometimes you need to apply, it's probably a deviation from the standard study protocol. How much would it really affect the actual outcome of those patients? Does it really affect the overall survival, progression-free survival? Are there any studies to give us a good feedback on these things that happen? And how many sessions sometimes you need to delay or to dose reduce? So what effect would they carry on the patient in view of the toxicity they are experiencing? Thank you.
Thank you. That's an excellent question, actually. Yes. So we know that the dose intensity is important and it does affect the efficacy of treatment. The patient selection is very important. You know, in the trials, all the patients were either performance status 0 and 1, but in real life, we know that usually 0 and 1 is very difficult to find. It's usually the performance status of 1, 2, or sometimes 3 also we give treatment. So you have to adjust the dose accordingly. Now, will it affect the efficacy? So in my experience, when I give full dose, I have to stop the treatment because of toxicity, and it delays the treatment anyhow. So that's why I change my practice. And this is I've learned from renal cell carcinoma, basically, when we were using sunitinib, how to play around with the VEGF inhibitors or targeted therapies. So I don't think so it will make much difference in terms of efficacy, but dose intensity is an important factor. And but if you see, In the study also, it was nearly 70 to 80% of patients had dose interruption or dose discontinuation. As such, there's no evidence or no study which has compared for those patients who had continued with a 100% dose and those patients who discontinued or dose interrupted or dose reduced. So we don't know what will be the outcome, but we know that the dose intensity is important. But as such, at the same time, you need to look into the quality of life. Is the patient tolerating or not tolerating? And especially in the real life, you see different sort of patient rather than trial patient. That is why I changed my practice. I used to start with full dose, which is a trial dose. But we do not see almost all of my patients. After some time, I would have to reduce the dose or stop the treatment. Now, with my current practice, now I am actually seeing more of the patient slowly adapting to the lower dose and then going up to the full dose after a couple of months or 3 months is much easier for me. This is what I'm doing it. But there's no evidence behind it. It's just my practice.
But this would not affect the sensitivity of the tumor when you start a lower dose rather than going for the full dose, wouldn't that?
No, I don't think so, because either you start full dose and stop within 3-4 weeks because of the toxicity and then restart after 2 or 3 months, or you continue with the lower dose for first 2 to 3 months and then increase the dose. Efficacy should be the same actually. And this we have learned from the renal cell carcinoma. For endometrial carcinoma, we don't have any evidence, but for renal cell carcinoma in sunitinib studies, it has been shown that you can start with half the dose and gradually build up for the 100% dose.
Thank you very much, sir.
Thank you.
Any further question? I think we reached the end for this session. So I would like to thank all the speakers and the moderators here for this nice session. And now we'll go for the next session.
Yeah.
Thank you very much for all the speaker moderator for the excellent session. Now we'll move to the satellite symposium from GSK. Will be presented by Dr. Faisal Azzam, who's already been introduced by the colleague Faisal Azzam. He's a senior consultant medical oncologist. Dr. Faisal, floor is yours.
Thank you very much. Thank you, Nashmiya, and thank you for the organizing committee to to invite me to talk about this session. So the session is more or less similar to which I presented. There will be some doubling of the slides. And thank you very much for GSK to organize this satellite symposium and inviting me to talk about improving outcome in management of metastatic endometrial cancer. Same disclosures as I've already presented. And this slide was also already presented. We know that the endometrial cancer is the most common gynecological malignancy. The idea behind showing this slide again is because most of these patients present with early stage 1 or stage 2 disease with 5-year overall survival of 75 to 90%. But the main problem is with the advanced stage disease, stage 4 disease, where the outcome is dismal. And that is why most of these trials are now trying to help to improve the survival of these patients. And there's an unmet need to improve the survival. So here you can see most of the endometrial cancer patients present with either localized or regional disease. And the 5-year survival for those is comparatively better as compared to those who have metastatic disease, which is only less than 20%. So there's definitely an unmet need to improve the survival of these patients. And so we are trying to use different drugs in combination or monotherapy. In ovarian cancer, we have seen for over the last few decades that their survival is improving, but unfortunately not the same for the endometrial cancer. And again, the same reason, we need to do something to improve the survival of these patients also. According to the Saudi Cancer Registry in 2018, endometrial cancer is among the top 10 cancers in Saudi Arabia, and among the female, it is on number 4. Cancer. The MMR DNA repair pathway is important. 4 genes which are involved in it are MLH1, MSH2, MSH6, and PMS2. Any mutation in these gene will not would lead to accumulation of thousands of mutations around the microsatellite region. and that is what we call it MSI high disease. And it has been shown that those patients who have an MSI high disease, their tumor respond to immunotherapy. In endometrial cancer, MSI high disease has been found, or its incidence is to be the highest at 28.3%, followed by stomach, colon cancer, rectal cancer, adrenal carcinoma, esophageal, ovarian cancer, hepatocellular, and cervical carcinoma at 2% of the incidence. We all know that there are type 1 and type 2 endometrial cancer. Type 2 is more aggressive as compared to type 1, and the MSI high is mostly in the type 1 endometrial cancer. This cartoon shows how how does the DNA repair pathway work. So this is when there's a DNA replication error and DNA mismatch repair pathway if it's intact. So the repair will happen, and what we call it MS stable. But when there is a DNA mismatch repair deficiency, or one of the gene is mutated, then there's mutations happening and accumulation of this or instability at the microsatellite region, what we call it the MSI high or MMR deficient disease. And this is the group of patients who responded better to the immunotherapy drugs. So Lynch syndrome accounts for 5.8% of the endometrial cancer. Lynch syndrome basically is the germline mutation in the DNA mismatch repair genes, which are MLH1, MSH2, MSH6, or PMS2. The immune microenvironment in the MSI high endometrial cancer exhibit elevated cytotoxic cell CD8 and B cells, which allow these patients to respond favorably to immunotherapy. The ESMO currently recommend to test the for the MMR or MSI high, and they are recommending to do the immunohistochemistry to look for the 4 proteins loss in the MLH1, MSH2, MSH6, and PMS2. If the immunohistochemistry results are not clear, then confirmatory PCR test or NGS needs to be done to confirm if there is a MMR deficiency in these genes. So NCCN guidelines similarly recommends to do the MMR testing for all colorectal and endometrial cancer, and that is regardless of the age of diagnosis. And why do we need to do the testing, and why is it so important? Because we know that the MMR deficient or MSI high tumors give rises to the mutation-associated new antigens. It causes, or it strongly expresses PD-1, PD-L1, CTLA-4, and LAG-3 receptors, and it also increases the cytotoxic T lymphocyte, which are CD3+, CD8+ invasion, and all these helps to improve the response or increase the response of immunotherapy. And it has been shown that dostarlimab and pembrolizumab currently are standard of care as a monotherapy immunotherapy in patients who have MSI high or MMR deficient endometrial cancer. So the guidelines recommend first-line treatment for metastatic endometrial cancer, still a chemotherapy, carboplatin and Taxol as a standard of care. Trastuzumab is added for serous carcinoma who have HER2 positive disease. And then in subsequent or second line, lenvatinib plus pembrolizumab is recommended regardless of the MMR status as per European and MMR proficient as per USA FDA approval. Pembrolizumab, dostarlimab, avelumab, and nivolumab are immunotherapy agents approved as a single agent for the MMR deficient or MSI high disease. So for the evidence behind these treatments, so Keynote 158, a phase 2 study, single arm using pembrolizumab reported an objective response rate of 57%, with complete responses 16%, those patients who had an MSI high disease. Garnet, a phase 1 study of dostarlimab, which led to approval of this study, also reported similar results, an objective response rate of 44.7% in patients who had MMR deficient disease as compared to 13.4% in MMR proficient disease. Complete responses were higher in the MMR deficient disease. Similarly, stable disease, the progression of the disease was higher in MMR proficient as compared to MMR deficient disease. Ongoing responses and responses at 6 months, 12 months, and 18 months were higher in patients who had MMR deficient disease as compared to MMR proficient disease when they used dostarlimab as a single agent in MSI high disease. Grade 3 and grade 4 toxicity in both these studies, Keynote 158, a phase 2 study for pembrolizumab, and Garnet, phase 1 study for dostarlimab in patients who had an MMR deficient or MSI high disease, reported grade 3 or grade 4 toxicity as a rare entity, so generally well tolerated. Immune-related adverse event of hypothyroidism, pneumonitis, and colitis has been also reported, but generally well tolerated. Most of these immune-related adverse events were with the pembrolizumab as compared to, or not compared, as reported in the Garnet study for dostarlimab. A Garnet study was a phase 1 study where they had the part 1 of the study was the dose finding. They enrolled 6 patients at 1 milligram per kilogram every 2 weeks, and when they did not find more than or less than, or when they did not find more than 1/3 of dose-limiting toxicity, they enrolled further 3 patients at 3 milligram per kilogram every 2 weeks. Again, when there was less than 1/3 of dose-limiting toxicity, they increased the dose to 10 milligram per kilogram, and they enrolled 12 further patients. So for in part 2A, they found the doses of 500 milligram every 3 weeks or 1,000 milligram every 6 weeks as the standard dose for the phase 2 part of the study. So they included 13 patients in part 2A to find the safety of that. In part 2B, they have tested dostarlimab in MMR deficient or MMR proficient disease. So the pharmacodynamic part in the part 1 reported the maximum achievable receptor occupancy through the CD3 binding assay and interleukin stimulation assay. So and then again in part 2A, the pharmacodynamic reported similarly when they used 500 milligram every 3 weeks or 1,000 milligram every 6 weeks, the receptor occupancy were the same as they have found at different doses in the part 1 part of the study. So for the recommended phase 2 dose was 500 milligram every 3 weeks for 4 cycles, followed by 1,000 milligram every 6 weeks. So in this phase 1 study, the baseline characteristics were well balanced in MMR deficient and MMR proficient disease with median age of around 65. They've included almost all different histological types. And of course, the MMR deficiency was more common in type 1 endometrial cancer. The results, as I've already mentioned, objective response rate was higher in MMR deficient, 44.7%, as compared to MMR proficient, 13.4%, 11% complete responses in MMR deficient, while only 2% in MMR proficient disease. The progression of disease was more common in MMR proficient as compared to MMR deficient disease. And the ongoing responses were 89% in MMR deficient, while 63% in MMR proficient disease. The probability of remaining in response at 6 months, 12 months, and 18 months were significantly higher in MMR deficient disease as compared to MMR proficient in those patients who had dostarlimab. These are the any grade treatment-related adverse event, but generally well tolerated. Fatigue, diarrhea, nausea, asthenia, anemia, and thyroid problems are a few of the common side effects, but generally well tolerated. And grade 3 or more severe toxicity was not that common in both groups of patients. So single-agent immunotherapy is an effective treatment in those patients who have an MSI high or MMR deficient disease. And then currently there are trials going on to combine chemotherapy with the immunotherapy. So NRG GY018 is testing pembrolizumab plus paclitaxel plus carboplatin in first-line setting. ATTEND is another study testing atezolizumab with chemotherapy in first-line setting. And RUBY is another phase 3 study, first-line study testing dostarlimab in chemotherapy. So currently we are waiting for the results of those, but Ruby study, we have initial results, which is a positive study and will be presented next month in SGO conference. Currently in second line or subsequent line, pembrolizumab plus lenvatinib is recommended. Pembrolizumab is an immunotherapeutic agent, while lenvatinib is VEGF TKI, which is a targeted therapy. So Keynote 146, a phase 2 study, Keynote 775, a phase 3 study led to approval of this combination in second or subsequent line. LEAP 001 is a phase 3 study currently ongoing to test this combination in first-line setting. Nivolumab plus cabozantinib again has been tested and shown to improve the progression-free survival in phase 2 study. Why do we want to combine chemotherapy with immunotherapy? And the reason for that is when you use chemotherapy, it signals recruitment of immune cells to the surrounding area. It increases the expression of tumor antigens, and it reduces the number of regulatory cells that suppress the immunotherapy effect. So you can see when this happens, the response to the immunotherapy drugs is much higher. And then we have studies in non-small cell lung cancer, Keynote 189, and Keynote 407, in triple negative breast cancer, Keynote 522, and then cervical cancer, Keynote 826, all showing improvement in the outcome when you combine chemotherapy with pembrolizumab. And that is why we want to test immunotherapy with chemotherapy in patients who have advanced stage endometrial cancer or metastatic endometrial cancer, where the survival is dismal, less than 20% of 5-year survival is there. So Keynote 146 already been discussed, a phase 2 study testing lenvatinib plus pembrolizumab, reporting significant improvement in progression-free survival or objective response rate in patients who have MMR deficient or MSI high disease, 63% with 9% complete responses. The highest responses were reported in clear cell carcinoma, which has one of the worst prognosis. Discontinuation and dose interruption was highest with lenvatinib alone. When you use this combination, pembrolizumab alone is usually not that much of a problem, but when you combine, toxicity of grade 3 and more has been reported as hypertension, the commonest in 32%, fatigue 8%, diarrhea 65%. Any grade immune-related adverse event, most common was hypothyroidism in 47% of the patient. Grade 3 or more adverse immune-related adverse event were not that common, mostly skin reaction in 4.6% of the patient. Then a phase 3 randomized phase 3 study testing lenvatinib plus pembrolizumab versus chemotherapy, either doxorubicin or Taxol, in patients who have previously had chemotherapy in second line or subsequent line treatment. Primary endpoint, progression-free survival and overall survival. Secondary endpoint of objective response rate. I've already discussed that the MMR proficient disease, the median progression-free survival was significantly higher with lenvatinib plus pembrolizumab as compared to chemotherapy. Hazard ratio was 0.60, while in all comer it was 0.56. This benefit of lenvatinib plus pembrolizumab over chemotherapy was seen regardless of the MMR status, regardless of the performance status, and regardless of the different histological types. Overall survival, again, was significantly better with lenvatinib plus pembrolizumab in either MMR proficient disease or in all comers. Hazard ratio was 0.68 for overall survival, favoring lenvatinib plus pembrolizumab over chemotherapy. For all comer, it was 0.62, favoring lenvatinib plus pembrolizumab over chemotherapy. Similar to progression-free survival, the overall survival was also favoring using lenvatinib plus pembrolizumab, and that is regardless of the age, regardless of the MMR status, and regardless of the different histological types. Objective response rate in MMR proficient disease for lenvatinib plus pembrolizumab was 30.3% versus 15%. Complete response is 5% versus 2%. And progression of disease was more common with chemotherapy as compared to lenvatinib plus pembrolizumab. In all comers, similar sorts of result favoring lenvatinib plus pembrolizumab. Median duration of response was also higher with lenvatinib plus pembrolizumab in MMR proficient or all comers of patients. The median time to response was only 2 months with lenvatinib plus pembrolizumab in either MMR proficient or all comers of disease. The toxicity, hypertension, hypothyroidism, and diarrhea were more common, and grade 3 toxicity of hypertension was comparatively common, 37.9%. Others were pretty much low. Weight decrease was seen in 10.3% of the patient. Other were less than 10% of the 10%. So just to conclude, Keynote 775 led to approval of lenvatinib plus pembrolizumab because it improved overall survival, progression-free survival, and objective response rate. And that is regardless of the MMR status in those patients who previously had chemotherapy. This benefit was, as I mentioned, was regardless of the MMR status and regardless of the different histological type. It was generally well tolerated. Hypertension was more common, but that is managed pretty well by the physicians. So pembrolizumab plus lenvatinib is currently approved and standard of care in second-line metastatic endometrial cancer, regardless of the MMR status, approved as per European guidelines or European approval, while US FDA approved it as MMR only in MMR proficient disease. And the reason I've already mentioned, because the US FDA is looking at the two phase 2 studies. One is single agent pembrolizumab, Keynote 581, reporting objective response rate of 57%. Another study of phase 2 study, Keynote 146, using pembrolizumab plus lenvatinib, reporting objective response rate of 63%. So these are all the patients who had MSI high or MMR deficient disease, and the objective response rate was not much different between pembrolizumab alone or pembrolizumab plus lenvatinib, and that is why US FDA approval is only for MMR proficient disease and not for MMR deficient disease. Anyhow, pembrolizumab plus lenvatinib have shown to improve overall survival, progression-free survival, and objective response rate. The dose interruption, dose reduction, I've already mentioned, is seen between 60 to 70% of patients when you use this combination. And most of this reduction is needed on lenvatinib as compared to pembrolizumab alone. So what has happened, or what will happen in the future? We have a study, LEAP-001, trying to test pembrolizumab plus lenvatinib versus chemotherapy in first-line setting. This is an ongoing study. We do not have the result. RUBY is another phase 3 study where there are two parts of the study. Part 1 of the study is dostarlimab, 500 milligram plus chemotherapy, which is carboplatin plus Taxol for 6 cycles, and then dostarlimab is used as maintenance therapy for 3 years. Another arm is carboplatin plus paclitaxel as a standard dose for 6 cycles, followed by maintenance placebo for 3 years. That's part 1 of the study, which is already completed, and initial results shown it to be a positive study, and it is going to be presented next month in SGO conference. The second part of the study, which is ongoing, is using dostarlimab, similar dose, 500 milligram, with paclitaxel and carboplatin for 6 cycles. And then in maintenance therapy, part 2 is a bit different than part 1. They have used dostarlimab, 1000 milligram, every 6 weeks for 3 years. In addition, niraparib, which is a PARP inhibitor, 200 milligram or 300 milligram daily for 3 years. So they are adding PARP inhibitor to immunotherapy for a maintenance therapy. And the another arm in part 2 is a standard arm, which is a chemotherapy for 6 cycles, followed by placebo as a maintenance therapy. So why are we using this combination? We know that the immunotherapy can cause DNA damage, and if you use PARP inhibitor with it, it will interfere in the DNA repair pathway, and this is what we need for the cancer treatment. So PARP inhibitor also upregulate tumor cells PD-L1 expression, which may increase the activity of the PD-1 or PD-L1 inhibitors. So the chemotherapy causing DNA damage, which PARP inhibitor can inhibit, and at the same time, it upregulates the PD-L1 expression, where the immunotherapy can work better. And that this is the rationale of using PARP inhibitor, niraparib, in addition to dostarlimab, which is immunotherapy as a maintenance therapy in part 2 of the study. Is still ongoing. We do not have the results yet from the part 2, but from part 1, initial results have shown that the that the Ruby study, a phase 3 study, met its primary endpoint in a planned interim analysis in patients with primary, advanced, or recurrent endometrial cancer. As I mentioned, this is a positive study and is going to be presented next month. It might change the standard of care. Another study is phase 3 study called NRG-GY 018, which is testing pembrolizumab plus chemotherapy for 6 cycles followed by pembrolizumab for 5 years as a maintenance therapy versus chemotherapy alone and then placebo maintenance for 5 years. Atezolizumab, similar study, atezolizumab plus chemotherapy for 6 to 8 cycles versus chemotherapy in first-line setting. In first-line setting, again, it's still an ongoing study, and we are waiting for the to complete the study. So my last slide, just to conclude, the current standard of care for metastatic endometrial cancer is carboplatin plus paclitaxel, but we have learned that when you use a combination of treatment, pembrolizumab plus lenvatinib or pembrolizumab alone, it improves the outcome. So the rationale of using immunotherapy plus chemotherapy in first line has been introduced by Ruby study, which is a phase 3 study. Initial results are positive, is going to be presented, and that might change the first-line treatment of just carboplatin plus paclitaxel, and instead that might change to carbo plus paclitaxel plus dostarlimab for 6 cycles, followed by dostarlimab maintenance therapy for 5 years. In subsequent lines, currently the standard of care is pembrolizumab plus lenvatinib in MMR proficient as per US FDA approval, or regardless of the MMR status as per EMA approval in Europe. Pembrolizumab alone or dostarlimab alone are the single-agent immunotherapy only approved for those patients who have an MMR deficient or MSI high disease. Thank you very much. That was my last slide.
Thank you, Dr. Faisal, for the excellent comprehensive presentation. Any questions from the audience? I don't see any questions. So thank you very much, Dr. Faisal. Now we'll end sorry, we have one question.
Yes, Dr. Faisal, Dr. Bassam with you. Just question, we know for the MSI deficient, we have now 2 options, Pembro or dostarlimab. Any preference for if both medications available from the trial, from the toxicity, from the response?
Yeah, thank you, Bassam, for asking this question. There is, I don't think so there's any comparison between the dostarlimab or pembrolizumab. Yes, so we can look at the toxicity profile is slightly different. This is what I have shown to you. The thyroid problems and thyroid and also pneumonitis were more common in phase 2 study of pembrolizumab as compared to dostarlimab. But remember, dostarlimab study is a phase 1 study which led to approval as a monotherapy. So they did not report that high incidence of thyroid problems and pneumonitis as compared to a phase 2 study for pembrolizumab. So that might be one of the things to consider. But as such, I don't think so there's any difference in terms of efficacy. In terms of tolerance, both are very well tolerated. If you have both these drugs, there's no evidence that you can prefer one or the others. But of course, toxicity profile is slightly different. So you might consider that when you're prescribing these monotherapy.
Other question, we'll have 5 minutes break, then we'll before we start the next session.
Thank you very much.
أنا عليك السلام يا هلا وسهلا والله شرفتوني.
لا المدير
Welcome back. We'll start our last session for today, which will be on the role of radiotherapy, palliative care, and fertility preservation in patients with gynecological malignancy. This session will be moderated by Dr. Salam Al-Shehri, who is the consultant, division head, radiation oncology, King Abdulaziz Medical City, and Dr. Ahmed bin Ahmed, consultant from palliative care team, and Dr. Muhammad Abu Shar, who is senior consultant from OBGYN. Please, Dr. Salam, the colleague, the floor.
So, hello everyone. It's my pleasure to introduce Dr. Noha Justiniya. She's a radiation oncologist at King Faisal Specialist Hospital. She's a reference and lead for the brachytherapy in gynecological cancer. She's going to cover and talk about the topic of advances in brachytherapy and gynecological cancers. Thank you.
All right, thank you, everybody. Thank you for the kind introduction, and thank you for sharing the podium. Looks like a dwindling actually audience, but we'll go over briefly advances in brachytherapy, specifically for gynecological cancers. I'm just going to focus on two recently implemented technologies that we've actually implemented in King Faisal Specialist Hospital. One which will have the most focus is the introduction of what we call hybrid intracavitary and interstitial brachytherapy in gynecological cancer, specifically cervical cancer, that we started in 2020. And I'll also highlight a new technique that we just implemented in kind of late 2022, which is the use of 3D printed applicators to deliver surface brachytherapy. So we'll go over these briefly. So we'll first start with the hybrid intracavitary and interstitial brachytherapy in cervical cancer, kind of why we use it, when to use it, and how to use it, walking through an actual clinical example. So kind of just like a starting message is that we do all know that brachytherapy is an essential component of cure in patients with cervical cancer. Over the past couple of decades, there have been a lot of improvement in extended beam delivery, and that has prompted some people kind of with a limited accessibility to brachytherapy to use like CyberKnife or intensity modulated radiation therapy as a mean of boosting to residual disease after external beam radiation therapy. But this has been proven to be a kind of an inferior approach with a major drop in local control and survival when substituting or when omitting brachytherapy. Brachytherapy is an essential element for patients with cervical cancer being treated with a curative intent, those with locally advanced disease, basically. And that owes kind of to the much better advantages of brachytherapy as compared to external beam. I'm not going to explain that graph, but simply brachytherapy can offer the option of giving a high dose to residual disease. There are areas within the target that receive extremely high doses, and that's thought to be a major contribution to the control of the disease. And with less doses to the organs at risk. But a major limitation for brachytherapy is the size of the residual tumor. And essentially what we're able to treat is a function of the geometry of the applicator that is available to us. That makes kind of a basic limitation when it comes to its uses. So I'll focus the talk now on image-guided adaptive brachytherapy, which is kind of the major kind of technique we've implemented. So over the past decade, I would say one of the most kind of breakthroughs, most of the clinically relevant breakthroughs in treatment of cervical cancer is the introduction of image-guided adaptive brachytherapy. So we like to use a lot of acronyms in radiation oncology. So just to simplify, this is a way where we've moved from using point-based prescriptions. I think most of the audience is familiar with the use of point A as a prescription point. But with image-guided adaptive brachytherapy, we've moved into using volumes to prescribe to. And these volumes are primarily based on utilization of MRI for the definition of volume. And this essentially allows escalating to the target, to higher doses that have been previously kind of achievable, and without exceeding the tolerance of the organs at risk. This is kind of a pivotal study that has actually the Retro-Embrace trial, which were kind of top centers, European centers that have introduced kind of the technique, gathered the data, and published kind of a homogeneous cohort on the outcome of these patients. And because of what we see in there in terms of excellent local control in these patients with limited severe morbidity, it's been very exciting to kind of adopt this technique in many other centers. And that eventually led to kind of the largest prospective multicentric cohort study, the Embrace-1, where they looked at 1,400 patients with locally advanced cervical cancer that were treated with EBRT and concurrent cisplatin, and then had MRI-based IGABT as per kind of agreed guidelines. And this has showed that local control can be achieved in 92% of patients with excellent overall survival and pelvic control. You can appreciate in the graph that in these patients, kind of on the lower side here, these are stage 3B and 4A patients where kind of local control rates in higher 80s, early 90s can be achieved, which was extremely difficult before with the use of intracavitary brachytherapy only. And if you look at the associated toxicity, grade 3 and 5 toxicity was actually limited in this cohort of patients. So this pretty much actually makes this technology the standard of care in treating patients with advanced cervical cancer, particularly those that have residual distal permeatrial disease at the time of brachytherapy, stage 3A and stage 3B and 4A patients. This is kind of the standard of care on these patients. And to further kind of elaborate on why this is important, this also stems from our kind of basic knowledge of cervical cancer, where there is a well-known established dose-response relationship. We didn't see this in all cancers. So you didn't see this, for example, in lymphoma, you didn't see it in GBM, but in cervical cancer, if you increase the dose, the control improves. And this escalation of the dose, as you can see in the graph there, is actually even more pronounced in larger tumors. So if you compare the improvement in local control with smaller tumors in the range of 20 cc versus those with 80 to 90 cc, this jump in the local control rate is very significant in those with large tumors. So how frequent this issue? I think also most of the audience here acknowledges, like, despite it's not a common disease, but most of our patients that present with cervical cancer have actually locally advanced disease. So in the Embrace-1 cohort that looked at what is the number of patients or the percentage of patients that actually end up having large residual disease at the time of brachytherapy. And if you look at the group here that have been kind of labeled 3 to 5, generally like 50% of the patients will still have disease where the volume of our target is more than 40 cubic centimeter. So that is to say that half of the patients will require a technique like that. So how do we achieve that, or what is image-guided adaptive brachytherapy? Maybe actually I missed pointing this out. If we notice here in the EMBRACE one, that brachytherapy that was delivered in about 43% of patients, they actually received the technique, what is called hybrid intracavitary and interstitial needles. So half of these patients, to achieve this outcome, there is a significant proportion of your patients that will require this technique to be able to achieve this outcome with improved dose escalation and less morbidity. So this is an example of how image-guided adaptive brachytherapy improves your outcome in terms of local control. So what is image-guided adaptive radiation therapy? To summarize, it is a component of three kind of aspects. One is the use of MRI for volume definition. The second part is moving from point-based prescription to volume-based prescriptions, and the addition of interstitial needles to intracavitary brachytherapy when required. So this is an example of, say, this is your residual disease that you have in the first kind of category. And if we were to use a point prescription, this target will be adequately covered. If we use image-guided adaptive brachytherapy and with the use of intracavitary brachytherapy only, you can optimize kind of the dose to the tumor if it increases slightly beyond point A. But if you have a lot of disease that is left at the time of brachytherapy beyond point A, then this will not be covered with intracavitary implant only. So since these are the hybrid interstitial intracavitary applicators I'm mentioning, and there are different types and different levels. So as you can see here in the middle, some of these applicators can actually give you the advantage of inserting kind of parallel needles to the tandem, and that will push the dose laterally in the parametria. But if you still have distal parametrial disease or pelvic sidewall disease, pretty much the use of oblique needles or another row of needles will help you achieve that targeted dose and avoid toxicity to the organs at risk. So what are the indications? Just to summarize, there are two groups of patients. So you either use it for patients with large disease and primarily large residual disease in the distal parametria, or patients with distal vaginal disease. But there are also situations where the disease volume is not that large, but location and shape of the disease kind of precludes the coverage with intracavitary lesions. For example, I'm showing here a very lateralized uterus that is close to the pelvic side wall and difficult to treat if you just push those from the intracavitary implant. Here in this area, the kind of parametrial disease is all the way along the uterosacral ligament and a very close proximity of the rectum. This is a patient with a small disease, but in a cervical stump who's had a subtotal hysterectomy initially for a benign reason. So there are other situations where it can actually be very helpful other than large disease. So what are the kind of applicators that are available? So there are different ways of achieving that. Most centers that have actually implemented that, they have their own workshop making these applicators in-house. But now, luckily, we have multiple commercially available applicators that can have the option of adding parallel needles, such as this is the Utrecht applicator or the Vienna one applicator, and you've got the Geneva applicator on this side. And on this side, we have the advanced gynecological applicator or the Venezia applicator, which actually constitutes of 6 segments that you can actually assemble together to achieve much more kind of needle arrangement, including even up to 4 rows of needles in the lateral parametria. So in terms of how to implement it, how do I choose between these applicators? We've got different options, and even within one applicator, you can have different users. Just to summarize, this is we make that decision based on the tumor topography. We take into account the normal anatomy of the patient, as well as what the applicator can achieve and cannot achieve. There are limitations also to certain applicators. So radiation oncologists need to be cognizant of all these details to achieve kind of the best decision of how to cover this tumor. So this is walking through an actual example of a patient we've treated, kind of one of the most advanced patients that we've treated. This is a 51-year-old invasive, the run-of-the-mill cervical cancer, HPV-associated squamous cell carcinoma. She had distal parametrial disease, kind of on both sides of the pelvis. It was kind of more lateral on the right side. She actually had right pelvic side wall involvement, and also radiologically, you can appreciate that the disease breaches the mesorectum in this area, goes into the mesorectum fat, and touches the rectal wall, and almost invades kind of the adventitia of the rectum. And this disease also in the lateral direction, you can appreciate in here that she actually has vaginal involvement, and that paravaginal tissue is involved all the way on the right side to a distance of about 3 to 4 centimeters. After, say, 5 weeks of external beam radiation therapy with rapid ARC technique and giving a simultaneous integrated boost to the involved lymph nodes, both in the common iliac and para-aortic, this is how the disease looks like at the time of brachytherapy. So you can appreciate that the high signal area as a GTP has improved a lot, but there is a lot of areas what we actually call gray zones. These are areas that we still consider as a target in our brachytherapy, and this is what we need to cover with a dose of 97 to 95 gray. And we still have areas where the disease in here, you can appreciate these tongues wrapping around the rectum and also along the right mesorectal fascia. And if you look at the disease in that direction also, you can appreciate this is where the ovoids are, and this is disease in the vagina at the level of the ovoids. So if we were to treat these patients, this is kind of just simulating how we would cover this disease using kind of conventional point A base planning. And if we prescribe to point A, we're pretty much what I'm showing here. So the 100% isodose is actually shown in the dark red line, and the dotted line is our target. So if we were to treat with a point A prescription, you can appreciate how much we're missing in terms of the lateral disease, especially this part that is along the mesorectum. If we use image guidance and volume-based prescription and try to optimize to the volume that we have, then you can improve it that much as compared to point A prescriptions. If we were to use, I've shown you also, we have 2 systems of applicators, some with the parallel needles and some with the parallel, oblique, and perennial needles. So if we were to use even the parallel and oblique needles to cover this disease, you appreciate that this disease in here that is not reached with the oblique needles with the Veneti applicator. So even with parallel oblique needles, without a transperineal approach and pushing kind of needles to cover this target in here, it's not achievable. This is what we actually did for this patient. And I'm showing the comparison here. We used the perennial template to add needles in the right lateral direction and the posterior lateral direction. And we've achieved 4 rows of needles in that area. And with this is how the plan looks like. You can appreciate here how we're able to shape that isodose line extremely nicely around this dotted target you see in here. So actually, it looks really kind of improved in terms of the coverage to the what we call the CTVHR. Just kind of to simplify in here, we try to achieve 90% to the CTVHR of 8 times 4, well, 7.5 to higher to achieve a total kind of BD dose of 90 gray to 95. And we're able to achieve that with good doses to the organs at risk without actually exceeding the tolerance of the organs at risk. And this is the advantage of this technique in these locally advanced patients. The next technique, I'll just briefly go over it, is the use of 3D printed applicators, customized 3D printed applicators for treating kind of superficial lesions. You might ask, what is the implication in patients with gynecological malignancies? This is something that adds an advantage to current techniques that treat superficial areas. And the implication for gynecological cancers is that you could think of this option in patients with vulvar cancer who have just been treated for, say, a closed margin or a deep depth of invasion, and the target is only the vulva. So when to use it, what are the advantages in comparison to the other techniques, and briefly go through a quick example. Just kind of the radiation oncologist, we know that as compared to other kind of techniques used to treat superficial areas, we have tomotherapy, but the disadvantages gives a lot of dose to the organs at risk in the deep areas. The other option is using electron therapy or electron beams, but you can appreciate here, I'm showing a comparison between the use of surface brachytherapy as compared to electron beams, and you have you can appreciate the red line in terms of the 100% isodose line and how this looks completely interrupted in this section as compared to the ability to optimize kind of the dose point by point based on the applicator source when we're utilizing surface brachytherapy. This becomes really useful if you have irregularly shaped targets, if you have targets in areas with crevices. So you can appreciate also kind of in the vulvar area where this can be appreciated post-operatively. So this is an example of the first patient, or actually the second patient we treated. The way that we actually do that is that the patient is brought, we define the target. It's a breast cancer patient that we've first treated. So this is our target being defined, and this is what we call an optical camera. It's basically a camera that we use over the patient to take just a 3D image of the surface. So there's no CT exposure, just kind of light being used to reflect the surface of the patient and define our target. Using special kind of softwares and with the help of our 3D printing services at King Faisal, we asked them to design kind of an applicator to cover this target, to orient. Also, you can see that it's actually curved to match the curvature of the patient surface, and the needles are oriented nicely with a specific distance to meet certain kind of guidelines of how to distribute it. It's being 3D printed, and that's the final applicator. This is how we actually print the patient, define the area, kind of stabilize and fix that applicator on the patient, take a CT scan with the applicator and the pathways for the brachytherapy source. This is the plan being implemented. So this is our target. We decide to choose the locations and these channels that correspond to the shape of the target, and we get our nice kind of homogeneous or more homogeneous, better conformal brachytherapy plan. We do have also kind of very well established verification system. So to implement such new techniques, we use chromographic films to verify on the patient that whatever dose we are prescribing is actually accurately being delivered. So it's kind of a full circle plan from kind of commissioning the process at the beginning, ensuring its safety, stress testing of the applicators, all in phantoms before actually implementing on the patient. And even when using it on patients, we're verifying kind of the dose being delivered. So that's kind of exciting if this is actually possible with the great team I've got in terms of brachytherapy, in terms of the medical physicists. We've got a brachytherapy specialist, like an MRI specialist, a 3D printing specialist, as well as our awesome kind of radiation therapists as well. So that's kind of to summarize. Image-guided adaptive brachytherapy results in excellent control with limited severe toxicity. And as I mentioned, irradiating large residual disease requires the use of hybrid interstitial and intracavitary systems to achieve the adequate target dose without exceeding the organs at risk. And the proper applicator selection is required and does require good understanding of the disease extent, normal anatomy of the patients, and limitation of the available applicator. Surface brachytherapy is a preferred technique in patients with small and shallow lesions or large inoperable lesions. These provide good conformity to the patient anatomy if utilized with customized 3D printed applicators. And as I mentioned, there are some gynecological kind of indications where this can be utilized. And that ends my talk. Thank you very much.
Thank you, Dr. Justiniya. Yeah, we will keep the questions at the end of the session.
Assalamu alaikum. The next session will be talking about palliative issue and advanced gynecological malignancies. It's my pleasure to introduce Dr. Mohammed Saeed. He's a consultant of holistic care, palliative care medicine at King Abdulaziz Medical City, Ministry of National Guard, Riyadh. Welcome, Dr. Saeed.
Bismillah ar-Rahman ar-Rahim. Thank you, organizing committee, for the opportunity to be here. So you see this picture this afternoon. We all have plans with the families, the spouses, the children, and Alhamdulillah, we are cancer free. So one smile, like once everybody, please, one smile. You too, please, organizing. Thank you. See the beauty, and we enjoy this beauty when we are healthy and in good spirits. So what happened here? Our patient comes with vaginal bleeding, abdominal pain, small bowel obstruction, and then CT scan is done. And now the roller coaster ride, the fear, the gham in Urdu, hazan, wa gham, and the fikr, and then the fakr. It is true, when I was doing my palliative medicine in America, $4 trillion economy, the world richest country. But when anyone strikes with the cancer, it is a destruction. Why? Alhamdulillah, in the kingdom, you cover everything. And that's why I tell my patient, you are, mashallah, very lucky. In America, every cancer chemotherapy, brachytherapy, co-payment, underpayment, this co-cost, it breaks them financially. To the point, I have seen some of my patients, I learned they sold their houses to carry on the cancer treatment. And the recent, you can see on the Google, my children are studying there now, older. In Atlanta, there was a lady stage 4 uterine cancer in the COVID time. Stage 4, you and me, we know how much is the fatigue, the taban, They have no energy level. So she did not pay the rent. They said, get out. Then the police came and they tased her. And this was a big national news. So Alhamdulillah, in the kingdom, we are taking care well. But how about that? When the CT scan is done and we know there is a mass, now you see the fear and the hope, and the patient are moving ups and down. What will happen with the biopsy result? I have twice biopsy in my life, but just waiting for the biopsy, you understand, oh my God, how much we pray to Allah subhanahu wa ta'ala. Ya Allah, the result is good. And when the news come, we jump in the air and run towards how everything is good. So this is the exact situation, the NGS, and then the tumor markers, and then the chemo, and now the repeat PET scan. Now, imagine the patient mind, how they are feeling. So now we are talking about the whole person. We're not talking about, the immune modulators or, immune checkpoint inhibitors, the TKIs. Now we are talking about the whole patient. And why it is important? 2016 June, first time I came to Saudi, and you know the scorching heat in Saudi, dry heat. And at that time to get the STC card was more difficult than Aqd Thani. Believe me, it is true. I went to 5 times to the bank to open my account. You have to have the Iqama, the true copy, not the National Guard give you a copy that he's now employed here. They don't accept that. So 5 times went there, bank account cannot. This guy met me with a smiling face, and I took his picture in June 2016. I think in my Hayate Tabai, I will remember him because he smiled. He was the only one who smiled. and still he struck me, and I still have his picture. So, mashallah, you are doing excellent job. Your patients are down to the earth. They are suffering. They are thinking about, what will happen to the future. So when they come and if you smile, it is a big charity. So please smile. And now we are going to do some case scenarios, and we always have to compare with the international standard. And then the third is NGHS study, where we stand, and some other palliative issues. So who will tell me what is this? What you get out of this picture? Not the doctors, the clinical staff, sports staff. Can anybody tell what that means? The iceberg phenomena. When we say the iceberg phenomena, anybody? So that the Titanic, the big, they claim that it will not sink. Maybe 70, 80 years ago, it went from UK to USA. So what happened? They saw the iceberg. They did not know what we see at the top. There is a much bigger, 50 times bigger problem is down the surface of the water. So it stuck there and drowned. Now we are going to talk about the case scenario. What is happening with our patient? And thanks, Dr. Lakshmi, mashallah, 2016 I saw, and she has no age effect. We all have age effect, mashallah. Okay, here is the case now. I know this lady almost 4 years now into my practice, coming to my clinic from Hofferbatten. She was 37 years old, endometriosis at the baseline, married for 14 years, infertility since marriage. 12 years she's trying to conceive. Then she first contact with the gynecology June 2019, and June 12, 2019, she came to the ER, and then she has a small bowel obstruction. They did the CT of the abdomen, and they flagged that it is biopsy proven metastatic ovarian stromal tumor. That was June 2019, within 1 week period. General surgery was consulted in June, palliative medicine in June. Then until Hatta November 2019, she was keep coming but refusing surgery. Someone mentioned she was depressed. March 2017, she comes to the ER again. Before that, she has numerous visits, and now this time ER, she comes with massive bilateral pulmonary embolism. Now the physician told, if you did not do the surgery, you will die. But nobody went deep into that why she was refusing. So she was refusing. 12 years she was trying to conceive. And when she has a diagnosis of this early stage, whatever the tumor, someone told her, we will take out your ovaries, your uterus, and some other areas. And that she got frightened. Her hope to have a baby in order to survive the marriage. So what happened when her husband knew that she cannot conceive, she cannot have baby, then he divorced her. So that's another big problem happened to that lady. Now she moved to the mom's house and she still comes to the clinic, but with mom's car on the mom's appointment. Now, November 17, 2020, first time adult mental health was consulted. Now, if you see the time period, June 2019, first gynae appointment and the initial diagnosis. Then she went to November 17, so almost how many months? Maybe 14 months. Adult mental health, first time. Then November 18, finally someone diagnosed in the mental health that she has a major depression, persistence with low suicide risk. Even she was flagged major depression, but she was not on the state-of-the-art therapy SSRI. That is the state-of-the-art therapy. And then, the CBT, counseling, frequent counseling. And then if possible, if she is resistant to the medication, then atypical antipsychotics. If she is still resistant, then ECT therapy. Anyway, now I will tell you the circle which this young lady was going. First, she got transportation issue from Hafarbatan to here. Then treatment decisions, then dealing with the partner. Many times we ignore the breast cancer, the cervical cancer, how much stress on the woman these things have. Then the fatigue, then the depression. I would say it was a psychotic depression because she was not rational in her decision. So she was keep postponing the curative treatment options, and then until she had massive bilateral pulmonary embolism, then the fear. See, I am an average person in regard to the, stressful life situation. There are very few people on the extreme of the sphere, like they're very brave. Okay, whatever comes, no problem. There are very few people on the other side who will have a diagnosis and they will die. The majority are the common people. Nervousness, worries, sadness, sexuality, husband divorce. She may come back if we have not told her that you still have chances of fertility, pain, ability to have children, housing. So she was in the loop, continuously in this loop. Now, this is the NCCN. I think we cannot change our practice or cannot improve the quality of care until we do system-based management of the patient. Like anyone who comes on this NCCN thermometer with a distress level of 8 to 10, automatically it should kick the mental health. They have to see, that's it. Because we are spending, mashallah, billions of dollars. And our spending is not less than USA or Europe, but the quality is not there. So that we have to work on that, how we can improve the quality. Now, this is the same. I will go some slide. Now, I tell you what is happening in other parts of the world. The Republic of Korea, they evaluated this anxiety and depression. 232 patients with gynecological and breast cancer. First time, they found severe depression and disruption of daily life with ovarian and breast cancer, then cervical cancer. Then they found that 10% of clinicians refer patients to psychiatric treatment, and more than half, 55% patients do not seek any specialized care in mental health services. This study was done in the United Kingdom. The first systematic review and meta-analysis, 3,623 patients with ovarian cancer from primary research investigation. They found almost 1/3 of the patients have serious depression and anxiety, 1/3 among these categories. And they found that the prevalence is almost 25%. Then this another, okay, now they correlated. If that happened to the 1/3 of the population, 1/3, what happened? They have high mortality, is meta-analysis. They have increased periods of hospitalization, and they have poorer treatment outcomes, and their quality of life is poor. So this mental health disorder with an existential threat to life correlates with the poor health quality. Now, this in acute care setting, they found the prevalence. This is a Annals of Oncology, 1,448 cancer patients from 46 retrieved manuscripts, and they found the combined prevalence rate is 32%. So people are really suffering. People are really suffering. This another from China, and their rate is above 80% and 90% with these problems. But they correlated with the poor income, low socioeconomic status, frequency of chemotherapy, and the diagnosis and poor sleep quality. This is another important thing. So it is important to address the anxiety and depression and poor sleep habits while people are going through. And this is the NCCN, distress thermometer. It is very good. The reason is that it tells you, it addresses the practical problem, like the iceberg case, 37 years old, child care. She did not have the children, housing. After divorce, she moved to the mother. Financial issues, transportation, she comes from Farbatan, family problem, dealing with the partner, ability to have the children, emotional problems, and then all other kinds of, it is very simple. Any new patient comes, they should fill out system-based approach, and if it reaches to 8 or 10, automatically it should trigger mental health consultation. Now, I was able to review 35 cases. Mashallah, we are the really compassionate friends of gynecology. 35 cases, 97%, they saw the patient, and 34 patients we saw. So this is good on our part. But how about the mental health? We are way behind from the international standard. They saw 90%, maybe 10 to 12% went to mental health. And when I reviewed the charts, it was very sporadic. Sometime after 6 months, sometime when person almost breaks down, then mental health kicks in. So this we need to change. And still the practice the same. We need mental health services, efficient, caring, and prompt. Now, these are the few slides. I'm going to tell you what happened when the gynae patient comes to us. We reviewed almost 100 patient data, and we found we are still working and fighting, just like American did, 20 years ago. Every life has to be saved. So that almost brought them two times to break the healthcare budget. Everyone is going to hospital, tertiary care center for the elderly care. But you cannot help. What can you do? People have to die. But they were dying in the hospital, and still our patient, almost 99% die in the hospital. We have to change this practice. Like you see, the glucose checks on the palliative patient with life expectancy less than 30 days. We checked blood sugar almost 4,000 times. CT scan, US, ultrasound, lactic acid, urinalysis, ammonia, coagulation, LFTs. Probably no benefit. So only 4% we did not do the blood testing, but that may be the reason they were very terminal. So this one patient, and almost every patient have this, but we are, alhamdulillah, making some progress. They don't need medicine. They need Ali. We started home health program, home hospice program. I believe if National Guard give us this beautiful dish from Romania and we take to the patient home, this is much better psychologically, mental health, appetite stimulant, inshallah. And see here, 10 or more medication in the last 30 days of life, 33% of the patient know they should be only on 5, and that should be the pain medicine and the mental health medicine, or anything, necessary. And we also know that polypharmacy and death systemic review and meta-analysis, not a categorical connection, but there's a discrete connection. More medicine, elderly, demented people, cancer patient, they die earlier than the people who are on less medicine. We are still giving. Yesterday, I took a patient off from 2 insulin Lispro, rapid acting, Lantus, and patient has zero appetite with tremendous weight loss and metformin. They take it like these are the mutbarrik, the blessing, but the medicines are not blessing. May Allah save all of us. So until a lot of patients fall into hypoglycemia, even doctors are scared. I don't know why. We have to train them, particularly the family physician. Take the medicine off once the cancer is diagnosed. There is no need, in respect to the parameters. But so a lot of people should be only on insulin if needed, or only on diet. But they are on many patients on multiple medication. Now, in our hospital, have you eaten the hospital food? Tasteless. Why? Give them free diet. All the cancer patients, this should be Dr. Nakshmi, mashallah, she's the deputy chairman. This should be ordered. All the cancer patients, no diet restriction. With someone who has very high blood pressure, that's something else. Now, this is my last 2 slides. How many minutes, Dr. Ahmed, I have?
You have 2 minutes.
Oh, 2 minutes. Okay, see, I have at the end of the life, it is for me, for my psychotherapy, for all of us. Kullu nafsin dha'iqatul maut. Honestly, we have nothing to offer. Morphine, fentanyl, hydromorphone, alprazolam. That's it. That's true. But I remember the lady from High. She was, I think, 38 years old, gynae, uterine cancer. She comes to me, a massive ascites. We did the ascites, and she tells me, Dr. Hof. Subhanallah, one time I have tear in my eyes, how to console this lady. And Hof was because she has small children, 4 children. And then her husband comes, very simple family. So I think we have to be proactive. Honestly, as a human, whether in America, I know there's a nasopharyngeal cancer, wife comes and tells me he's scared of death. He should finish now. The patient has PPS 70 or 80, he come to my, but he, the problem was getting in the radiation and the chemo was not working. I think for those category of patients, we should have charismatic, our chaplains. And I go to the patient room, Quran recitation is going on, but the topic is about the marriage. Our topic is about the Hajj. That does not correlate. There should be selection of the topics in the end of the life. And here, Allah takhafu wala tahzan. And this is the truth. As a human, all over the world, we cannot offer the remedy, except God is telling that you saying you should not grieve nor be sad. And abshiru, you know this better than me, and there is a much more for you somewhere else. I think at least they should have some hope. They should die with hope. They should not, our patients are dying with serious depression, because many times when we go to the patient, 98% of the time we are talking with the caregivers. We are giving counseling to them rather to the subject. Subject is the patient. He is dying, not the caregivers. So this is another. And second thing is that when I remember that lady, one time there was a young guy, I think he was 24 years old, some strange tumor, and either he will bleed to death, but he's, young guy, smiling, talking, beautiful, handsome. And then I sat with his brother, and their oncologist said nothing from our side to do. And then he went to the liver failure. Honestly, I told him, I said, brother, we are here on the earth for 3.5 minutes. For equal to 1 day of the judgment time period. You ask to Allah now. You ask, whatever your religion, la ikraha fi din. So connect them, because the God gives them hope. We have no hope. If a dying person, whether goes to America, UK, Germany, or here, there is no hope. Ma tashtahi anfusukum walakum fiha ma tadda'un. So when, this tashdid comes, and Salasi Mujarrad changes into Mazid Fi word, it means anything you can imagine, anything you can hope, anything you talk, you will be getting there in paradigm. Whether your children, mother is worried about the children, are you rich, you are leaving behind everything, and you are sad, you know, you should have enjoyed more. So everything you will get there. At least for the dying people, this is the true hope. What we do, you know, alprazolam, this anxiety, I have seen people dying, particularly with the lung issue, and the shortness of breath is a serious problem. Only 2 patients I saw in my practice 7 years, one from the same area and another lady with the breast cancer. Subhanallah, goes to her room and she has a lipstick on. I was terrified myself. What is this smiling face? Someone did her counseling and she was prepared for death. And I think when it happens to me, Dr. Ahmed come to me and tell me these verses, I will be in much better shape than morphine or fentanyl bag. And that lady, we gave minimal anxiolity and she passed away smoothly. And the other case was, but these are the 2 cases I remember in my 7 years. So I think we need to be more charismatic, where there is the strength, we get that, and where we can improve. System-based approach is much better than the physician-based approach. And thank you very much.
Okay, thank you very much, Dr. Muhammad Said. For the next speaker, I have the honor to introduce Dr. Hayat Rabia. She's the former president of GYN. She's the head of the IVF and reproductive endocrinology. She's going to tell us how to preserve the fertility in gynecological cancer patients. Welcome, Dr. Hayat.
Assalamu alaikum. Good afternoon, everybody. I know this is the last lecture. Everybody is tired and waiting for the last lecture to be finished as early as soon. I promise to be precise, but inshallah informative talk. بسم الله الرحمن الرحيم. قال الله تعالى ومن أحياها فكأنما أحيا الناس جميعا. Although the incidence of most gynecologic malignancies peaks substantially after the age of 50 years, a significant number of women encounter with a diagnosis of gynecological cancer during reproductive age. Considering the standard treatment strategy for gynecologic cancer, which involve surgical removal with or without ablative therapies of reproductive tract organs, the importance of preserving a reproductive potential in this patient population has become more evident than ever before. Therefore, providing timely evaluation and treatment for available fertility preservation options without jeopardizing the cancer treatment has become an essential component of a modern oncological care. Actually, in gynecological oncology surgery, there has been a gradual development of fertility-sparing surgery with the aim of preserving the reproductive organs. Survival shouldn't be compromised, and thus, indications are restricted to patients of a young age with a desire to preserve fertility and presenting with a well-differentiated cervical, ovarian, or endometrial low-grade tumor in its early stage or with low malignant potential. We will start with the treatment and therapies and their effect on gonads. Chemotherapy and its gonadotoxic effect. Actually, chemotherapy induces ovarian damage. The gonadotoxic effect of chemotherapy on female gonadal function is dependent on the age of the patient, type of agents, cumulative doses, and the patient's ovarian reserve. The prepubertal ovary is least actually susceptible to the gonadotoxicity, and older women have a higher incidence of complete ovarian failure and permanent infertility in comparison with the younger women, unfortunately. All chemotherapeutic drugs act by interrupting vital cell process and arresting the normal cellular proliferation cycle. As we know, alkylating agents are the most gonadotoxic, and there is a confirmation of ovarian impact on alkylating agents on follicular oocyte depletion and ovarian fibrosis, followed by taxanes, may also contribute to germ cell damage, which acts by arresting the mitosis. How to prevent the gonadotoxicity of chemotherapy? Rendering the ovarian follicular development quiescent by suppressing of gonadotropins has been proposed to protect women from damage by cytotoxic therapy. Concomitant treatment with gonadotropin-releasing hormone agonist is likely to prevent ovarian failure induced by cancer therapy, though the effectiveness of this intervention actually is controversial. Treatment with GnRH agonists should begin at least 1 week before the beginning of chemotherapy, as the initial flare-up effect causes undesirable ovarian stimulation. The application can continue when chemotherapy is given in the form of depot injections, so that the downregulating effect remains for at least 2 weeks after the chemotherapy. In cases of estrogen-sensitive tumors, tamoxifen therapy can be initiated after GnRH treatment. Second therapy is radiotherapy, has ovarian effects and uterine effects. Starting with ovarian effects, ovarian damage can occur due to radiotherapy, while damage occurrence is irrespective of age. But the degree and persistence of the damage is dependent on the dose, the radiation field, and the patient's age. Older women who are at a greater risk of damage. It was reported that women under 40 years of age are less sensitive to radiation. And this is maybe Dr. Salim has more information. I will not interfere with his work. شو تزعل علي. Second, uterine effects. Radiation effect on the uterus and subsequent pregnancy outcome is known. Direct effects on the uterus include irreversible changes in the uterine musculature and blood flow, as well as hormone-resistant endometrial insufficiency. Uterine irradiation is associated with infertility, miscarriages, and intrauterine growth retardation, and actually higher rates of obstetric complications in comparison with the general population. How to prevent the effect of radiation? By ovariopexy or ovarian transposition, which should be considered in each case of a blind pelvic or whole body irradiation where ovarian involvement is unlikely and chemotherapy is not necessary. Cervical cancer. Actually, in cervical cancer, ovarian cancer, endometrial cancer, with a surgical treatment or surgical fertility sparing is managed by GyneOncology, concomitant with us. So after surgical cervical cancer management, like in FIGO stage 1A1, cervical carcinoma can be treated with simple large lobe excision of a transformation zone without further affecting fertility. And so on, so in FIGO stage 1A2, FIGO stage 1B1, I will talk about our part as a reproductive medicine or infertility preservation team. Ovarian stimulation in connection with subsequent cryopreservation of oocyte or embryos before cancer treatment is thus indicated in such cases. However, even if ovarian function is preserved, oocyte or embryos should be cryopreserved. Irradiation of the uterus might cause irreversible damage as well. So, cases of good obstetric outcomes have been reported after fertility preservation among women with a heavily irradiated uterus. In endometrial cancer, patients at high risk of presenting endometrial carcinoma during reproductive age are overweight women and those with a polycystic ovarian syndrome. in endometrial cancer, stage 1A, without infiltration to myometrium and no extrauterine involvement, conservative treatment can be offered to women who wish to maintain fertility. To counsel a woman wishing fertility-sparing treatment options, probably myometrial evaluation by MRI should be performed, actually. In women free of relapse, pregnancy should be achieved within the shortest period of time, and assisted reproductive treatment may have a place in reducing time to conception, thus reducing the time at risk recurrence. Actually, ovarian stimulation in cases of endometrial cancer has been an issue because of the supraphysiological estrogen level attained during hormone treatments required for recovery of oocyte for IVF and possible tumor stimulation. The addition of letrozole to standard gonadotropin protocol has been proposed for ovarian stimulation among women with estrogen-sensitive tumors. The protocols initially developed for women with breast cancer could also be used in a patient with endometrial cancer as well. Ovarian cancer, the surgical management for fertility sparing. As we know, in stage 1A, it will be unilateral salpingo-oophorectomy. Up to now, data are lacking on ovarian cancer relapse rates after gonadotropin stimulation. However, data on women at high risk of ovarian cancer as a result of BRCA mutations are reassuring, and no association between gonadotropic ovarian stimulation and ovarian cancer has been observed in these patients. Ovarian tissue cryopreservation in patients with early ovarian cancer or borderline tumors is highly controversial, but has been described by some authors because of hidden or occult cancer. As autotransplantation of the retrieved ovarian tissue is not visible due to the risk of reintroducing malignant cells, alternatives has been discussed, such as culture and maturation of oocyte gained from the tissue in vitro. A procedure is still under development, which could be used in the future, inshallah. Briefly, on conclusion, types of fertility preservation: gonadotropin releasing hormone agonist, oocyte cryopreservation, embryo cryopreservation, ovarian tissue cryopreservation. Types of fertility preservation as a surgical: the radical trachelectomy procedure in cervical cancer, hormonal treatment of early endometrial cancer, conservative surgical management of early stage epithelial ovarian cancer, and novel assisted reproductive technologies for women with impaired ovarian function after cancer treatment are the options for fertility preservation in young women suffering from gynae cancer. Thank you.
Okay, it's time for questions. Dr. Ahmed has a question.
There is a question for Dr. Mohammed Saeed from Navid Ahmed. Do you think adding palliative care training to medical oncology training will be the problem of, will help the problem of polypharmacy and unnecessary investigation? Terminal cancer patients are subjective to. Thank you.
I think we have to go back to the basis, like family physicians who have been, much higher number across the kingdom. And now we see the new graduates as well. During medical school, they come for 1 month or 2 months, and also during the residency. I think that's the better approach, because until the family physician take the lead, like yesterday in human papilloma virus, unfortunately, Dr. Hani mentioned that most of the physicians, trained family physicians, they do not know how to do the pelvic smear. So I think foundationally, the family physician doctor must have 1 or 2 month rotation with the hospice and palliative care, and it is not a rocket science. They can understand when to take the statins off. The risk of bleeding with the thrombolytics is more than any beneficial. The PPIs, there are not a lot of medicine. So if we want to change the situation towards better outcome across the kingdom, then family physician should be the target. Oncologists are so busy. I see them day and night. I doubt we should push them that they have to see the internal medicine issues too.
Thank you. One question for Dr. Hayat. Thank you very much. I'm talking hypothetically about preserving endometrial tissue or stem cell rule into this.
Stem cell for endometrial?
Yes.
Well, I have no idea. This is not my field. Maybe Dr. Nashmiya can help us.
So, preserving the ligaments with the hand tissue will promote a treatment for those heavy disease.
And I think theoretically, we had patients with the destructed endometrial tissue after iatrogenic surgical resection. Reviewed was the literature, and the data is very weak for this issue. It's still very experimental with no result.
Regarding the ovarian preservation tissue, is it preferred to do cryopreservation or surgical ovarian biopsy? We have to try to spare the ovaries.
For ovarian transposition or ovarian biopsy, in case of radiation, taking the ovary away from the radiation field. Ovarian tissue freezing is different. This is in case patient is in need chemotherapy. So the whole ovary is taken for the wedge biopsy, then a freeze the tissue to be transplanted later.
So the preservation, if a married woman want to preserve fertility.
So embryo freezing is the best for the married woman.
So embryo freezing better than ovarian tissue preservation. Thank you. I have a question, please.
Don't think there is any further questions. I have a question for myself. Dr. Zahra, Justini, if you don't mind, when you see a limitation of providing brachytherapy, as you mentioned, in large residuals, do you believe on applying the stereotactic ablative radiotherapy in that situation? Have you been experienced it before?
So I've shown you the data from the CL meta-analysis, and in a portion of these patients, they've actually used stereotactic radiation therapy. And it does not give you the same outcome at all. So it's discouraged completely in terms of as an alternative to brachytherapy in patients with cervical cancer. In addition, like with the main limitation is with stereotactic, you can never treat it without a target, without a PTV marker. Sorry. And this is something that is almost eliminated with the use of brachytherapy. So you cannot reach the same external, same dose to the target with good kind of preservation of the organs at risk. So this is one factor. The other factor is that given that the radiation deposition is from outside to inside, splashing of the dose will definitely exceed your organs at risk outside. So you're pretty limited in terms of the dose that you can achieve. And we've shown that doses of kind of 90 and 95 does correlate significantly with local control. So this is one aspect. there has been utilization, and I think we've done this on a couple of our patients before we've actually introduced the interstitial needles. There has been an experience from Aarhus and the Denmark. These are kind of also the leaders in the JET-ISRO and Embrace trial, where they've had patients that even if you have intracavitary and interstitial needles that are oblique, you still have disease in the pelvic side wall that is not achievable by brachytherapy. So what they did in this situation is that try to supplement that additional disease in the lateral parametria with stereotactic while the applicator is in situ, and having kind of some dose with the SBFT and the brachytherapy. We've done this on a few patients before where we only had an intracavitary, we still have disease in the parametria, but you have to do the SBFT boost with the applicator. The issue is that you have to actually develop a plan, QA, and deliver it after the applicator is inserted on the same day. So you can imagine how kind of difficult, like this patient would finish probably at 10 or 11 o'clock in the evening. Using it solely is not advisable, but I think there is a lot of work developing in terms of utilizing it in addition to brachytherapy itself. Key element with image-guided adaptive brachytherapy is that one of the recommendations of the JET-ISRO is you try to keep a balance between how much is coming from the intracavitary component and how much is coming from the interstitial. So we try not to add more than 20% of the dose through the interstitial brachytherapy. And the main reason for that is that historically we've had very good results with intracavitary. So there is a lot of emphasis on not to deviate a lot from our classical approach, but to use the kind of interstitial component to optimize your dose and limit dose to organ risk. So I think all these factors speak against utilization of stereotactic as a sole kind of therapy in patients with cervical cancer.
But would you consider it as alternative in scenarios that brachytherapy is not applicable? Alternative, I'm saying. Yeah.
If the patient say inoperable or something like that. Yeah, I would consider it, but this is in a very high risk patient where like I would actually even prefer doing a cervical block with just an intrauterine canal than doing a stereotactic. Yes. I've had patients that have been kind of high risk for surgery, and you can manage with spinal, you can even manage with a cervical block and put an intracavitary applicator. So I will push every other possibility to try to do the brachytherapy before actually resolving to doing stereotactic, because cure rates drop significantly, and that's a very clear.
Thank you so much. Thank you. Thank you.
Doctor, can I just ask you out of interest, does chemotherapy prior to brachytherapy makes a difference in response?
As a new adjuvant, so the volumes can decrease, all right, but do we have data that tells us that these patients have a better survival or progression-free survival or any of that? I don't think so. So this is why there is a lot of controversy. Kind of the JET-ISRO guidelines recommend against actually using chemotherapy if this patient is being treated with a curative intent.
There is one more question.
There is a last question for Dr. Saeed. What is palliative treatment can be given to a woman who refuse to go to higher centers? So
yeah, if you were with us, last 2 days, there is a lot of complexity and the stage of the cancer, where there is a cervical, uterine, ovarian, or breast cancer. So first, I believe if you want to help that patient, then you can facilitate and you can counsel the patient first that why she's refusing to go, because there is a progression-free survival, cancer-free survival, even cure is available depending upon the situation in hand. So the palliative physician should not be just to give, tramadol or constipation medicine and let the patient go. You have to take the interest. Maybe you are a potential vector to save the life of that particular patient because patient may be in curable phase still. This patient which I encountered, mashallah, she survived cancer. But 2 weeks ago, when she came to my clinic, she mentioned again that better I had a cancer than this life. You know what happened? She has diarrhea every 10 minutes when she eats something. Every 10 minutes. She said, I'm sick and tired. I cannot live with this situation. I have to fight with the surgery because they removed 20 centimeter small intestine. They said from our side, she's clear. I have to fight with them to take back and see why she has diarrhea, because she should not have that frequency of diarrhea with just 20 centimeter of small bowel resection. And you know what happened? She went back. And I was worried about my job because I fought with a consultant who's very high-fi. And then, alhamdulillah, Dr. Nakshmiya is there. So it did not approach to that level. But anyway, they did the biopsy of the small intestine. And you know what they found? She has a macrophages and she has a gluten-sensitive enteropathy. And then Saudi Council approved 400 riyal or 300 riyal budget for 1 month, but the diet cost 1,000 riyal, that special diet. And mashallah, this time when she came, she was not crying. At least she's living her life. So the palliative physician can do a lot. Since you don't have too many patient burden, please keep your internal medicine, family medicine skills intact and try to dig in. You are not a pain doctor. You are much more. You are seeing the whole patient. So I hope that will help.
Thank you, Dr. Saeed. So we end our session. Thank you.
Thank you very much. By this, we end our meeting. Thank you for all the speakers, moderators, and for our supporting sponsoring company, AstraZeneca, MSD, and GSK for their support. And of course, special thank for our audience and participants physically and virtually. We have more than 1,000 participants virtually. And I hope that you enjoy this session, you get the benefit, and hopefully it will be affecting your practice in a positive way in your daily practice. And by this way, we will conclude and we hope we'll see you next year meeting. Thank you very much. Enjoy the day.
Thank you all for your attendance. We wish that you enjoyed the meeting and you had the benefit, knowledge, and you enjoyed your time and weekend. Please be informed that you will receive an email which contains a link for the evaluation for this event. You have to respond to that email in order to get your CMEs. After that, we'll be checking your information, the registered information, and we'll be sending it to the authorities to give you the CMEs. If you did not receive any CMEs, it means that you did not attend the whole 2 days, or your information was entered in a wrong way, or you are not eligible for CMEs by the authorities as your actual practice is not related to the topic of this presentation. We would like to encourage you all to follow us on our social media accounts, Facebook, Twitter, Instagram, Telegram, and YouTube. And also don't forget to visit our website, oncologyevents.info, where you can find all the related information and the recorded lectures as well. Thank you all. See you next time. Assalamu alaikum.